He's got his testimony, otherwise we'll have to stop.
Good morning. Welcome to the Health and Human Services Committee on this snowy morning. I'm Senator Henry Ingwerson, and I'll be introducing, let our guests, not our guests, our committee members introduce themselves. I'm going to start over there to my right. Representative Graham.
Yes, good morning, Senator. Thank you so much. Good morning, everyone. I'm Representative Annie Graham. I serve the people of North Yarmouth and the majority of Gray, House District 105. As I was driving up from home, I was reminded that this winter has been a quintessential Maine winter. This is the winters that I remember as a child. I love a new fallen snow. So thank you for being here today.
Hello, good morning. My name is Flavia DeBrito. I represent House District 64, which is part of Waterville and part of Winslow.
Hello, everyone. My name is Sam Zager. I represent District 116, which is part of Portland.
And down.
Good morning, everyone. My name is Ann Fredericks. I represent House District 143. That's down in South Sanford.
Good morning, everyone. My name is Julie McCabe. I represent District 93, part of Lewiston.
Representative Daigle.
Good morning, everyone. I'm Representative Lucian Daigle, and I represent House District 1. And I'm a little late this morning, not because I have to travel from up there.
We came early, that's right. Good morning, I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County and 16 communities in eastern Hancock County, down East Maine. That's still getting snow right now.
And we have Representative Griffin on Zoom.
Good morning, everyone. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levant, and Kudeske.
Good morning and welcome. I'm Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott, where I live, parts of Kittery and South Berwick, and I'm honored to serve as this committee's House Chair.
And I am Senator Henry Ingwerson, representing Senate District 32, the city of Biddeford and the towns of Arundel, Dayton, Hollis, and Lyman. And I'm pleased to be the Senate Chair of this committee and will be presiding over the hearings today. We just had a new member walk in. Will you introduce yourself?
Thank you, Senator. I'm Michael Lemlin. I represent House District 53, which is Chelsea, Randolph, Pittston, and Dresden.
And we have our clerk, Sophie Dubé, and our analyst, Anna Brum, this morning. I'll be presiding over the public hearings today. The purpose of the hearings is to invite testimony from members of the public regarding proposed legislation that is before this committee. On our agenda today, and the following bills will be heard in this order: LD 2177, LD 2131, and LD 2119. This committee will hear testimony from people present and on Zoom who wish to speak for, against, or neither for nor against the bills being heard today. With the leave of the chair, committee members may ask clarifying questions of the person testifying today. The public hearing is just for that. It's for the public. The committee will have time for deliberation and debate at the work session that will be scheduled in the next few weeks. Whether you testify or not, you can submit written testimony to the committee. Please be mindful that the testimony is public and available to all once you present it. The hearing is live streamed and there's a recording of the meeting. Please silence all your electronic devices. If you are on Zoom, please be sure we're able to identify you when we are ready to take testimony from those who will be attending virtually. If you're having any technical difficulties, please call our clerk, Sophie, at 207-287-1317. Some of our committee members serve on other committees this morning, and you may see them come and go. You may also see committee members eating and drinking at the Horseshoe. The public is permitted to drink water, but unfortunately, no food is allowed behind the other side of the Horseshoe. We'll take testimony from people in the room and on Zoom in the following order: those in support of the bill, those opposed, and those neither for nor against. The committee will give members of the public priority when taking testimony. Only the bill sponsor and co-sponsors will be recognized before the public. We do run a 3-minute clock here on testimony. You'll see the clock in the front of the Horseshoe. As you're approaching the 3-minute point, please wrap your testimony up. If you have prepared testimony, please provide 20 copies to our clerk. You may leave those copies at the end of the Horseshoe to our left. please sign in at the podium, and we thank you so much for joining us this morning. With that, we will start hearing on the first bill, LD 2177, an act to update and improve the main care reimbursement system, presented by the bill's sponsor, Representative Drew Gattine.
Thank you. Senator Ingwerson, Representative Meyer, and my colleagues on the HHS committee. I'm Drew Gattine. I represent parts of Saco, Scarborough, and Westbrook in the main house, and I'm here today to present a department bill, LD 2177, an act to update and improve the main care reimbursement system. I think you're going to hear a lot of testimony about whether or not this actually improves it. But I will leave that up to your deliberations. It's kind of a complicated bill in terms of its language, so I'm going to leave it to the department to walk through with you the specifics. But I really wanted to start out by explaining to you why I agreed to present this bill on the department's behalf. And it's a little bit of a lesson in recent history. As you recall, in last year's proposed budget, the administration didn't bring forth initiatives that would fund rate increases related to cost of living adjustments required by the current statute. And there was a lot of discussion about that. In addition to not bringing forward those budget initiatives, there was language proposed by the administration, which was Part UU, if you recall Part UU, that is very similar to the language proposed in this bill. And Part UU would have done a number of things, but in essence, it would have altered the timing of some rate increases related to COLAs. And it had some language that explicitly acknowledged that the rate increases contemplated by the statute are dependent upon appropriation. So when this committee reported back to AFA, they had before it the department's language, and then there was, I guess I'll characterize it as a split in the committee in terms of what it was recommending AFA did. And there were a couple of different alternatives that were proposed by this committee in its report back, neither of which was to simply accept what the department was proposing. And I don't really think either of them was to like wholeheartedly reject what the department was proposing. It's a complicated issue and there are a lot of opinions. So ultimately what we did in the budget was that we funded a partial rate increase to reflect the cost of living adjustment, but we did not move forward with Part UU as proposed by the governor, nor did we include any of the alternative language that was suggested by this committee in the report back. We declined to make any changes in the rate determination process, and I think it might have actually been me, suggested to the department that it might be better if they brought back a clean bill in the next legislature that could be taken up by the policy committee and not debated in the context of the budget. And honestly, as someone who serves on the appropriations committee, but also someone who served 4 years in this committee when we did rate, when the whole subject of rates was done in a very different way and discussed in a very different way, part of that suggestion was based on a respect of the expertise of this committee and all of the knowledge that has been accumulated within this committee on this work. It just seemed that it would better to have a full-blown policy debate in front of this committee as opposed to simply in the context of a report back to AFA. So here we are. And I acknowledge that this is a very tough issue to be dropping in your lap. And I know there are a lot of people in this room behind me whose efforts that I wholeheartedly support, who understandably wish we probably weren't having this discussion today. But I do want to acknowledge that I think this is an important conversation to have. Main care is a cornerstone of our healthcare system, and the work this committee and the department have done over the last few years to rationalize the rate determination process has been sorely needed and was long overdue. And I think it has promise of tremendous success for all Maine people going forward. As a result, the legislature and the department together with people in this room have invested significantly in programs and services while improving value and promoting accountability. And there's a reason why in the rate determination process that we included cost of living adjustments when that reform statute was negotiated. They keep care available, they support workers, they help to keep providers viable, and they promote health communities. But all of those good intentions alone, codified in statute, don't sustain those improvements. I think it's fair to acknowledge that DHHS really can't and shouldn't raise rates without appropriations. And it seems worthwhile to see if we can find a way to have the rate setting statute provide clear guidance to the department about what the expectations are when those funds aren't there for DHHS to do what the statute directs it to do. There are a number of options, and this bill sets forth the department's proposed solution. But, you know, being honest about the reality of funding and reflecting it in statute doesn't weaken the Medicare program. It should make it more sustainable. And I think if the statute ignores budget realities, and we control some of those realities, arguably the statute becomes, I think, politically vulnerable and more easily undone when leadership changes. If it's not sustainable or not well thought out, future governors, future legislators say, like, we just don't want to do this anymore, or we're just going to ignore it and not withstand it. And I think the effort to continue to strengthen this process is worthwhile. So I know there's real concern from providers and advocates about this bill. I know that this committee will take those concerns seriously and weigh carefully the impact of making any changes in the statute. Certainly willing to help this committee in any way as you think this through, and try to answer any technical questions about the bill, although I think that might be better left to the department. So thank you for having me here today.
Thank you for bringing this bill to us this morning.
Thank you.
Appreciate it. Any questions for Representative McKean? Yes.
Thank you so much
Yeah.
for being here. And you're right. I mean, you lay this out as it's very, I guess where I'm at is about the COLAs.
Mm-hmm.
You know, and everywhere we turn around, we have COLAs, you know, even in our Social Security and everything like that. I mean, if we have that included in the rate case, why do we need to put it in the statute that we're not going to cover COLAs?
Well, I don't think that this statute says we're not going to cover COLAs.
Okay.
I think what this statute, I think the position that the department is put in, that we're put in, that the providers are put in, is what happens when you have a statute that says you're going to do COLAs, but there isn't necessarily clearly identified the money that's going to fund those COLAs. Do we want the department to do the rate increases knowing that that the money isn't there? Do we want the department to have the ability to do the best that it can with the money that is there, which might not fully fund? I think at least my intent is to preserve the requirements and stronger than the desire, the requirement that there be COLAs, but also acknowledge the fact that the budgetary situation of the state, the revenue situation of the state will change year after year. And it isn't necessarily fair to the providers to be guessing what the department is going to do when there's a statute that says on January 1st, there's going to be an increase in rates based on inflation. No one knows what that's going to be in January. You know, there hasn't necessarily been money appropriated. You know, what are we going to tell the department to do? To put those rates in place or not put those rates in place? I think it puts the providers in a very tough position, and some providers may make different decisions about how they're going to respond to that. And again, I just think we need to consider this effort to be something that we're going to have to continually look at and try to improve.
Oh,
Yeah.
And I agree with you totally on that. But I think about our unions, you know, and they have their union contracts, and in those contracts, they specifically say, you know, that they would get their COLAs, and usually it ties it into a federal number, you know, and I mean, is that something that we might consider doing as far as the statute goes?
Well, I do think that the COLAs are tied to federal, again, the department can talk about the mechanics of how the COLAs determined. I think it is tied to cost of, to the CPI.
Okay.
I think that's where, it all sort of drifts down to eventually.
Okay. We'll take
Pretty
it.
sure.
Yeah, okay. We'll talk more with them.
That's a great question, Senator.
Thank you.
Any further questions? Thank you, Representative Katina.
Thank you.
Yeah. And do we have a representative from the department here to share this with us? Thank you so much.
Still getting a copy of the long testimony.
Walk us through this.
Yes, good morning.
And just for the public, before you start, department testimony is not timed, so. Sorry, I interrupted you.
Yeah, no, I'm going to also be referencing a one pager, and I do have extra copies for the public as well. Maybe not enough for everyone in the room, but I'm going to put them here. And when you hear me start to talk about that, if you're interested in a copy, it's right here. Senator. All right. Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Olivia Alford. I serve as the Deputy Director of Policy and Programs of the Office of Maine Care Services in Maine DHHS. Our apologies from the Director. Michelle Probert is on a plane right now. Otherwise, she would be here representing this very important bill. I am here today to testify in support of LD 2177, an act to update and improve the Maine Care reimbursement system. I also want to extend my gratitude to Representative Gatine for providing the department the opportunity to bring this important conversation to the committee today. Maine's rate reform statute, as we call 223173J, passed unanimously in 2022 and ensures that Maine Care reimbursement is developed and updated through a systematic approach that is transparent and includes public input, is data-driven and equitable across provider types, and supports access to services for Maine Care members and value for the Maine Care taxpayers. Together, we have made great strides in these efforts. As of early January 2026, rate reform initiatives have completed or are in progress for 48 sections of policy or service areas. This system has been a monumental shift for the Maine Care program, and we thank everyone involved, from providers who have submitted relevant cost data, to vendors that support our more complicated projects, to the legislature for acknowledging time and again that effective and fair reimbursement systems require the ability to plan and engage substantively with partners and must be informed by meaningful data and analysis. Now that we have a few years of this work and additional learnings under our belt, we are glad to present some amendments through this bill that are critical to strengthening the legacy of this shared work. These amendments reflect our shared responsibility to support long-term sustainability and strong fiscal stewardship of the Maine Care program. This proposal has 4 main goals for rate setting and rulemaking. The first goal is to protect the ongoing sustainability of this process and enshrine the roles of both the executive and the legislative branch that must be completed to make this system work. Many states' similar efforts at Medicaid rate reform, institutionalizing review and adjustment, have been dismantled in times of economic and budget challenges. This bill would clarify that rate adjustments, including cost of living adjustments, are subject to appropriation so that the state cannot be required to implement increases without sufficient funds. Proposed provisions include a prioritization framework to guide implementation of rate changes when sufficient funding is not available. The framework considers rate adjustments from rate determinations for services that have yet to have a reimbursement established through 3173J, and prioritizes services for which there is evidence of issues related to member access. This bill also clarifies that the use of the Maine Care Stabilization Fund for reimbursement adjustments is not a permanent solution, and sustainable adjustments require ongoing appropriations. The second goal is to address budgetary inefficiency and confusion specifically related to COLAs. Before explaining these items, I want to say very clearly that this bill does not change the requirement that rates must support 125% of the minimum wage for essential health workers. This is codified in MRSA 7402. This bill does seek to adjust the timing of when COLAs that are tied to minimum wage increases are applied in order to ensure the state has the required time to conduct appropriate budget planning and to operationalize the rate changes. Under this LD, the COLA adjustment will be applied to the reimbursement rate 6 to 12 months after the minimum wage increase goes into effect. I have a visual for this if we want to go there later. This lag allows for the state budget process to consider the budgetary impact related to the released minimum wage increases. Upon legislative appropriation of necessary funds, the COLAs will be applied according to the service's July or January COLA schedule. This process change removes the impossible task of accurately predicting minimum wage increases and the subsequent need to make administratively burdensome retroactive COLA updates. And if needed, the department seeks to work with this committee to address any conflicting or confusing statutory language related to this intent. The first two goals seek to directly address the reality of the state budget making process. MaineCare cannot pay out funds it does not have. So by default, making rate adjustments subject to appropriations, allowing for the increases proportional to available funding, and arranging COLA schedules to facilitate budget planning and reduce rework. This helps set realistic expectations and that shared responsibility between the executive and legislative branches to identify this funding. As you may recall, the concepts of an allowance for proportional increases and the need for a delay between the minimum wage increase and implementation of related rate adjustments are shared with LD 1932, an act to support essential support workers and enhance workforce development, as presented to the committee a few weeks ago. The third goal is to ensure that MaineCare is more efficiently able to implement recommended rate changes and navigate this statute, 3173J. Specifically, this LD allows more flexibility for the rulemaking process by explicitly permitting incorporation by reference, a legal term, of sources in addition to those currently permitted under the Administrative Procedure Act. It amends several definitions to support clarity of rule reviews and proposes that rate changes required by the federal government due to emergency or extraordinary circumstances, or rate reductions required by the legislature in response to projected MaineCare budget shortfalls are not subject to the process outlined in 3173J. Lastly, there are several clarifications in this bill which are important to ensure statutory language is streamlined, accurate, and up to date, and to facilitate efficient related rulemakings going forward. These changes include language to reflect nursing facility rate reforms that are now in place, and consolidation of MaineCare reimbursement related statute under 3173J. This bill also updates or removes one of the two Department of Professional and Financial Regulation participants from the technical advisory panel based on feedback from that department, and changes the meeting frequency from 2 times per year to once per year. We know that MaineCare services are in many ways the lifeblood of our healthcare system, and that making significant changes in the rates themselves or the system that governs them can create skepticism and anxiety. We would all like to do our work in a vacuum of the financial realities, but as we've seen over the last few years, systems will always be limited by reality and practicality. Subjecting COLAs and increases to appropriations adds another step in the process, but that step is already there. Reflecting in this statute sets the clear expectation that the executive and legislative branches will work together, the bureaucracy and the purse strings, to determine what is possible within the principle that cost of living adjustments are good government and keep systems healthy and growing. There is an alternative here, that someday there are people in both branches who do not see the value in keeping reimbursements as close to pace as possible. By not making this statute flexible for the realities of a state budget, we make the whole system much more vulnerable to repeal. We need to fix the current conflicts now so that rate reform will be sustained in the long term into the future and ensure that transparent and data-driven processes is as much an institution as the program itself. Thank you for your time and attention. I'd be happy to answer questions you have and make myself available to the work session. And then at this point, just again, referencing the one pager,
Oh, yeah.
additionally, a little more condensed.
That would be helpful to have.
You should have a copy. Yes.
Oh, okay. Oh, yeah. Thank you. Yes. Questions? Representative Lemelin.
I have a lot of questions with this, but I'll just start with this. We have the money. So the money isn't the problem. So the problem is, what are we putting as a priority as far as your department and AFA above the COLAs? So what I would like for the work session is not a vague answer, but an intricate detail of what you chose to pay that was a higher priority than the COLAs that we promised these people. So that's what I would like. And my question is, why are you stating here, I don't understand the statement that this bill seeks to adjust the timing of when COLAs that are tied to the minimum wage increases are applied in order to ensure the state has the required time to conduct appropriate budget planning and to operationalize the rate changes.
Yeah.
I don't get that at all, because the state already does this. The governor's office comes up with a budget, and when she comes up with that budget, her department should already implement that, because they should already be talking to you. Is that not correct?
Well, I'm not going to speak for the governor, but I will hand out this visual. This might help. So regarding the timing of COLAs and how it would be able, how will you be able to effectively budget into proactively what that amount of money is needed to reflect those minimum wage increases, those COLAs? There is a challenge with the timing of when information is released. At the end of each calendar year, towards the end of each calendar year, the Maine Department of Labor releases the minimum wage that will be effective that next January. We need to see if that, by the time that's happened, the department has already crafted a budget for that year. In order for us to be able to use the value that was released at the end of the previous calendar year to inform future budget planning, we need to basically have that lag of 6 to 12 months to say, okay, this value X was released January 1, 2026. We are going to incorporate that into what we request for the upcoming state fiscal year. And we're going to apply that value X into COLAs that are effective July of 2026 in this example, or January of 2027 in this example. Right now, the way that we have to do it is we don't have the information available to us to know what the COLA is going to be in time to request the appropriate amount of funding. We're guessing at the appropriate amount of funding need to request a COLA to be effective the same time that minimum wage was released. So we need that extra 6 to 12 months to be able to say effectively, we know how much this will cost us and put it into that budget.
Well, we did this a long time ago. I mean, the rate reform statute was passed unanimously in 2022. We passed these COLAs quite a while ago. I mean, more than 6 to 12 months ago. So it could be in the budget already. So I'm not understanding why it's not. And the governor gave, what, $100 million in the supplemental budget. Top priority, why isn't it the COLAs? Why is it something else? And I would like to know for the work session, what those decisions were and why, please. Thank you.
Yes, Senator Moore.
This is probably a little bit different than this, but right now the plan is every 5 years. We try to rotate and look at the different rates. Is there any conversation about reducing that down to 3 maybe? I know it's a lot of work, but I think 3 would be a little bit more realistic as to really what's going on, as far as the rate reimbursement.
Yeah, we haven't had conversation about reducing the cycle of doing another rate determination to every 5 years. I will say I feel like if once we get past this first 5 years, where I can say it's been a tremendous amount of work to try to get through all main care coverage services within a 5-year period, we would like to think that we are at a better baseline where with this statute still in existence, that we have a much stronger foundation going into future rate determinations. I believe the statute says up to 5 years. So I don't believe it prohibits doing things more quickly than every 5 years, but I can say we haven't discussed reducing that time frame, but open to that conversation.
Thank you.
Again, not really feasible this
Yeah.
first 5 years.
Yeah, because we haven't gotten to
right.
numbers. Just a follow-up question. I know we're saying complete or in progress for 48 sections. Do we know how many more we have left?
I can get that number to you. I don't have the top of my head.
Just curious, it'd be good to know. Thank you.
Any further questions for the department at this point? Yes, Representative Fredericks.
Thank you, Mr. Chair. Just trying to understand the rate setting process.
Mhm.
I understand the schedule. I understand that the federal government does rate setting every 3 years. And my question is, does the department use the federal rates as a starting board and go up and down from that, or it's nullified? We don't even use the federal rates at all.
When you say federal rates, do you mean the rates set by the Medicare program?
Yes.
We do benchmark to the Medicare program whenever possible. It's a really efficient way to do rate setting. There are not appropriate Medicare benchmarks for every service, but that is one of the steps we do take during the rate determination process, is to assess whether there is a Medicare service that we could base our rates off of. When there is, it's a priority to look there. Sometimes there are differences between the way that what our services are that makes that not possible, or that Medicare doesn't price the service.
Thank you. Last follow-up question,
Yes,
if I
go
may.
ahead.
Thank you, Mr. Chair. Do the federal rates adjust for cost of living adjustments?
Some areas do. It really varies. Every year, there's an intensive rate setting process at the federal level where certain assumptions are reevaluated. I can't say that they characterize them all as cost of living adjustments or inflationary adjustments, but there is a review process, and I can get back to you more specifically on what that schedule is for different services.
Thank you.
Further questions? Seeing none, thank you. Testimony. Testimony in support at this point from folks in the audience. 177, okay, we got against. All right. Testimony in opposition.
Is there a pen with them?
There are multiple pens here. We're
Good.
well
Thank you.
Usually
prepared.
they grow feet, so that's why.
If they're really good. All right, I'll fill that out in a second. Good morning, Madam Chair, Mr. Chair, members of the committee. My name is Todd Goodwin. I am the CEO of an organization called John F. Murphy Homes. We are a disability provider based in Auburn. Our services stretch up around these parts, Augusta area, down to Saco, over to Brunswick, and several places in between. I'm here in opposition to this bill. I want to open with a quote here. Maybe some of you remember this. Quote, "This legislation creates a strong, sustainable framework that will endure well into the future for Maine's healthcare coverage system that supports more than 380,000 residents." That was DHS Commissioner Lambrou back in 2022. And to borrow Representative Gattin's words from just a few moments ago, here we are. Here we are contemplating undoing so many key provisions in the rate reform statute. Like many people here, I have stood behind this podium in this room countless times for a decade or more, begging for an injection of stability, transparency, predictability into the rate setting system. When that statute passed a few years back, I had optimism I haven't had for a long time. We employ about 900 people. I said to our people, there is reason for optimism. I get the complexities. I understand it. I don't claim to be an expert in, managing our state's main care program. But what I can tell you is that placing contingencies on funding, whether it's COLAs, the schedule of rate adjustments, indexing of all rates, that one was curious to me. Why would you not put everything there? But placing contingencies on that, our people lose out. And I'm not being hyperbolic. The data's there. Look at the record, right? So I would just urge you to reject the proposed language in this bill that seeks to place contingencies and if this and if that on the COLAs, on the schedule of rate adjustments, and on the publishing of rates across all programs. Thank you very much.
Thank you for your testimony, Todd. Do we have any questions? Yes, Representative Frederick.
Thank you, Mr. Chair. Thank you for being here today. So back to you using the terms, I'm not going to be hyperbolic, but it hurts us. Can you describe, what do you mean by that?
Well, yeah, thank you for the question. I'll try to be brief. It's hard to answer that question and be brief. But if you look at our system over the last decade, it's actually a little bit longer, okay? You're going to see all kinds of variations in where the rates were, right? You're going to see long lags of doing proper reviews of the rates, right? The other thing you're going to see is you're going to see a lot of program closures, right? If you look at this trajectory, you all have heard ad nauseum, I'm sure, about the workforce crisis. All of this stuff is directly related to the stuff that was in that rate reform statute. That's why we were so excited about it. Finally, some meaningful steps. When the workforce stuff, we don't have the people there, then who suffers with that? The people we serve, right? Because remember, the department gives us certain obligations under the main care section having to do with settings, rules, stuff. Everybody needs to get out. Everybody needs to do all these wonderful things. You can only do so much when you have limited resources, right? And there is a direct connection between the funding, the unpredictability of the funding in our services and what we're seeing on the ground and our ability to make sure that we are providing services that go beyond basic health and safety. Does that answer your question? Thank you.
Further questions? Seeing none. Thank you.
Thank you very much.
Further testimony in opposition?
Good morning, everyone. Senator Ingerson, Representative Meyer, and members of the committee. I appreciate the opportunity to share my thoughts related to this bill. My name is Michael Tyler. I'm the managing partner for the Sandy River Company. I'm a senior analyst for North Country Associates. I'm the chairman of the board for the Maine Healthcare Association and a member of the state Workforce Board. I've been involved with long-term care provision for over 40 years as an owner, operator, developer, and consultant on facilities in every county in the state of Maine. I'm testifying today in strong opposition to LD 2177 because it provides unfettered authority to DHS to withhold reduced payments to nursing homes while the responsibility to care for Maine seniors remains, regardless of whether facilities are paid. This is too much. This is a bad concept. It is bad policy. I think most everyone here knows that caring for Maine's seniors and most frail is a budget priority. There's no doubt about that. The changes that are being proposed to the new payment system and rate setting that was put in place are not a move forward. It is a move backwards. The three major things that I want to focus on, and it's in my testimonies and other will talk about it, making COLAs optional is a bad idea. We still have to care for folks. We still have to hire employees. Without cost of living adjustments, it is impossible to continue the same level of quality and care for folks. Eliminating recurring rebasing, another really bad idea. Eliminating and reducing informal notices and comment periods in rulemaking, that's not what this committee even does. Making reimbursement adjustments that are subject to available appropriation. That's what's not being said is our care optional? Is the care we have to provide also based on appropriation? That is not good policy. That is not what Maine is about. I could go on. I have 3 minutes. My time is rapidly going away. I would encourage you to really look at this with a jaundiced eye. This is bad policy. And it's frankly disturbing after we did such a great job with this new payment system of collaborating, finding solutions, disagreeing, coming to the middle ground. It is the one thing that I think I've been involved with, if I may to finish, for the last 40 years that was done exceptionally well. It is something that was to be proud of. This takes us backwards.
Thank you.
If folks have questions, I'd be more than glad to try to answer them.
Thank you, Mr. Tyler. We have any questions for Mr. Tyler? Seeing none. Further testimony in opposition.
Welcome.
Good morning. Senator Ingerson, Representative Meyer, members of the Health and Human Services Committee, thank you for the opportunity to come before you today on the snowy morning. My name is Laura Cordes. I'm the Executive Director of the Maine Association for Community Service Providers. I know you're familiar with our association. You have my written testimony. I do stand in opposition on behalf of our 100 members and the 2,000 children, 5,000 adults, an estimated workforce of 9,000 direct service professionals who do the work every day to focus on helping people with disabilities to live meaningful lives in their communities. You know, we are in opposition to the bill, but not to this system that we all worked so hard to set up. I really appreciate Representative Gattine's remarks this morning about the importance of this conversation and really providing the context of which so many of us in this room have lived over the last several years. I can't also not comment on the hard work that the department has done. I sit on the MAC, on the Rates System Subcommittee. I've seen how much work they have done, both in the first 2 years of COLA implementations, as well as the 48 service systems rate determinations that have been done. That said, the language in this bill as written allows cost of living adjustments to be reduced or eliminated based on available funding, makes reimbursement explicitly subject to the availability of appropriation, permits rate adjustments to occur without rulemaking, reducing legislative and public oversight, and further weakens transparency by changing what rate information must be publicly available to what may be available. And I have those referenced in my testimony. Taken together, the provisions shift discretion entirely to the department and the executive branch while weakening legislative oversight and leaving both legislators and providers without the information needed to budget and plan responsibly or assess whether statutory commitments are being met. There is nothing in this bill or rate setting system that compels the department to expressly ask the legislature via proposed biennial or supplemental budget for the dollars that are needed to hold up this system, both rates and COLAs. So far from safeguarding or sustaining the main care rate setting system, this bill would codify uncertainty and undermine the transparency and predictability that rate reform was designed to provide. I know my time is limited. I want to make one comment about the IDD services and folks that are providing home and community-based services to adults with disabilities. We've waited patiently and in good faith, yet today our uncertainty is really deepening. The administration has not proposed funding an annual COLA in the FY27 supplemental budget, nor to the best of our knowledge has it proposed funding to implement the new HCBS service rates that have been determined, started in 2023, and are sitting on the table. And I just have to say I'm certainly appreciative of the work that has been done. Our rate setting process is only as strong as the funding and transparency and predictability that supports it. I'm happy to work with the department, any of you all, to answer questions ahead of the work session. Thank you.
Thank you. Questions for Ms. Cordes? Yes.
Thank you, Madam Chair. First, applause to you. Thank you for emphasizing that the information in the bill would be changing from a must be publicly accessible to a may be accessible. Thank you for emphasizing that. My question is, you mentioned that you're a member of the MAC, the Main Care Advisory Committee. Yes. And my question is, relative to the schedule of rate setting, which you contribute to, you play a role in that. When a service is asking to be changed in priority, elevated in priority, does it go back to the MAC or does the department make that decision?
No, the department makes that decision on an annual basis. I will add, however, that process has been very transparent in terms of the calendar year schedule that's put forward. So, the public has and stakeholders have the opportunity to weigh into that. The department does come to the rate system subcommittee to talk about that schedule. Earlier, it was commented, hey, could we do this in 3 years? I certainly can't speak for the department, but it takes an extensive amount of time. Certainly, I would imagine at this first pass in this first 5-year cycle to do that. So some of the concerns and comments are about, hey, something was put on the schedule a couple years ago and we haven't seen progress. But that piece of the actual scheduling, is very transparent.
Any other questions? Seeing none. Thank you, Laura.
Thank you.
Testimony in opposition here in the room.
Good morning, and welcome. My name is Betsy Sweet, and I'm here on behalf of Behavioral Health Community Collaborative. Again, and you've heard a lot. You're getting our testimony in writing. I just want to add a few couple of things that we're very concerned. We too have been working hard with the department. We appreciate everything this committee, the Appropriations Committee, the legislature has done. It is miles beyond where we started. So thank you so much for that. And this isn't, we offer this in the spirit of cooperation and wanting to get to the right answer here. So just want to say that. And I think one of the things that we really appreciate is this effort to try and make sure in times of uncertainty to try and make it as certain as possible. And that's what this bill is trying to do. We agree that we need to do that. I think the big question is, where is the locus of control for bearing that uncertainty? This bill shifts it very much to providers so that we don't know. Is there going to be a COLA? Is there not going to be a COLA? Can we wait 12 months before we see? We already know, for example, in Portland, there's going to be an increase in minimum wage. We know that a year and a half ahead of time. So it's really, and what I would like to say is, I would like that control of that uncertainty to sit with the legislature. Because you are whom we can count on to know and to understand. And again, it takes more time, but you're the ones that you can look, you know what's happening in your communities. You're right there on the ground in cooperation with all of us. So that's the context of my remarks. And I just want to say a couple of things that have not been mentioned yet. One is there's a concern, this prioritizes benchmarking to Medicare. That is not always reflective of the cost of living of doing business in Maine, in particular in behavioral health services. So that's a concern. Also, the COLA process focuses on direct care costs, staffing costs, and does not look at all the other associated costs, administrative support, compliance, quality assurance, all of that. And then the other one that's really important to us is that this bill prioritizes access, and that's a great thing. We want to prioritize access, but it does it kind of in a reverse. I think it ends up doing it in reverse incentive. So if you are providing access by trying to do things in your own organization to keep that access, then you are penalized and the money goes to people who aren't providing access, right? So you see those who are trying to like hold on and do it. So I just want us to think about that language in particular. So I just want to say those few things, and we encourage us to pursue the intent of this bill, but to really be very careful because we don't know what's going to happen now in November. And we also appreciate that this is in anticipation of the kind of Medicaid cuts that we're going to see in November. After when the new ones, we understand that 100%. And so it's like, how do we balance all those things? We think this pendulum swings too far in the favor of letting the department decide things, much to the instability of the providers who are trying to provide the services every day. I'm happy to answer the questions and look forward to working with all of you in the department to figure this out.
Questions? Yes.
Thank you, Madam Chair. Thank you, Ms. Sweet, for being here.
Welcome
Nice-
to the committee.
Thank
Nice
you
to see
very-
you again.
Thank you very much. So excellent points that you made, and one specifically you emphasized about COLAs not to be kind of limited, that they assist with direct care providers, but not all other infrastructure. So my question for you is, are you in support of an inflationary market adjustment, a new term? Is that so that we incorporate all of it, but just don't hold to a COLA?
I mean, however, I think we need to look at, I don't have an exact answer yet, but I'm happy to try and look for one because I just think that it's also true in the rate reforms. Some of the questions that we've had about, one of the challenges we've had in rate reform is it often doesn't take into account other associated costs. It doesn't look at direct costs, some of the indirect costs that we have. Indirect costs. So yeah, I think we can look at that and just how do we, as people have said before me, we all know everything's going up, right? And so if we only look at one thing that's going up, and again, you all have done such an amazing job at helping us with direct care workers, and that's key and critical. And there's all these other things that go with it that have not gotten that same look.
Representative Zager.
Thank you, Madam Chair. Good to see you. Specifically about the lag.
Mhm.
What are your thoughts about that?
It's hard because I understand the lag on the department's end, but there's no lag in what we have to pay, the providers have to pay. So the costs have already gone up. And so if we say wait 12 months until we can sort of figure it out, who absorbs that time? Workers, the lot. And I'm just using the Portland minimum wage as an example. We don't have 12, we have to start paying it right away. So we don't have 12 months. So it's just like, and again, I wish I had an easy thing to say, let's do it like this, but I think that we have to, if there's a way to figure out a provision that allows, for example, an automatic adjuster to go in and then we can readjust it. I don't know, but I think that it really is who's going to hold the bag. Yeah.
What if it were retroactive? If it weren't determined until the information was known, but then retroactively reimburse in a way what the behavioral health provider
That is a
said.
huge help. And that's what's happened with the COLAs here. And that is a huge help. And it puts smaller agencies at a big disadvantage. There are some agencies that can float that. There are many, particularly in direct care for IDD and for, home care, especially with kids with behavioral health getting home services. A lot of those agencies don't have that kind of float.
Yeah, noted. Thank you.
I just also want to say to thank you for mentioning some of the federal cuts that are coming. There were comments made about budget priorities here in the state, and I think it's important to note what the budget priorities have been at the federal level and the impact on the funds that are coming to Maine or not coming to Maine, and the uncertainty that builds into our system of care delivery.
100%. I think that's going to be, we're all going to find things. And I think in terms of setting priority, that's one of the other things I didn't mention in the COLA conversation is the other thing is not defined in the bill is in what pot of money are we looking at? So it may be that things are so bad with what's coming down the pike from the federal government that we may have to say, we're not going to, I'll use a terrible example, but we can't fix that road now because people are starving. That's
Yes.
I know that's very dramatic, but so it may be that we can't look just within the allocated DHHS budget because the cuts are so dramatic and terrible that we are anticipating. And it's really people in our communities that will be dying. So we may have to look at some other bucket of money that isn't traditionally looked at when we look at, do we have the money for COLAs or other things?
Thank you.
Thank you so much.
Testimony in opposition here in the room. Morning.
Good morning, Senator Ingerson, Representative Meyer, members of the committee. My name is Ann Robinson. I'm a lawyer with Pierce Atwood, and I'm here today on behalf of Spectrum Healthcare Partners, which is an independent multi-specialty physician practice group here in Maine. I'll try not to be redundant, and I know my time is limited. I just want to step back and say that, prior to the enactment of the rate setting process that we have, providers, had to go to the legislature, right? And, sort of petition, if you will, for a rate increase. And so the thought was that rather than this sort of ad hoc process by which one provider after the other would come forward, that there'd be a more systematic process with some predictability and regularity in terms of the cycle, right? And so this system was established. One of so Spectrum was among the many providers who participated in that legislative discussion and was part of the group of providers that the department conferred with in the process of the enactment of that legislation. And one of the hallmarks or overriding concerns and among the providers was the need to be able to participate in the rulemaking process and the rate making process, consistent with the process of the Administrative Procedures Act and the opportunity to be heard and have comment. And so one of our chief concerns with this bill is that the approach taken here now would substantially limit or impede the ability of providers to have a voice and to be heard in the actual development of the rate itself. Secondly, and these are points that I recognize have been made by the previous speakers, is the decision to take the approach to addressing the circumstance of a Medicaid budget or a budget shortfall by conferring on the department the ability in the first instance unilaterally to just decide not to implement a rate or a rate increase, rather than that being a decision and a discussion that would otherwise occur between the department and the Appropriations Committee and this committee, ultimately, the full legislature to decide how to deal with that circumstance and to take into account, other possible solutions and all of the sort of competing interests and concerns that you have in the circumstance of a budget shortfall. So we think that ironically, what this bill does is to, in many ways, eliminate or deprioritize the sort of the voice of the legislature in that process, let alone the ability, again, for providers to have a meaningful opportunity to comment. And I would just close by urging this committee to allow sufficient time between now and the work session for the kinds of conversations and discussions to occur with the department that occurred in the enactment of the original program, or in the alternative, to vote on not to pass and have those discussions occur between now and the next legislative biennium. I appreciate your time. Happy to answer questions, and I'll be here at the
Ms.
work session.
Robinson.
Thank you.
Questions from the committee? Yes, Representative Zager.
Madam Chair, forgive me, I can't find the testimonies. Maybe you've written it.
I have
written it,
not
but-
yet. I'd be
Oh,
happy
okay.
to supplement it, though.
Can you just then share with us, spectrum, it's orthopedics, it's anesthesia, it's radiology. Can you just describe the scope of your
Sure.
client?
I'd be happy to. Actually, it is no longer orthopedics, so, but anesthesiology, radiology, pathology, vascular intervention, radiology, oncology, pain management.
Okay, thank you.
Orthopedics at one time was part of it, so I understand why you asked that, but it is no longer.
Okay, thank you.
Thank you. Thank you very much.
Testimony in opposition in the room.
Good morning, Senator Ingerson, Representative Meyer, and esteemed members of the Health and Human Services Committee. My name is Mary Jane McDade, CEO of North Country Associates. We represent 20 facilities across Maine. We employ roughly 1,100 employees and care for 909 residents. I'm testifying this morning in opposition of LD 2177. My concerns are that this bill would allow the department to take actions that would reduce the predictability and stability of Maine care reimbursement. LD 2177 makes adjustments to nursing home reimbursement. Specifically in Section 1 of the bill, it seeks to eliminate the 2-year rebasing for nursing facility rates. This is problematic because when nursing home main care rates are not rebased regularly, the gap between cost of care and reimbursement widens and makes it very challenging for nursing homes to continue to operate. Section 3 of the bill is especially concerning. It proposes to significant changes to the reform statute that Olivia spoke about, 3173J, that would expand DHHS ability to adjust rates without rulemaking or informal notice and comment. Therefore, provider input would be eliminated. This would create unprecedented latitude to change payment rates for main care covered services without public comment opportunity and without any clearly defined opportunity for appeal or recourse. In addition to not requiring public comment on rate change, there is language that would create a blanket exemption from the entire rate reform statute for changes to rates required, and I quote, by the federal government to assist with emergency or extraordinary circumstances or rate reductions required by the legislature for the purpose of responding to projected main care budget shortfalls. This is also troubling. This could lead to reductions in provider reimbursements, being the first line of response to resolving budget shortfalls. One of the most important components of rate reform was recognizing that COLA adjustments are a standard part of updating rates. 2177 gives the department widespread authority to reduce reimbursement amounts, specified cost of living adjustment amounts in proportion to available funding. including elimination of scheduled adjustment if funding is unavailable. This creates, as we've heard, uncertainty for main care providers. In light of the historic workforce shortages, main care providers and large number of nursing home and residential care facility closures across Maine, this is deeply concerning bill language. Having been part of several closures throughout Maine, I would urge you to do anything you can to try to prevent that from happening. I urge the committee to vote no on LD 2177. I appreciate your time and attention and happy to answer any questions.
Thanks for being here. Yes, Senator.
Thank you. I'll be honest with you, I have not gone word for word in the bill itself. Am I also understanding that this is repealing that $10,000 that we can use for medical director that is as part of the nursing home?
That I am not sure of.
Okay.
Does any of my colleagues? It does, yes.
Yeah, okay. Which would that be a problem for the nursing homes? I assume it would.
Right.
Yeah.
We all are required to have a medical director, so that would be problematic.
Well, and 10,000 isn't even enough as it
Oh,
is.
no, it is not. Not in this day and age.
No.
No.
Thank you. Thank you.
You're welcome.
Seeing no other questions.
Thank
Thanks
you.
for being here. Anyone else in the room with testimony? Yeah. Hi. Anything written, Jennifer?
I apologize. I submitted written testimony and
Thank
then
you.
just wanted to share. Good morning, Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. My name is Jennifer Putnam. I'm the CEO of Waypoint Maine in Southern and Western Maine. And I just wanted to share how Section 3 of LD 2177 would affect our ability to plan and stabilize services and continue to support the individuals and families that rely on us every day. We're located across Southern and in the Western foothills and provide a wide range of services, including pre-K through grade 5, special purpose preschool, case management and care coordination for children and adults, day programs, and a wide variety of residential services and remote support. We have over 350 employees, and we've supported thousands of adults, children, and families over the last 60 years. Every day, due to staffing shortages, particularly in our group homes, I'm faced with decisions about paying overtime, hiring costly temp staffing, and how to remain competitive as the state's minimum wage continues to rise and undercut that. In 2022, we were really excited and relieved to learn of the bipartisan rate-setting framework. We understood that it would provide us a clear picture about how to plan our budgets and plan for wage adjustments to our direct care staff. And the predictability of the COLAs tied to minimum wage meant, just like any other business, we were going to be able to plan ahead. The framework also meant that we all shared a common goal, one that's also required by the federal Medicaid rules, which is to ensure that rates are adequate to meet the service needs of people with IDD across the state. By changing the language to tie reimbursement adjustments based on appropriations, Section 3 walks this back. It walks back that commitment, and we're very concerned about that. At our agency, we've long since squeezed out all of the efficiencies we can think of from a business standpoint. We have low admin costs. We own all our group homes. 2 years ago, we created a premium pay model that would provide premium wage adjustments for people working weekends, longer shifts, all of those things. Those have been successful, but now we're losing ground. If we can't be assured that as minimum wage rises, so will rates, then we can't increase the wages of our direct care workers. At our agency, we know how important this is. We want to stay competitive. And more than that, we want to make sure that we're providing high quality care and not just your basic care to people who deserve it. We know it's the right thing to do, and so we continue to raise wages whether or not we have increases that are timely. However, that has come at a cost to our agency's bottom line. We're halfway through our fiscal year. We're $800,000 in the red on our group homes alone. It's a staggering loss, and our agency's ability and others to continue providing those critical services are going to be further compromised. So we ask you to oppose LD 2177. I see my time is up.
Thank you. Questions? Yes.
Thank you, Madam Chair. Thank you, Jennifer. Could you tell me again, who you represent and do you have written testimony, please?
I submitted written testimony online. I'm sorry, so it's there.
That's
And I represent Waypoint, Maine. We used to be known as Waban.
Okay.
And became Waypoint.
All right, thank you.
Thanks.
Seeing no other questions, thanks for being here.
Thank you.
Anyone else in the room with testimony in opposition?
Good morning.
Morning.
My name's Jess Fay, and I am the Policy and Advocacy Director for the Maine Council on Aging. Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. I am here to testify in opposition to LD 2177. As Representative Gatine mentioned, the department and this committee have invested considerable effort in rate reform designed to create a predictable and stable reimbursement system. That reform was recognized as an award-winning model by organizations across the country. And there was a time when this committee heard multiple bills each session, and you've heard others mention this. Rather than building on the progress towards predictability, this bill really introduces uncertainty about funding, as you've heard. Will statutory cost of living adjustments be made, and will the necessary funding to meet those adjustments be requested? The provisions that are most concerning to us in LD 21-7 are the language pieces making payment of cost of living adjustments subject to available appropriations. It's unclear whether this includes all rate adjustments as well as the 125% of minimum wage provision. For adequate appropriations to be made, appropriate funds actually need to be requested. We all recognize that the cost of essential care and support has increased as the minimum wage increases, and the costs of benefits, utilities, and other supplies have also increased. This is why the COLAs are so important. The department should be responsible for requesting adequate appropriations based on anticipated usage and cost. The legislature then exercises its authority to decide whether to fund those requests. There's a mechanism actually available to you for understanding this usage and projected future costs in LD 1932. Making COLAs subject to appropriations transforms what should be a predictable statutory obligation into an uncertain possibility. Providers can't budget on possibilities. They can't recruit and retain qualified staff. They can't promise even cost of living wage increases. People who rely on these services deserve to know that the services they qualify for and depend on will be there for them in the future. We understand that the department's desire to make the statute flow better and appreciate the attempt to streamline the language, and we're supportive of this streamlining, as long as it doesn't interfere with the current statutory requirements for rebasing, for COLAs, or for rate updates. I have a little bit more in my written testimony, and thank you very much for your time. Happy to answer any questions.
Thank you. Jess, yes?
Thank you, Madam Chair. Thank you for being here, and the work you're doing now and what you've done in the previous legislatures. And that goes to my question. Help me understand, you've served on appropriations, and I don't know what other committees you've been on, but if this is an unusual request from any administration to ask for this type of way to handle funding.
You know, that's a really good question, Representative Graham. I might have to think about that a little bit. In my experience, I think Maine Care is a little bit of a different animal because of the obligations in Maine Care. But I have to think about that in order to give you, I think, a really comprehensive response to that question. But off the top of my head, I think departments ask for what they need, and then the budget process is, you know, it goes through a filter and there's a priority setting, and that's how the budget comes to the legislature.
Thank you. well, thank you for that. And your last paragraph, understanding the department's desire to make this work better. I would, if able, if you could bring back or share with us before the work session, some of your ideas about how the department might be able to make things better without extensive changes. So I don't want you to answer that now. I guess you can if you want.
I don't. I think it would be here a while. But I really appreciate the question, and I know there has been some thinking about that. And so we'll bring some back for the work session, some suggestions. Thank you.
Thank you.
Thanks.
Anyone else in the room?
Good morning, Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. My name is Clara McConnell. I'm a government affairs consultant at Main Street Solutions, and today I'm here representing the Maine Alliance for Care at Home. I'm going to paraphrase, so I hopefully don't repeat what others have said. But as others have mentioned, we're troubled that this language would perhaps unintentionally weaken Maine's statutory rate setting process. And our primary objection comes from the language in Section 3 that would make adjustments to future rates subject to appropriations and would give the department authority to reduce rates, including COLAs, in proportion to available funding, including the ability to cancel COLAs altogether. We, like others, were very heartened when the legislature and the department worked together on the statutory rate setting process that went into place in 2022. And we have been participating in that process in good faith. But for providers, the most important part of that process is the culmination of it and the implementation of it. And that's where our concern really comes into play today. And so as an example, I would just mention the ongoing rate setting process for home and community-based services that the department launched in June of 2024. This includes nursing services in home care. And home care agencies have been waiting on a rate adjustment for nursing services, which, as you all know, are extremely critical to allowing people to remain in their homes and serving medically complex children, et cetera. The current rates went into effect in 2018 based on a 2016 rate study that utilized data from 2012 to 2014. So we're paying nurses in home care based on data collected in 2012 here in the year of 2026. So as you can see, this is creates a huge workforce challenge for home care agencies. So we participated in the stakeholder process in fall of 2024. We're told that the process would wrap up in April of 2025. Here we are in February of 2026. We don't have an update on that process, and the supplemental budget was just released with no funding in it for these rates for home care nursing. So that's unfortunately very troubling for us and brings me back to this idea of the implementation, the onus for implementing these rate determination processes. We would recommend alternative or perhaps additional language in this sort of bill that would require the department, upon the culmination of a rate determination process, to come forward with a budget proposal that includes funding the rates, and perhaps also language that somehow encourages or requires the department to finalize these processes in a very timely fashion. I thank you all for thoughtfully considering this. I thank the department for all the work that they've put in to the process and all the 48 sections that they have completed or are ongoing. We're happy to help continue to refine this going forward.
Thank you. Questions from the committee? Seeing none. Appreciate you being
Thank
here.
you.
I'm a little short. Good morning, Senator Ingerson, Representative Meyer, and honorable members of the Committee of Health and Human Services. My name is Wanda Pelkey. I'm the CEO of First Atlantic Healthcare. I'm providing testimony today in opposition of LD 2177. First Atlantic is a Maine-based company. We have 17 nursing facility and residential facilities from Saco up to Madawaska, so really throughout the state. Every day, we take care of about 1,500 Maine citizens in our beds. I'm not going to read my testimony verbatim, so I'll spare you that, but I do want to add a bit of information that just underpins what others have said before me. I agree this is really bad policy for the state. Pulling away regular scheduled COLAs and regular rebasings will undermine all of the good work that was done during the rate reform committee work. I participated collaboratively in that nursing facility committee that led to the rate reform. While we didn't agree with everything in that work process, it was a huge step forward that really helped providers like ours depend on a rate that was sustainable for the long term. In that, key to those elements was having regular COLAs and these rebasings. As a company, First Atlantic invested a lot of those new resources towards really bolstering the base pay, sign-on bonuses, differentials, strong benefits in order to hire our own staff. As you may remember, I've come before this committee and talked about some of the strains we had during the pandemic of rampant contract nursing use. We've really made some inroads there, and this rate reform program really helped us do that. Now is the time to really sustain that good work that was being done, and this bill has the dangerous element of really undoing all of that good work. I have a chart in my testimony that just reminds us of how the number of Mainers 80 years old and up, which is our core population, how that's going to change in the next 15 years. It almost doubles. So, you know, we have all learned that over the past, if we don't provide sustainable rates, we face closures. I'm worried that we'll face that again. To sum up here, I do want to answer a question that's been talked about today. Part of that is around the timing of COLAs with what happens when the minimum wage rate changes on January 1. We all have to pay those increases. Yet, for planning purposes, DHHS will find it difficult to determine what that right COLA would be. And so they're suggesting let's make that change on July 1. We can take a page out of the Medicare guidelines, and that provides an estimate of what COLA will be. They pay that out timely, and then they do a backwards look. So the next year, they take a look at what actual CPI was. If they were wrong in that estimate, there's a forecast error adjustment that then, you know, for future looking rates, adjusts it. So just a solution there for that problem that's been raised. Happy to take questions.
Thank you, Wanda. Questions from the committee? Seeing none.
Thank you.
It is still morning. Good morning. I had to look at my watch. Thank you for the opportunity to be here. Senator Ingerson, Representative Meyer, and distinguished members of the Health and Human Services Committee. Good morning. My name is Angela Westhoff. I'm the president and CEO of the Maine Healthcare Association. We represent more than 200 nursing homes, residential care facilities, and assisted living facilities across Maine. I'm here today to testify in opposition to LD 2177. I'm not going to repeat the testimony of many colleagues who have come before me today. A few points that I would raise that are slightly different. You've heard several folks testify that Maine long-term care system is already in crisis, and I've been before this committee numerous times talking about the more than 50 nursing home and residential facility closures or conversions. And we all know that Maine is the oldest state in the nation, and sadly, access to long-term care continues to shrink, and we can't afford any further destabilization. I think others before me have really emphasized key sections of the bill, particularly Section 3, that would reduce predictability and stability of main care reimbursement. So I'm not going to focus on that. I would, in my testimony, however, call your attention to an extensive legal memorandum from Attorney Dingman at Kozak and Geyer. He has provided you with an in-depth analysis of the impacts of LD 2177, and I can't do it justice in my remaining minute and 43 seconds, so I'll just let you know that it's there. I'm going to focus on the nursing home specific sections. You've heard about Section 1. There's several things in there that is essentially updating statutes to tie to our new payment model. We do not object to any of those changes, eliminating a flat rate or occupancy penalties, for example. What is concerning, as you've heard from others, is the elimination of the 2-year rebasing. We know from history all too well, unfortunately, what happens when there's gaps between looking at the cost of care and main care reimbursement. In the interest of time, I'm going to jump ahead, even in my verbal comments, to just talk about giving the department widespread authority to reduce or flat out eliminate cost of living increases when funding's not available. And I think available is not defined particularly well in this draft. What does that mean? Does the money have to be appropriated? Does it have to be potentially from a main care stabilization fund or another OSR account? I think we need to spend some time thinking about what is that source of money. It also reverses the core principle of rate reform that rates must keep pace with the real cost of care. I think you've heard that a lot today. And then finally, I really want to focus in on Section 4. It's confusing what Section 4 of this bill is trying to do. We know that it's repealing a statute requiring rebasing every 5 years, particularly for 125% of minimum wage for essential support workers. But it appears that the bill's also eroding the ability of rates to keep pace with rising non-labor costs, so costs outside of providing direct care, but also very essential to supporting our oldest and most vulnerable adults. I can see that I'm out of time. I want to thank the committee for their time and attention. This is difficult work. We're grateful for the department for the opportunity to partner with them on rate reform and would encourage opportunity for provider input as we move forward with this discussion. Thank you.
Thank you, Ms. Westhoff. Questions from the committee? I'm seeing none.
Thank you.
Anyone else in the room? Testimony in opposition? Anybody on here?
Good morning, Senator Irwinson, Representative Meyer, and esteemed members of the Health and Human Services Committee. My name is Anne Marie Mayberry, and I am the CEO of Three Rivers, a statewide provider delivering essential main care funded services to individuals with intellectual and developmental disabilities across all 16 counties in Maine. Thank you for the opportunity to provide testimony in opposition of LD 2077. While we fully support efforts to modernize main care payments, the payment system, this legislation, as written, removes the only reliable mechanism that allows providers like Three Rivers to keep pace with the real labor market, guaranteed annual cost of living adjustments. Instead of COLAs becoming discretionary, dependent on whatever funds happen to be available in any given year, the department would be permitted to reduce or eliminate them entirely. For a provider operating statewide across every labor market in Maine, that creates instability we simply cannot navigate. Our ability to maintain staffing and therefore maintain access to services depends on the reimbursement rates that move with actual economic conditions, not year-to-year budget discretions. Let me be clear, direct support professionals are not competing for Maine minimum wage of $15.10. We are competing with the broader labor market, which pays significantly more. Across Maine, fast food employers routinely paying $19 an hour or more, especially in high volume or high pressure locations. Statewide data shows that fast food workers now average $21.30 an hour, with the 75th percentile earning $23.27 an hour, in wages reaching as high as $30. Most of our services in our southern region are in the Portland, and people have made reference here to the Portland minimum wage, which is significantly higher. This is the wage landscape we are competing in today in every single county. But it's not only wages that are increasing elsewhere, turnover within our sector is rising to crisis levels. DSP turnover nationwide is 50%. And with some agencies reporting that 1 in 8 DSP positions remain vacant at all times. That is true for our agency as well. According to the 2024 Anchor Workforce Crisis Report, 90% of the providers nationwide experience moderate or severe staffing shortages. 69% of them had to turn away new referrals due to lack of staff. So these are not abstract numbers. These are conditions which we are living in as a statewide provider. High turnover hurts continuity, increases risk, and directly reduces access to services. Every time a DSP leaves, the individuals we support lose a trusted relationship. Family members lose stability. Our remaining staff shoulder more overtime, more burnout, and more crisis work. Now more than ever, predictable COLAs are essential to stopping these losses. I have a little more, but I'm out of time. So I urge the committee to amend this bill to restore required annual COLAs or adopt a wage index model that acknowledges the true labor environment DSPs operate in. With this, Maine system will continue to lose DSPs at unsustainable rates.
Ms. Mayberry.
And the people will feel the consequences first. Thank you.
Thank you for being here today. Questions from the committee? I'm seeing none. Appreciate you being here. Testimony in opposition?
Good morning, Senator Ingerson, Representative Meyer, and esteemed members of the HHS committee. My name is Amanda Caromba, and I serve as the CEO of Happy Haven, a Maine provider of home and community-based services. We support individuals with intellectual and developmental disabilities, autism, and brain injury through residential, shared living, and in-home quarter-hour supports to allow them to live freely in their community rather in institutional settings. I'm here today in opposition of Section 3 of LD 2177. Our services are entirely dependent on Maine Care reimbursement. We do not have the ability to offset underfunded rates through private pay or cost shifting. When rates are unstable or unpredictable, services and workforce stability are directly impacted. Section 3 makes reimbursement adjustments, including 5-year redeterminations and COLAs subject to available appropriations. It allows the department to reduce or even eliminate scheduled adjustments if funding is unavailable. Without COLAs, we cannot responsibly commit to wage increases. We cannot offer competitive pay to recruit and retain staff. And we also cannot plan for long-term investments in training, quality, and compliance. At a time when providers are already absorbing new licensing costs, workforce shortages, and preparing for system redesign, this added uncertainty is destabilizing. Section 3 also weakens transparency by changing the requirement from must to may, which you've heard, and transparency in publicly funded programs is not optional. Providers, legislators, and the public deserve clear, accessible information about how rates are set and determined. When COLAs were fully funded in earlier years of the rate reform, we saw improvements in wage competitiveness, or at least service stability. Delayed or reduced adjustments in recent years have created real uncertainty. And HCBS providers cannot pause services while funding questions are resolved. We continue supporting people every single day. LD 2177 would roll back predictability and accountability in Maine's rate setting system. I respectfully urge the committee to oppose LD 2177 or at minimum, remove the language in Section 3 that makes reimbursement adjustments discretionary and weakens transparency. Providers need stability in order to provide stability. Thank you for your time and consideration.
Thank you for your testimony this morning, Ms. Karamba.
Thank
Do you have any questions? Seeing none.
Thanks.
Further testimony in the room in opposition?
Good morning, Senator Ingerson, Representative Meyer, and esteemed members of HHS. My name is Jen Jello. I'm State Director of NeuroRestorative. Since 2009, NeuroRestorative has been a proud provider of neurorehab services, and we currently participate in multiple waiver programs. We employ 329 Mainers and serve over 300 people with disabilities in the counties of Androscoggin, Cumberland, Kennebec, and York counties. I appreciate the good work that has been these past years to address Maine's dwindling workforce and to provide predictability in Maine's system of care. I don't oppose the general technical changes to 2177. The language, though, in Section 3, subsection 4, serves to destabilize the good work that has been done by this legislature, by the department and stakeholders, which had been previously implemented. So I'm not going to read all of this, but the primary objection here is the COLAs and the undermining of the rate system. As a person who experienced these last years, the heavy challenge of facing families when we told them we were going to have to close group homes and moved loved ones to involuntarily because of the lack of direct care workers made remaining open impossible. And as a person who had to spend days working out of a group home during the height of the pandemic just to be an extra pair of hands for transfer assistance because there simply were not enough people to have safe ratios, I can say from experience this bill deeply concerns me. I have been witness to workers experiencing challenges with rising housing costs, workers who have been in positions to live out of their cars, who have couch surfed as a method of survival. And these are people that have had full-time jobs. As a provider, I, along with many providers in this room, are committed to preventing that and have had a consistent track record of increasing direct care wages for our company annually. This bill jeopardizes that commitment. As written, 2177 is detrimental to our workforce and bad for our system of care. I ask you to oppose 2177 or at the very least amend the language on page 7 that provides for COLAs only when there are available funds and would allow for the elimination of scheduled adjustments. I ask you to make Maine's essential workforce a priority by ensuring that COLAs are consistent, predictable, and not a consideration only when it's convenient. Thank you.
Thank you for your testimony. Any questions? Seeing none. Further testimony in opposition?
Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Denise Vachon, and I'm here on behalf of Maine Care participating nursing care and assisted living members of Leading Age, Maine, New Hampshire, to speak in opposition to 2177. Leading Age Maine, New Hampshire represents mission-driven providers, many who participate in Maine Care supported assisted living and nursing care programs, specifically to ensure that financially vulnerable residents can remain in their communities as their care needs change.
These programs were built from the start on mutual commitment. Providers committed to operating licensed, compliant, and high-quality programs that serve Maine citizens in their most vulnerable moments. And in return, the state committed to providing reliable reimbursement that recognizes the real costs of staffing, operations, and maintaining environments. This partnership has been essential to sustaining care for those who depend on it. LD 2177 fundamentally weakens that partnership by making reimbursement contingent on available funding rather than a dependable component of the Maine care system. This change sends a clear message to providers that funding for essential services is no longer assured. When reimbursement is unpredictable, providers are forced to do more with less, undermining their ability to plan responsibly and pursue excellence. Unreliable funding pressures providers to make impossible trade-offs, limiting wage growth, reducing benefits, cutting services, closing beds, or avoiding Maine care admissions altogether. These pressures directly contribute to staffing challenges, reduced access to care, and growing instability across the long-term system. All of the closures and workforce shortages that we've talked about before stem from the same root cause, a reimbursement system that providers can't rely on. Without a stable, predictable funding structure, sustainability is not achievable. What providers need is a clear, consistent, budgeted baseline for reimbursement. And some great ideas have been shared here this morning, which we would support. But a system that is free from contingencies, clawbacks, or uncertainty is essential. The state must prioritize this partnership with fair and reasonable annual adjustments that reflect the true cost of care, including competitive wages and benefits for the workforce delivering these services. Leading Age Maine, New Hampshire urges you to reject elements of LD 2177 that make funding inconsistent and unpredictable, and instead to rework the bill to ensure reliable, sustainable reimbursement for providers, consumers, and taxpayers alike. We thank you all for your time. These are very big conversations, and we appreciate you very much. I'd be happy to answer questions or to help as the work goes on.
Thank you for your testimony. Any questions? Seeing none. Further testimony?
I apologize. My testimony is submitted online. Good morning, Senator Ingerson, Representative Meyer, and esteemed members of the Health and Human Services Committee. I'm here to testify against LD 2177, specifically Section 3, Subsection 4. I'm Kristen Overton and the Executive Director of Skills, Inc., and serve on the Board of Directors for MaxBeat, representing community supports and employment service providers. Skills is a nonprofit provider serving people with intellectual and developmental disabilities in rural central Maine. We employ over 140 people and serve about 120 people with residential community building, in-home, and employment supports. I recognize the many valid and fair changes that this bill proposes. I oppose specifically the language which makes appropriations discretionary or forgotten. The majority of providers are barely scraping by. At Skills, we've had to stop giving raises and significantly reduce healthcare coverage in order to still not make ends meet. I wouldn't be testifying today if COLAs and the finalized rate study were only a question of when. This language makes it a question of if money will be included in the budget or supplemental. While we welcome both, as providers without rate predictability, we can't afford to invest in new ODES initiatives like the lifespan waiver or respond to unexpected expenses such as the new licensing rule, which requires us to hire a part-time nurse to oversee all medications and will require an additional compliance person to expand our infection control program and manage the new risk assessment and reporting process outlined in the rule. Community support providers across the state who have been in business for decades are being asked by the fire marshal to install wired fire alarm systems and often sprinkler systems, fire suppression stove hoods, and pay a new registration fee as an adult daycare provider. Tens of thousands of dollars without reimbursement, unpredicted yet required of providers to continue services. The people we support are struggling as well. They're seeing new faces daily, which doesn't lead to quality support. Turnover is between 40 and 45% at our organization. For every 3 employees hired, 1 doesn't make it past 3 months and another doesn't make it past a year. Callouts are common, and so is burnout from the numerous employees working overtime to fill shifts. In the first 2 years of the rate reform system, we saw turnover drop to 22% and employees received meaningful raises. Overtime was down to the single digits. It really changes that quickly. Subsection 4 does not preserve the main care reimbursement system. It pushes the burden of deciding who is most worthy of a rate increase back onto this committee. Without predictability and consistency in implementing rates, the service structure fails while the codified reimbursement system remains pristine on paper. It goes back to being a discretionary system funded on what kind of feels like luck and political positioning. I urge you to remove any language in this bill that would make the main care rate setting subject to available appropriations.
Thank you for your testimony. Appreciate it. Any questions? Seeing none, further testimony in opposition to this bill. We do have 2 on Zoom. At least Adam Bloom Picopoulos and then Ann Sedlak.
Good morning. I think it's also still morning. Can you all hear me?
Yes.
Wonderful. Thank you. Good morning, Senator Ingerson, Representative Meyer, honorable members on the Committee on Health and Human Services. My name is Adam Bloom Picopoulos. I serve as the Executive Director of the Alliance for Addiction and Mental Health Services. The Alliance is the statewide association that represents community behavioral health providers. We represent 34 members who serve over 120,000 Mainers each year. On behalf of the Alliance, I'm here today to speak in opposition to LD 2177. I won't read my full testimony that is being provided. Folks today have really walked through some of the concerns well, but I did want to say that as community behavioral health providers who are overwhelmingly reliant on Medicaid as the primary payer of mental health and substance use disorder services, we do appreciate and agree with the department's goal of protecting main care and rate reform. And I also serve as the Main Care Advisory Committee's vice chair and also on the MAC subcommittee, rate subcommittee with Laura. And as someone who cares really deeply about Medicaid, I share in the department's desire to maintain the system in the long run. And I also really appreciate Representative Gattin's comments this morning to that effect. That said, we cannot support components of this legislation that would ultimately threaten the years of progress that have been made on rate reform and cost of living adjustments. These COLAs have really been a direct lifeline to our providers who have been able to rely on them to keep up with rising costs, particularly at a time when Maine is experiencing and expecting significant cuts to our healthcare system from H.R. 1. Maine's healthcare and workforce continuum of care cannot stand to bear additional instability. These predictable COLAs and the reliable 5-year determination schedule have been a lifeline for behavioral health providers as folks plan for the future, again, keep up with rising wages and operational costs, and are able to help keep programs open. Through COLAs, many of our members have been able to give much needed raises to their direct care workers on the front lines of this critical work over the last recent years that COLAs have been applied. Last year, as Representative Gattin had walked through, the administration did not include COLAs in the budget, and we are grateful that the legislature stepped in to support the direct care workforce and offer a partial COLA last year. That said, that development has already created a lot of additional unpredictability and instability among the provider community, and our position is that we cannot afford to continue taking steps back that inject instability to an increasingly fragile system at a time when it most needs consistency and support in the face of these federal cuts. Maine must remain committed to its promise of predictable rate setting and COLAs that direct care workers can count on to stay in this field and providers can rely on to ensure that life-saving services remain accessible. For these reasons, we respectfully urge the committee to vote ought not to pass on this legislation. I'd be happy to answer any questions, be a resource to the committee during the work session or with the department, and I appreciate the opportunity to provide testimony this morning.
Thank you for your testimony, Adam. Have any questions? Yes, Representative.
Thank you, Mr. Chair. Thank you, Adam, for being here virtually. You mentioned HR1 and the impact of the of federal monies not making it to our state for services. Do you have a general sense from the individuals that you represent, how they may be planning for this and how, because I know we all have great anxiety that federal dollars are going to be extremely limited. And do you have a sense of how your alliance is planning for this?
Yeah, thank you, Representative Graham, for the question. It's certainly an issue that is really top of mind of our providers as we try and, offer scenario planning and sustainability. One of the biggest challenges we're seeing is not just the dollars from the feds coming down, but also the increase in the uninsured population that we're expected to see. So the sort of double whammy crunch, if you will, I know that's not a super policy wonky term, but of folks who are currently enrolled in Medicaid who will be losing their coverage due to some of the community engagement requirements, those folks will now fall into the uninsured category. In addition, we have folks who are currently covered under CoverMe or the Maine's marketplace for commercial private coverage that will also be losing coverage due to lack of subsidies. So both from the marketplace and for MaineCare, you're going to see that uninsured area really widen. And what we see is our behavioral health providers are going to be bearing a lot of the brunt of that. And so that's where things like COLAs and predictable rates are able to help. It won't offset everything, but being able to have that and try and remain to stay open as folks will need to continue providing care to folks who no longer have insurance and are able to pay is really going to be the challenge that we're going to see in the next coming months and years. And that's why, those goals are so important and folks having something to predict and rely on.
Thank you. Sorry. Any questions? Any further questions? Testimony in opposition?
Thank you.
Yes, sir. Okay, come on up. Thank you.
Yeah, she's active. Yeah. We're gonna switch it up and do the Brio's-Ville next. It's okay with Ann, Sam will be here. We got James Mile.
Good morning, Senator Ingerson, Representative Meyer, and members of the Committee on Health and Human Services. My name is Jim Beaudry. I'm a veteran and survivor of 3 brain injuries, including.
1 minute, Mr. Beaudry.
The mic went off.
There you go.
There you go.
Should I start over?
Sure. Yes.
Good morning, Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. My name is Jim Beaudry. I'm a veteran and a survivor of 3 brain injuries, including an anoxic, a stroke, and later a traumatic brain injury. On behalf of the Acquired Brain Injury Advisory Council, thank you for the opportunity to submit testimony on LD 2177. I'm proud to be on the council, and I've dedicated the rest of my life to helping those with brain injuries, because it's such a struggle. And when I die, I'm going to leave my brain to Mount Sinai for research. I have several secondary conditions due to my brain injury. I qualify for in-home care, but I've been waiting 3 years. I just got it last Wednesday. I'm a resident of Auckland. In the absence of direct care workers in my area, it's adversely impacting my ability to live independently in the community. I need assistance with meal preparation, planning, sequencing, and much, much more. Our council does not oppose the technical changes to 2177. However, the language in Section 3, subsection 4, risk destabilizing the good work this legislature has done. The department, the stakeholders who previously implemented many scheduled adjustments, subject to available appropriation, scares us, which could include the eliminations of adjustments altogether. I'm looking to you today to ensure consistency in COLAs and to ensure a livable wage for the workers who are so essential to the Maine community. Stable funding is vital to maintaining trust, ongoing services. Improving access to services is the Council's core ongoing goals. We are charged with advocating and expanding, improving services, addressing barriers, wait list, provider capacities, workforce shortages, out-of-state placements. Without a stable and adequately compensated direct care workforce in any of these areas is limited. Oh, my time's up. I'll respect your time and the rest of you have the rest.
More words you'd like to say, go ahead. If you'd like.
His mic.
Yeah, I'm not a provider. The workforce crisis is evident within the brain injury waiver. Currently, we have 37 funded offers, yet 290 individuals remain on the wait list. More people are waiting for services than there are being served. The average wait for a waiver is 4.6 years. Imagine that. Waiting 4.6 years before you get help. It didn't do me any good. And those with the highest priority wait 1 and 2 years. As a result, 42 Maine residents have been placed out of state. Very expensive. Due to lack of specialized services in Maine, enhancing wages and supporting direct care force would have a meaningful and immediate impact. Imposing access to those services, reducing wait lists, strengthening provider capacity, and keeping Mainers with brain injury supported in their own communities. For those reasons, the Acquired Brain Injury Advisory Council urges you to reject this bill, or at least amend the language on page 7 for COLAs only when they are available. And we will allow the elimination of scheduled adjustment. I ask you to prioritize Maine's essential workforces by ensuring COLAs are consistent and predictable. Thank you so much.
Thank you. Thank you for being here.
Can I answer any questions?
Does anybody have any questions for Mr. Beaudry?
We
Seeing
can
none.
break for lunch.
Thanks so much for being here. Wish we could. That's a good idea. Further testimony, there's no more on Zoom in against, any more in the room against? Seeing none. Testimony neither for nor against in the room. We have one on Zoom, James Mile. Welcome.
Hey, good afternoon. Can you hear me?
Yes.
Okay, great. Good afternoon, Senator Ingerson, Representative Meyer, members of the committee. My name is James Mile. I'm a policy analyst at the Maine Center for Economic Policy. I'm here to testify neither for nor against the bill. While MESEP recognizes that the intent of this bill is to bring consistency to the Maine Care reimbursement and rate setting system, we do share some of the concerns that others have talked about today, that it will encourage the continued underpayment of essential care workers. In particular, we are worried that the bill would codify the administration's current practice of failing to meet the full cost of living adjustments to reimbursement rates that are designed to ensure that essential healthcare workers are paid something approaching a competitive wage. While we understand the department's position that this bill addresses the reality that appropriations have not allowed them to meet their statutory obligation, we do believe that the department also has its own obligation to request or at least report the full amount of money necessary to meet its obligations each budget cycle. I believe, if my memory is correct, those cost of living adjustments were underfunded in the last budget cycle, and I don't believe there's sufficient appropriations requested in the current supplemental budget to even take us up to where we should be, let alone future years. And then we believe if the legislature chooses not to make the appropriation that the department has adjusted, then that's a decision for the legislative body. I just want to take some time to remind the committee of some of the MECEP's prior findings that reinforce the need to ensure an adequate wage for care workers. We found that over 23,500 hours of approved home care for older adults goes undelivered every year due to staffing shortages. That statewide we're short at least 2,300 more full-time care workers to clear the wait list for approved care, and many more to meet the demand for care for people who haven't even applied due to the problems in the current system. We know that in addition to high turnover rates and chronic understaffing, the underpayment of workers leads to hardship for those workers, making them much more likely to close to the poverty line and to suffer for things like food insecurity. And meanwhile, as you've heard, the ultimate cost is borne by patients and their families who can't get the care that they need reliably or affordably. So I'd just say, as you consider LD 2177, I would urge you to find ways to ensure that the bill does not absolve the administration of its obligation to seek funding that will ensure adequate wages for care workers that keeps pace with the cost of living. Thank you, and I'm happy to answer any questions.
Thank you, Mr. Mayall. Do we have any questions? Seeing none. Thank you.
Thank you.
Any further testimony in the room, neither for nor against? Request from the committee for the work session? It's Representative Zager.
Thank you, Senator Ingerson. Who defines when money is not available? Like it's on page 5 and 7 of the bill. I think it's an important question. Also interested in any insight as to how the constitutional requirement for a balanced budget applies to this. I'll leave it at that. We can discuss more at the work session.
Any other requests for information? Seeing none, that brings to a close our hearing on LD 2177. We're going to skip to.
Take 5 minutes. Yeah, thank you.
I'll take
please.
5 minutes. Okay.
So welcome back. After a brief break, we are going to open the public hearing on LD 119. And we will welcome the bill's sponsor, our own Representative DeBrito, to introduce for
Thank you.
us. Welcome.
Thank you. Good afternoon, Senator Ingerson and Representative Meyer and colleagues on the Health and Human Service Committee. As you all know, my name is Flavia DeBrito. I represent House District 64, which is part of Waterville and part of Winslow. I'm honored to be here today to introduce LD 2119, an act to expand reimbursement for treatment in place, community paramedicine, and alternative destination transport on behalf of the Waterville EMS Department. This bill modifies how Maine pays for emergency medical service. Our system reflects how care is delivered today, not how it worked decades ago. Right now, EMS agencies are primarily reimbursed only when patients are transferred to hospital emergency department. But across Maine, EMS professionals are increasingly treating patients safely on scene, providing community paramedicine service, and transporting patients to clinical appropriate alternative destination, often keeping people out of overwhelming emergency rooms. This service saves money. They reduce unnecessarily hospital utilization, and most important, they improve patient outcomes. Yet today, many of these services are either under reimbursed or not reimbursed at all, forcing municipalities, taxpayers to absorb the costs or rely on unstable funding just to keep the programs alive. LD 2119 does not mandate new service. It does not set reimbursement rate, and it does not pass existing client clinical or safety standards. Instead, it directs the Department of Health and Human Service in consultation with Maine EMS and other partners to establish clear rules, build pathway, and quality standards for treatment provided on scene, regardless of transport, community paramedicine service delivered under PC licensure, and transporting clients appropriately to alternative destination when hospital emergency department are not the right place. This approach aligns with what the department has already shared in the testimony I will share, that community paramedicine is not emergent, episodic, delivered by licensed providers, and distinct from emergency ambulance service, and that reimbursement must be built thoughtfully with appropriate safeguards and documentation standards. It also recognizes that Maine Care has begun this work, but that wait until 2030 leaves community carrying the burden of years long that they can't afford. Across Maine, from urban centers to rural and island communities, EMS agents are already doing this work. LD 2119 ensures that when they do, it is stable, accountable reimbursement framework to support it. This bill is about smart care, the right care at the right place and the right time, while protecting patient safety and public dollars. I appreciate the collaboration with Maine EMS, DHHS, local fire department, EMS department, and my legislative colleagues as this bill moves forward. I want to thank you for your time, and I would hold any questions for the experts behind me.
Thank you, Representative. We appreciate your being here.
Thank you.
Yes. Representative Daigle?
I direct our ski patrol at our ski hill. So you tell me if we get a patient that comes down, goes in the ambulance to be evaluated or whatever, parent comes over to the hill, says, I'm not going to allow that to go to the hospital. I'm going to take the child home. They would get no reimbursement at all, even for that type of thing.
That's correct.
Okay.
Yeah.
Cool.
Thank you, Representative.
Thank you.
It's my understanding we have a co-sponsor on Zoom.
Good morning.
Good afternoon, Representative Ducharme.
Good afternoon. Good afternoon, Senator Ingerson, Representative Meyer, and esteemed members of the Health and Human Services Committee. I'm Jack Ducharme, and I proudly represent the people of Madison, Norridgewock, and Cornville in Maine House District 71. Thank you for the opportunity to testify today in strong support of LD 2119, an act to expand reimbursement for treatment in place, community paramedicine, and alternate destination transport, a bipartisan bill that I am pleased to co-sponsor. Our healthcare system is in crisis, on the verge of collapse, particularly in rural Maine, where residents wait weeks and months for doctor's appointments for minor issues. Those wait times often turn minor health challenges into full-blown medical crises that require hospitalization and much more extensive treatment and expensive treatment. The bill as proposed would help mitigate some of those situations by utilizing medical professionals who are available where the patients are rather than transporting them to some distant medical center. Treatment in place is roughly 25% of the calls for many EMS agencies. However, current reimbursement policies for EMS providers do not permit payment for services unless the patient is transported to an emergency department. Here's the scenario. Mr. Smith calls 911 for a medical emergency at his home. XYZ EMS responds to the call. When they arrive, Mr. Smith has an issue that the on-scene paramedic or EMT can handle on-site and does. Once the emergent situation is under control, the EMS personnel determine that there is no need to transport Mr. Smith to the emergency room that is 15 miles away. Mr. Smith is stabilized and can safely remain in his home or may be effectively served at the local urgent care facility. However, because Mr. Smith does not need to be transported to an emergency department, XYZ EMS won't get paid for the call. To get reimbursed for the call, XYZ must transport Mr. Smith to the emergency department and bill for that service. Once Mr. Smith is transported, the ER reviews the on-scene actions, perhaps repeats those actions and bills for those services. XYZ EMS gets paid for the transport. The ER gets paid for their services as if Mr. Smith had walked in on his own. I understand that this scenario is a simplification of the issue that we face, but this makes no sense. We can change this with LD 2119. This bill proposes to allow EMS agencies to bill for medical services rendered on site rather than requiring transport to allow for the billing of the EMS provider. EMS providers tell me that no transport situations occur roughly 25% on 25% of their 911 calls. Insurance companies almost never reimburse these calls. The response and assessment is occurring in 100% of these 911 calls, and that service warrants compensation to help EMS agencies fund their operations. Most people expect an ambulance to be ready to roll when they need it. However, many people fail to understand the cost of that readiness to roll in real life. Roughly 60% of our EMS agencies see 300 or less calls per year. The gap between the cost of readiness and medical insurance reimbursement is as high as $2,500 per 911 call, according to the recent Blue Ribbon Commission report. This bill works to shrink that gap. This bill also asks to reimburse our EMS agencies to help fill the gaps in our rural healthcare coverage. Access to healthcare in Maine is an acute problem in many areas of the state. Community paramedicine can help fill those gaps in our system, but we must authorize them and pay for them. It seems to make sense to me that since many EMS agencies are handling an average of one call a day, they would have capacity to help in our communities with some routine health care. This would help fill in some coverage and access gaps in our rural communities and provide financial support to help sustain the readiness of our EMS responders while not creating a new system that can be costly and may not work. The Jackman area is using a community paramedicine approach to provide health care in that remote area, and this system seems to be working. We should make sure that they are getting compensated for this service and look to expand this type of service in some of the more rural areas of our state. Alternate destination transportation is another area that needs to be addressed in terms of compensation for our EMS agencies. Currently, there is no ability for an agency to get reimbursed to transport a patient to a local primary care facility that does not have an emergency department. There's no reimbursement provision for transport to an urgent care facility or behavioral health or substance use clinics and facilities. Make no mistake, the appropriate destination for true emergencies is clearly the emergency department. However, for less acute complaints, it makes sense to allow EMS to transport to a more appropriate destination. Sending a minor complaint to the emergency department costs insurance companies and patients more for the same care that can be provided at less expensive destinations. This is done in other areas of the nation. We're simply asking to catch up with more efficient and innovative EMS systems. I'm not an expert on all these various EMS things. However, I have some experience in the EMS world, having served for 9 years as a board member of Anson Madison Starks Emergency Services. While on that board, we continually wrestled with how to provide appropriate service to the residents of the area at a cost that they could afford. When reimbursements for necessary services are not available from insurers or Medicaid, these agencies must reach out to municipalities for support in the way of a per capita assessment. While adding a per capita assessment to the municipal property tax may help offset some of the readiness costs, it usually does not cover those costs fully. Further, in a time when property taxes are crushing local citizens in many areas, we must look for alternative ways of funding these services. When payment for services fails to cover the cost of services, it creates a gap in financing for those agencies that will cause them to fail unless it is addressed. This bill, an act to expand reimbursement for treatment in place, community paramedicine, and alternate destination transport, will help us fill that gap, particularly in our rural areas. Your support for this bill will help us fill some of the funding gaps in our rural healthcare system. Thank you for listening to this and other testimonies in support of this bill. If you have questions, I'd be happy to try and answer or would defer to those folks coming later that have far more detailed knowledge of this. Thank you very much.
Thank you, Representative Ducharme. Questions for the bill's co-sponsor? Seeing none. Nice seeing you here in the Health and Human Services Committee, Jack.
Thank you.
We've got another co-sponsor here in the room. Welcome.
Hi there.
You can get
Thank you.
started.
Representative Meyer and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Sue Salisbury, and I represent House District 128, which is part of Westbrook. And I am here today in support of LD 2119. You already know the title of the bill. I won't read that again. But I first wanted to take a quick moment to thank Representative DeVerto for your extensive work on this bill and the effort that you put into collaboration. It was really, really impressive. In the past few legislatures, we have made significant investments in Maine's emergency medical services, both financially and through policy development. In the 130th legislature, we deemed EMS to be an essential service. In the 131st legislature, we allocated a historic $34 million to help struggling EMS providers keep the lights on and plan for the future. Along the way, we have learned the struggles that EMS providers face day in and day out to provide essential services to our communities. With the cost of healthcare rising, hospitals closing across our state, healthcare for our sick and injured neighbors is falling on EMS in ways we could have never imagined. It is time for us to meet the moment and help fill the gaps left by services that go unpaid. Data from the Maine EMS website show that in 2024, there were 52,020 cases in which patients refused transport. MaineCare will provide a small reimbursement to patients for whom treatment was provided, but transport was refused. Medicare will also reimburse a nominal amount for cardiac arrest and diabetic calls when treatment is provided. In other calls where further treatment is refused, such as an overdose, a minor car accident,
A skiing accident, as Representative Daigle mentioned, or a fall, no reimbursement for care is provided. This bill recognizes that these types of calls are increasing and that the critical treatment options that are becoming more common by community paramedicine need to be reimbursed by insurance carriers. To reiterate the goal of this bill, it expands the existing requirements for insurance carriers and the main care program to provide reimbursement for ambulance services, treatment that's provided on scene in response to an emergency call, regardless of transport, which I don't think people realize how frequently that happens. And in my relatively short time being an EMS provider, helping someone that's fallen, they just need help getting back into a chair, they need help getting back into bed, just some sort of assistance. That happens pretty frequently. You respond to a car accident, someone's called for 911 and ambulance response, but the person's not injured. They don't want to be transported. Those sorts of calls are very routine calls. So it's very important that those are addressed. As mentioned before in other testimony, the community paramedic programs that are really reinventing how emergency care is being provided and really addressing the healthcare needs to our rural Mainers. And then finally, the alternate destination transport to clinically appropriate facilities. Again, meeting the needs of our patients and our neighbors and people in the community that maybe an alternate aside from a hospital might be the best way for them to get treated. This bill is a significant step to meeting EMS providers at a moment when they need our help to provide crucial care as they step into a larger role in patient care. I urge you to vote ought to pass and provide the much needed support to our EMS providers. Thank you for your time and consideration, and I am happy to answer any questions you might have.
Thank you, Representative. Questions from the committee? I'm seeing none.
Thank you.
Any other co-sponsors here in the room? I'm seeing none. I know there's a lot of testimony in support of the bill here in the room, but I had a request from Dr. Amy Madden, who needs to duck out. So if you will indulge this individual with her testimony.
Please go first, right? Oh, goodness, this is awkward. Thank you very much. I'm sure I am.
Some high expectations for you right now.
Well, good afternoon, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. My name is Amy Madden. I'm a family physician and geriatrician. I practice in Belgrade. I've been there for the past 18 years. I'm also a past president of the Maine Medical Association, and I serve on the MMA's board of directors. I am here today to submit testimony in support of LD 2119 on behalf of the Maine Medical Association and the Maine Osteopathic Association. So as you've heard from the sponsor and co-sponsor, this legislation would ensure that EMS gets paid for the work they do, even when they are not providing ER transport, that community paramedics are paid for their work, and that EMS can now transfer patients to the most appropriate setting for their care, not just to the emergency room. It builds within stakeholders to manage specifically the details around reimbursement and alternative destination transport. This is an excellent opportunity for our state to leverage services that could improve healthcare access, lower healthcare costs, and also bolster community health. I'm a medical director for 12 federally qualified health centers throughout central and western Maine, so I'm fairly intimate with what it means when people don't have access to care. As you know, there's many parts of rural Maine where home health services are not available, even if people do qualify. We have an older population who deserve to age in place at their home, but may require some additional support to do so. And obviously places where really the only access to urgent but not emergent care is going to be in the emergency room. Community paramedicine is a tool that really helps to fill this gap. So I'm going to give you a few examples. I have a patient of mine who lives about an hour from our clinic. He has severe dementia. His spouse is his caregiver. She can't get him out of the house for care. So her only option when he develops a symptom is to call 911.
So he developed a cough. She called our office. We reached out to the community paramedicine program through Maine Health. Emily Hargraves went to his home, set up a telehealth visit for me so I could speak with the wife, while Emily was there to be my eyes and ears. She listened to his lungs. She took his vitals. We were able to really assess him and realize that he didn't need to go anywhere. We just needed to reassure his spouse that she was taking great care of him. Similarly, in Waterville, I have another patient living with dementia. This is the geriatrics part of my job. And she can't leave her home either. She does not drive. She needed some labs done. So we called the Waterville community paramedic team to go over to her home and draw some labs. And, you know, I think there's a little bit of an intangible here. I was satisfied because I got my lab results, but she really related to her daughter how nice it was to have these great people from the ambulance service come and visit her during the day. And that human touch, hard to measure, really valuable. So obviously providing care at home or in another setting instead of the emergency department reduces costs to the system as a whole, and is critical for us to leverage these different parts, particularly in this uncertain healthcare environment. To do this, I really want to echo what Representative Ducharme said about sustaining EMS services. Providing reimbursement for the care that they render, regardless of whether they transport, helps to further stabilize these services so that they can remain the viable asset for the community that they serve. So all of this put together, obviously, very, very good for our community health. I can see I'm at time. And I, you know, being a rural healthcare provider, I just wanted to further emphasize that for rural Maine, this is going to be a very uncertain time that we're facing. And these types of services really help to support the people that live in the state. That is all of my testimony. You have it in writing, but I would urge you to vote ought to pass on 2119. And thank you. And thank you. Any questions?
Thank you. Any questions for Dr. Madden?
I just wanted to point out, I did notice in your testimony that you suggested a slight amendment to add a tool timeline to the rulemaking.
Yes, I sort of skipped over that
I know,
part.
it's
at
okay
time.
because your time was up, right?
Yeah, I mean, I think one of the things that helps for planning purposes for any EMS agency is to understand what changes are coming and when. And of course, this would change what things look for like for them as a bottom line. So I think being able to predict that, not only, we want rulemaking to be deliberate and thoughtful, but we also want it to happen at a pace that allows for them to actually make these changes and put them into action.
Thank you.
Yes.
See no other questions.
Thanks.
Testimony in support.
I have to put my glasses on. This is new to me, so.
Welcome to my world.
Well, good afternoon.
Welcome.
Distinguished members of the Committee on Health and Human Services. My name is Jason Frost. I have the honor and privilege of serving as the fire chief in the city of Waterville. And I'm here today to submit testimony in strong support of LD 2119. And I do want to thank Representative DeBrito. She has worked very hard on this, and she has been with us every step of the way, and I thank you very much. Healthcare providers across Maine are struggling to keep up with the demand, and the challenges are especially pronounced in central Maine. With the closure of Inland Hospital in Waterville, Waterville residents and surrounding communities have experienced significant strain. Emergency departments are farther away, local services are overextended, and vulnerable populations are left with fewer care options. Our boots on the grounds, which is our EMS providers, our CP teams, and home-based care professionals see the daily, real-world consequences of these gaps. LD 2119 directly addresses many of those systemic issues by expanding existing reimbursement requirements for treatment in place, care delivered through community paramedicine programs, and transport to alternative, clinically appropriate destinations. These changes would make foundational improvements that would modernize Maine's emergency and community-based healthcare systems. LD 2119 builds a sustainable framework to support these expanded services. Community paramedicine in particular, and something we are very, very proud of in the city of Waterville right now, has emerged as a vital tool in preventing hospital admissions and readmissions. These programs fill the gaps between traditional EMS response and ongoing primary care especially for older adults who want and deserve to age in place safely and with dignity. But these services, they do cost money. Without proper reimbursement, agencies cannot expand or even maintain these programs. Many EMS services in Maine are already operating under severe financial stress, and LD 2119 would provide that financial structure to help stabilize and grow these critical supports. We have a wonderful CP program in the city of Waterville that is all grant funded. And when that grant money runs out, the program is not sustainable for us anymore. We just can't run it. Since the closure of Inland Hospital, our region has seen increased strain on EMS transporting services, longer time for emergency care, and reduced access to health care for elderly patients and our patients with increased medical needs. LD 2119, unfortunately, will not reopen Inland Hospital, but would give our community and communities across Maine the tools needed to adapt. Provides immediate relief by empowering EMS and community paramedicine teams to treat patients appropriately in their homes and receive reimbursements for doing so. LD 2119 is a practical bill that strengthens Maine's healthcare system, improves patient outcomes, and supports the professionals who are already doing the work. It helps close those long-standing gaps in reimbursement and creates a community-centered care model that will have a positive impact long into the future. For the healthcare and safety of our elderly population, for overburdened EMS agencies, and for communities still reeling from the loss of healthcare infrastructure, I urge the committee to vote ought to pass LD 2119. Thank you for your time, and I'd be happy to answer any questions.
Thank you, Chief. Question?
Thank you for your service. How far out would the Waterville EMS potentially travel to handle a call?
Well, we do travel outside the city of Waterville when asked to from other departments if they are also struggling, but we also have to ask them to come help us too. We have a robust mutual aid paperwork with our surrounding community, so we all do have to help each other. As far as EMS goes, now community paramedicine right now, because it's grant funded, we are helping other communities out. We hate to say no to people that need help.
How far of a travel? The reason I ask that, because where I'm from, Fort Kent, Allagash, you might be 45 miles away.
You want me to come up Fort Kent?
Well, no, you don't have to.
I will.
But an ambulance would leave, go up to the end of Allagash, take care of a minor thing because they don't, I mean, that's a significant distance.
It is.
And I know I understand from my area, but I assume it affects you also.
It does. Yeah, it does. Since the closure of Inland Hospital, we are left with Thayer, which is a great place, but they are just a standalone ER. So if we know that our patients are going to need definitive care, we do have to bring them to another place, which is usually either Augusta or Reddington. So that adds about an hour and a half of total time between runs now.
Thank you.
Thank you.
See no other questions. Thank you for being
Thank
here.
you.
Testimony in support.
Good morning, Chair, Representative Meyer, and committee members of HHS. My name is Everett Flannery. I'm the EMS Deputy Chief here at the Waterville Fire Department. I did submit written testimony online, which is a more comprehensive overview of what I'm going to speak on today. I was hired at the Waterville Fire Department 3 years ago to direct the ambulance program. One of my core tasks was to establish a community paramedicine program. While me personally, I was new to the specialty, I understood its role in community health. In 2023, Waterville did face a significant homeless encampment and record overdose numbers. Through a coordinated effort between our department and the police department, we were able to bring vulnerable individuals indoors during that winter and connect many to needed services. In 2024, we saw multiple success stories on unhoused patients with substance use issues and chronic medical problems who had no primary care. We connected them to providers, healthcare providers. We were able to secure appropriate medications for them, stabilize their conditions. And it is my opinion that those interventions were life-saving. Certainly after the closure of Inland Hospital, Waterville experienced several months where many high-risk patients had no primary care access. Okay. And when healthcare systems fail, EMS and emergency departments bear that burden. And that is a matter of fact. And there's a lot of history to that here in Maine and across the nation. Our community paramedicine program became a stopgap, checking vitals, ensuring medication access, coordinating refills through the Northern Light until patients could reestablish care. I believe our personnel, we prevented ER visits, hospital admissions, and serious medical events as a result. Today, as we continue to serve Waterville and much of northern Kennebec County as our catchment area for community paramedicine, we do support aging in place by monitoring patients at home, ensuring medication compliance, reporting current concerns back to their primary healthcare providers. As Dr. Madden had mentioned, we conduct in-home blood draws for individuals with mobility or transportation barriers. We perform simple wound care and provide the episodic attention that many patients need, but do not qualify to receive through home health. And I want to be clear, we're not a home health agency, okay? We are a stopgap until those services can be established. But there's many delays in that or lack of access to care in rural Maine that do increase the burden on EMS, the emergency departments, and hospitals as a whole. As you know, we're operating through grant funding right now, which is fantastic. We're up and running and we're proving our worth. But that funding is just not going to be forever. We need a better pathway for sustainability. We also have a limited tax base in Waterville. We're 14 square miles, so we understand the tax burden on property taxes. And I see my time's up. Like I said, I've expanded on this in my written testimony that I provided online. Please take a look. I certainly urge you to vote ought to pass on 2119, and more than happy to take questions for me.
Thank you. Questions from the committee? I'm seeing none. We appreciate you being here. Ongoing testimony and support. Welcome.
Good morning, afternoon, Representative Mayor, and members of the Health and Human Service Committee. Thank you for your attention to LD 2119, an act to reimbursement of treatment in place community paramedicine and alternate destination transport. My name is Chief Scott Susie, and I serve as fire chief for the city of Sanford. And on behalf of the city of Sanford and the Maine Fire Chiefs Association, I'm here to express my strong support for this bill. Sanford Fire and EMS is a career department serving more than 22,000 residents of York County from 2 stations. Like many other communities across Maine, we have adapted continually to meet the growing and challenging needs of our citizens and the many visitors that rely on our services. Each year, it becomes more challenging to provide safe, effective emergency medical services as staffing, equipment, and regulatory costs continue to rise. Yet the reimbursement structure we depend on has not kept pace. Federal Medicare rates, the foundation of ambulance reimbursement, have not increased since 2011. In 2023, the passage of LD 1602 capped private insurance reimbursement at those same outdated Medicare rates. This means we're operating modern EMS on a system 15-year-old financial formula. Just as every household has felt the rising cost of heat, electricity, groceries, rent, mortgages since 2011, municipal services face those same pressures. We must keep the lights on, maintain equipment, heat our stations, and respond to an increasing number of calls. Sanford's call volume grows by an average of 5% a year. Last year alone, we had more than 7,000 responses. 21% of our population is calling for EMS. 18% of our residents are now 65 years of age or older. And in 2025, they accounted for more than 1,987 calls for service. Like many communities, We are seeing more people aging in place and requiring more frequent medical support services. More than 600 of our responses last year resulted in no transport. Calls where we were required to respond, but the patient either refused, needed a bit of assistance, or did not require transport. Under the current rules, we receive no reimbursements for these calls, despite the time, personnel, and resources required. Treat and place reimbursement would significantly reduce the burden placed on our local taxpayers, who currently subsidize these unfunded services. I've got more. It's handed out to you. I'm just about out of time. But I strongly urge support in this moving forward, just so we can maintain the services that we're doing now.
Thank you. Questions from the committee for Chief Susie? Yes.
Really just a comment. I want to thank you for the additional legislative Q&A with the talking points. This is very helpful too. So thank you for.
Tried to break it down. You're welcome.
Thanks for taking the time to do that.
Seeing no other questions. Testimony and support?
Good afternoon, Representative Meyer and other committee members. My name is Butch Russell, and I'm the Executive Director for the Maine Ambulance Association. I'm also the CEO for Northeast Mobile Health Services. Here today to speak on in support of 2119, and I'm going off script a little bit here, and I want to just point out a couple of comments. I completely agree with everything that's been said before me, and appreciate all the work that representatives and senators have done for EMS and in the recent past. And these are all really important things here. Three things that kind of stand out in this bill: community paramedicine, treatment in place, and then transport to alternate destinations. Community paramedicine has been proven to work in Maine, and it's a program that we started probably 10 years ago or more and are still struggling to get it funded. There are work being done right now from the Department of EMS, and I'm sure they're probably going to speak to that. They're working with MaineCare to develop billing codes and a structure around this. So there is current work being done. If I could give one thing, if I could get one thing out of this, it would be if we could expedite that, that'd be great, because we're just kind of spinning our wheels. Treatment in place. As others have said, it's 20 to 30% of our call volume in EMS across, and that's most services in the state see that. We do get small amounts. It's been mentioned, MaineCare pays about $95 for certain no transports. And the one thing I'd like for this committee to really take away from, that's nowhere near enough to even roll the wheels. So I've said it before, I've been in front of this committee myself 3, 4, or 5 times speaking about this one thing. And the perfect example here is you roll the wheels to go to cardiac arrest, and those are all treatment in place unless you're successful. But on the unsuccessful ones, you know, you're emptying the station, all kinds of resources. You're emptying the drug box. You're using tons of supplies and equipment. One IO needle costs $150. We only get $95 for doing that event if it's a MaineCare patient. So just food for thought. The alternate destination is a really neat idea as well. And the other handout that I gave you is a summary of a national model that was just recently, I say recent, they ended it in 23, but there's all kinds of information there on that national model. This is the future of EMS, like Agenda of 2050 for EMS. And CMS, they are looking at these type of things. The ET3 is a national model. I think there was a couple of services in Maine that were part of that group, but it was a thing that you had to apply for and be accepted into. They ended the program early for a number of reasons, but the program itself is not looked at as a fail. It is looked at as a learning opportunity. And the one thing for Maine, this would be great as a starting point. I caution just flipping a switch and saying you can now do this. There's a lot of work that has to go into developing these kind of programs, and the association is here wholeheartedly to support that and to help in any way that we can. But our recommendation would be to try to either the new EMS commission or the main EMS office to direct them to look at this and to start the process of developing these programs. And been out of time for a little while.
Is that recommendation somewhere within the two pieces of?
Yes.
Okay. Can I ask, did you provide testimony or were you involved at all in a similar bill over in HCIFS 1530?
Yes. So in 1530, there's several pieces to 1530. So CP was part of 1530, and the major piece for us for this was there was treat no transport, and but for non-transporting services to pay for treat no transport, and I think that's the piece of currently in 1530. Someone can kick me from behind if I'm wrong on this, but that's so 1530. It was a divided report at a work session, and like 6 ought not to pass, 6 to pass, and 1 that was a
three-way
one as
report?
amended, 1 as
Okay.
supporting it.
And what does, well, we'll get the information on what 1530 does and how it works.
It
or
doesn't
against
change.
this piece
What
of-
it does is it brings the big piece of that is for the non-transporting services. So currently they can't bill at all for anything. So a non-transporting service is a service that is a first response service.
Yep.
They first respond, and then a transporting service comes in behind them and transports the patient. They've never been able to bill for that service. So this opens the door for them to be able to bill commercial payers for that service. Still unable to Medicare and main
Okay.
care, but it opens the door for them for commercial payers.
Yep, thank you. Appreciate that. Any other questions? Seeing none. Thanks
you.
for being here. Testimony and support?
I have the right number this time. Good afternoon, Senator Ingerson, Representative Meyer, esteemed members of the Joint Standing Committee on Health and Human Services. My name is Marge Kilkelly, and I am here on behalf of Legal Services for Maine Elders. LSE provides free legal help statewide for Mainers over age 60 when their basic human needs are at stake. Our clients are generally low income, some with medically complex conditions. We strongly support LD 2119. Maine has a history of being resourceful and thrifty. We have a tendency to find solutions to issues often by looking at what we already have and utilizing it better. This legislation offers a unique and creative solution to some of the healthcare issues of older, rural, often isolated Mainers. There are 3 types of care addressed in the bill. Treatment on site. Not every call requires transport. When a trained EMS provider can resolve a situation in the patient's home, it often reduces the stress for that patient as well as being more cost-effective. Transport to other than an emergency room. Sometimes an emergency call actually requires transport, but to a facility other than an emergency department. This reduces the number of transitions for a patient as well as reducing cost. Providing episodic patient evaluation, advice, and treatment as requested by a physician, such as post-hospitalization follow-up care, monitoring chronic conditions, or wellness check. Quality follow-up care improves patient outcomes and reduces readmission. Community paramedicine home-based care has many benefits beyond the actual care. A trained EMS person would be able to identify issues that would almost never be brought up during an office visit. Is the home too hot or too cold? Is there food available for the resident? Is the patient struggling with mental health issues? Is the home safe, or does there need to be an evaluation, for example, for fall prevention? Are there people living in the home that raise a question of safety for that resident? Further, this care also creates a relationship between the provider and the patient. So when an actual emergency transport to an emergency room is needed, there is less stress on the patient. And I think you heard that in previous testimony about how nice it was to have a visit. Finally, cost. We all know that the cost of healthcare is skyrocketing. Paramedicine serves as a triage to assure a patient gets appropriate care in the most appropriate setting, which can often reduce the cost of care. I'm going to end where I began. Maine has a history of being resourceful and thrifty. We have a tendency to find solutions to issues by looking at what we have and utilizing it better. Community paramedicine is an example of Maine resourcefulness, thriftiness, and good common sense. We urge the committee to pass LD 2119. Thank you.
Thank you so much for your testimony here today. Do we have any questions for Marge? Seeing none?
Thank you. Happy to
Take care.
assist in work session if necessary.
Okay. For the testimony and support?
Senator Ingwerson, members of the Health and Human Services Committee, my name is Anthony Wilson. I'm the town manager in Winthrop, and I'm here testifying on behalf of the Winthrop Ambulance Service and the 7 communities it serves in strong support of LD 2019. And ma'am, thank you so much for your sponsorship of this bill. Last year, the Winthrop Ambulance Service responded to 2,181 calls. 22% of those involved medically appropriate care at the scene, but without any transport. So in other words, 1/5 of the calls that the Winthrop Ambulance Service responded to, there was no avenue to recoup even a portion of the cost of personnel, equipment, supplies, medications, and the resources used in order to treat those patients. Thus, and I'm going to stress something that really hasn't been talked about to this point, taxpayers in the 7 communities that we serve absorb the cost of that treatment that was, again, clinically appropriate, and also help to reduce the burden on already overburdened emergency rooms. In the current fiscal year, the taxpayers in those 7 communities are subsidizing the Winthrop Ambulance Service by about $850,000 due to uncollectibles, people getting treatment who are uninsured, and inadequate, and has been spoken about before, outdated insurance rates. So LD 2119, in our opinion, would mitigate that impact in 2 really substantial ways. Number one, it would fortify the financial stability of ambulance services, particularly the private providers that are struggling just for survival. So their demise would further strain municipal providers and, again, the taxpayers that support those services. Number two, it would, as I mentioned earlier, shift the cost from property taxpayers to insurers and Maine Care when treatment in place is, again, medically appropriate. So by reducing that municipal subsidy to those providers, you're also providing a measure of property tax relief. So the town of Winthrop respectfully urges the committee to vote ought to pass on LD 2119, and we thank you for your consideration.
Thank you so much for being here, Mr. Wilson. Do we have any questions? Seeing none. Further testimony and support?
Okay, good afternoon, Senator Ingerson, committee members, my name is Lisa Harvey McPherson, and I'm here today on behalf of Andrea McGraw, the Vice President of Emergency Medical Services at Northern Light Health. We too are impacted by the non-transport challenges, and we too provide community paramedicine services. In fact, a significant portion of our calls include response and treatment without transport. In 2025, we had 2,421 calls that resulted in no transport. This is 14.5% of all of our requests for 911 services. And as you've heard, we're not reimbursed for these calls, but yet we do incur the full expense. We offer community paramedicine services at Northern Light Medical Transport, Northern Light Mayo, and Northern Light CA Dean. All are licensed community paramedicine agencies. We partner with our home care and hospice team in these rural communities to provide home care, hospice, and community paramedicine services as a combined team. I speak a lot in this committee about the challenges of home care and the home care workforce. This model works, but yet very often we're wholly and fully dependent on grant funding. And we know grant funding comes and then grant funding goes. I want to take a little bit of time of talking about alternative destination transport. There are successful programs in other states, but we really believe that we need a work group to focus on this. Because if I think about the Northern Light primary care practices, for example, our primary care practices are not structured today for a transport into their practice of a low acuity patient that isn't built into their workflow. I'm not sure that walk-in care is prepared. I'm not sure that a variety of health centers are prepared for an influx of ambulances bringing patients to their facilities when the providers are pretty well booked for care. So, but yet this does work and it does have potential and it would be a cost saving to avoid those emergency room charges. So I think this needs a bigger portfolio of engagement. And I really think this particular part of the proposal needs a work group. And with that, I welcome any questions that you have.
Any questions? Thank you, Lisa. Further testimony and support.
Good morning, afternoon.
Afternoon.
Senator Ingerson, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Amanda Campbell, and I am submitting testimony in support of LD 2119 on behalf of the Maine Municipal Association's 70-member Legislative Policy Committee. LD 2119 recognizes a longstanding need for adjustments to ambulance service treatment models and reimbursements, concepts identified as vital in 2017 and earlier with the launch of the Community Paramedicine Pilot Program. In response to the lack of funding for these much needed and successful programs, MMA put forward a platform bill during the first session, LD 1530, as Representative Meyer has mentioned, which was sponsored by Senator Curry, who was also a co-sponsor to this bill, to include non-transporting emergency medical services into Title 24A, the section that we're discussing in this bill. Representative DeBruto's bill repeals that whole section and completely replaces it with new language that requires reimbursements for the vital services of emergency transport, treatment in place, community paramedicine, and alternative destination transport. This proposal was unanimously supported by our LPC. This session, MMA's platform bills focused on workable solutions to decrease the over-reliance on the property taxpayers for the delivery of vital services. Codifying reimbursements for these community options aligns with the policy priorities of municipal officials and reduces the need for property taxpayers to bear the full burden. You will hear and have heard testimony from community leaders that illustrates exactly how vital these reimbursements are to the continued provision of local EMS services. Thank you for your consideration. I'm happy to take any questions and I can be available for the work session.
Thank you so much. Questions? Seeing none.
Thank you.
Further testimony and support?
Good afternoon. My name is Dennis Russell, no relation to Butch, but we do work together on many occasions. I'm a resident of Gray. I really would like to thank you all for listening today. And I have a written that will give you some additional information. I'm extremely excited to support this piece. It's been a long, strange trip for us at United for community paramedicine over the years. I've been involved in community paramedicine since one of the starting programs. United has been doing it since 2013. And all along the years, it's been grant funded. And it's a lot of work to go through grant to grant to grant. The other thing that unfortunately, going from grant to grant, some of the focuses really depend on the grant and the grant funding and what you're doing and those focuses. I think community paramedicine can be so much more. And it's extremely exciting to kind of see where we started to move. We've done a lot of work in the education committee, which I'm not speaking for them. I'm speaking for myself as a paramedic, as a community paramedic, and as the operations manager for United and the community paramedicine program at United as well. This bill has so many things to unwrap that is super exciting, I think, for EMS on many different factors. The community paramedicine aspect, we've been working quite some time. I think this opens the door to really start looking at some of those pieces. We have 2 full-time community paramedics, and we have them because of the grant funding that we've worked really hard to obtain, and that grant funding is extremely difficult to do. If we didn't have that grant funding, our program would be drastically changed. We service not only Lewiston and our surrounding communities, but we also service Bridgeton as well. We are looking with some of the grants to really explore some of the higher level things with community paramedicine. We're looking at some of the other point of care testing and doing some other things that actually could be some real help to some of those aspects. Seeing that, I don't want to run out of too much time, but the community paramedicine is a huge piece. The no transport as well really is an interesting factor. I gave you some raw information, but with the city of Lewiston and our surrounding communities, which we're privileged to serve, we have a very large call volume. We're number 2 in the state as far as 911 responses. The numbers that you see there are just 911 responses. And the smaller numbers that you see there are actually ones that would potentially be able to be billed. That doesn't count the canceled en routes, doesn't count a whole bunch of other pieces, but that does give you some information. And one last thing before I get booted out, the alternate destination, though it needs work, extremely exciting. And I think you'll hear some other testimonies saying that this is something that at least now we have something we can start talking about and moving this forward. And this is an amazing bill and super excited to see this happen. Thank you.
Oh, I'm the guy. I have a question for you. Trying to give myself permission to ask. I think I need some lunch. Do you agree that the alternative transportation idea needs some work in order to come up with something that's practical?
I think it does. I think it is practical now. It's not like at United, we're going to all of a sudden start bringing people to primary care offices. There's a whole lot of work. But we haven't been able to have those discussions right now. We haven't been able to explore that opportunity. So I think, yes, there's a lot of framework, there's a lot of guidance that will be needed, but having this in place is super important. The other thing that I did forget to say, timeline. like, we've been kicking the can of community paramedicine down the road. I've been here multiple times talking about community paramedicine for years. If I didn't have grant funding, I wouldn't have a program. And we see about 12 to 1,300, we do about 12 to 1,300 visits. So I think it's really important. But for that piece, I do think there needs to be some work to make sure that everything is safe and we don't overwhelm other systems. But it's super exciting. I know Spurwink was talking about putting in some testimony to support, and they're putting up some really interesting substance use disorder pieces, and we've already started talking about what things would look like. I can't, without this bill, I couldn't necessarily transport there. There's some other things that need to take place, but this is a great start to move forward.
Thank you. Any further questions? Yes, Representative Loveland.
So to be clear, Bridgeton has their own fire department, but you provide the ambulance service
Correct.
for them?
Yes.
How many other communities have their own fire department and you provide the services?
So for twofold, so United, we're two companies but one, so to speak. So we have United Ambulance Lewiston. We provide services for the city of Lewiston, Sabattis, Wales, Green, Minot, Mechanic Falls, all underneath 911 response. That's for the city of Lewiston. For Bridgeton, we do this town of Bridgeton, Denmark, half of Harrison, Sweden, and a few others as well. So we have multiple communities that participate with that.
Thank you.
Further questions? Seeing none, thank you.
Thank you.
For the testimony and support. We have on Zoom, Catherine Ryder from Spurwink. And then, is that true? Are we on 2119?
Yeah.
Okay. We also have Jack
No,
Ducharme.
Jack's already been on. He
Oh, okay.
testified as a co-sponsor.
That's right. He went on as co-sponsor. Okay. Catherine Ryder.
Sorry about that. I was digging around for the unmute.
It's okay. We can hear you.
Okay, thank you.
No visual, but that's fine.
Oh, I'm so sorry. Let me see if I can make the visual work. Start my video. There were 2 questions and I went back to my
Oh, there
testimony.
you go.
I'm here now. Can you see me?
Yeah, I can see you. Thank you.
Okay, great. Thank you. Good afternoon, Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Catherine Ryder, and I serve as the Senior Director of Strategic Initiatives at Spurwink, having formerly served as the CEO of Tri-County Mental Health Services until our organizations joined in April of 24. I am submitting testimony in support of LD 2119. While at Tri-County, I partnered directly with United Ambulance's community paramedicine program through grants that were supported by the United Way and the Maine Health Access Foundation. This collaboration allowed us to bring clinical care into the community for 3 high-risk populations. First, we served individuals with opioid use disorder by providing buprenorphine induction directly in the field, with rapid transition to our clinicians for ongoing treatment. Second, we worked with people living with serious mental illness who were frequent emergency department users, offering structured in-home assessment and stabilization. And third, we focused on older adults with complex medical and psychiatric needs, providing community-based evaluation to avoid unnecessary acute care admissions. Each initiative produced exceptional outcomes and demonstrated that community paramedicine is critical to improving access, ensuring high-quality care, and reducing healthcare costs. In my current role with Spurwink, we are exploring new ways to collaborate with community paramedicine programs to enhance community health and reduce strain on already overburdened hospital systems. Spurwink is proud to operate a crisis receiving center in Portland with a second site in Lewiston scheduled to open in July of this year. For years, providers in EMS have recognized the need for alternate destination transport, particularly for behavioral health crisis, where in many instances we can be part of the solution to preventing unnecessary hospitalization or incarceration. Community paramedicine is not merely promising, it is evidence-based and highly effective. A few data points include 40% of U.S. emergency department visits are non-urgent, indicating strong potential for diversion to CP programs. Community paramedics improve chronic disease outcomes through home visits, education, and preventive care, reducing exacerbations linked to poor primary care access. CP programs enhance access for rural, older, and high-risk populations, addressing social determinants such as transportation, scheduling, and health system navigation. At least 7 state Medicaid programs in 14 states reimburse community paramedicine or treat without transport services. This legislation is timely and necessary as Maine faces widening gaps in primary care access, significant needs in rural communities, and increasing pressures on EMS and hospital systems. It also establishes the reimbursement mechanisms needed to make alternate destination transportation viable as protocols are built. I strongly urge you to pass LD 2119. Community paramedicine works. It reduces unnecessary emergency department use, improves outcomes, lowers costs, and reaches people who would otherwise fall through the cracks of our healthcare system. Thank you for your time and for your leadership.
Thank you so much for your testimony. Any questions? Seeing none. Thank you. No further testimony in favor? Testimony in opposition?
Someone left their testimony up here and careful I don't start just reading it. Yeah, I know. Yeah, it's kind of, yeah. Yeah. Good afternoon. My name is Senator Ingerson, members of the committee. My name is Dan Demerit. I am the Executive Director of the Maine Association of Health Plans. Speaking in opposition to the bill today, but not in opposition to the good and hard work that's being done to advance community paramedicine. I think we have a shared outcome. Everyone in the healthcare system has a shared interest in making sure that people get the right care that they need in the right setting at an affordable cost. And a lot of good work is going on in that space, and that's part of what our testimony is about today. Just to walk you through sort of the highlights of my testimony that, in writing, that I provided in writing. The Maine Association of Health Plans has participated in the community paramedicine stakeholder group in the summer of 2024 and has been an active participant in legislation being considered in the health. And I'll speak about Title 24A today, but in the HCIFS committee. We're opposed to LD 2119 because we think it's overly broad and could be costly, and because it doesn't align well with the ongoing work that's being done to create a community paramedicine infrastructure in the state of Maine, particularly on the private coverage side. We think that the bill, as presented, expands coverage for community-based services for Maine's fully insured private health plans. It's important to point out items in 24A apply to fully insured plans in Maine, which is about a third of the commercial market in Maine. So only those fully insured plans in the large group, small group, and individual market, and not the self-insured market. But Maine's private health plans already do provide coverage for home health care, basic life and advanced life support services, and treat no support services provided by ambulance service providers, and transportation by ambulance service providers to hospitals, between hospitals, from a hospital to a nursing home, hospice, or other healthcare facility when medically necessary. Those items have been addressed in statute and are currently law today. Again, that's in the I know this bill encompasses 2 different titles and two different types of payers. The reimbursement rates for treat no transport, basic life, and advanced life support in current law is set at 200% and 180% of Medicare rates for network and out-of-network ambulance service providers. That was advanced in the 131st legislature. We would share that if this bill does move forward, it would require a mandate study, as was shared with you in the Bureau of Insurance letter that you received as part of the testimony package, to understand the premium impact, other social impacts, and potential defrayal expenses if the bill moves forward and expands Maine's essential health benefits. So there's a lot of questions to be answered about where this bill and what it encompasses and how it's different from what's already in law and what that could mean for the costs and delivery of service in Maine. We would share some news there was a question about the LD 1530 and the work that's going on. I provide you in my testimony some of the basics of the ought to pass as amended report that's before that committee and was reported out. The language was reviewed last week. And finally, I would share that the there's a work session I wrote this afternoon in my testimony, but it's probably happening like right now on the licensing bill for community paramedicine in HCIFS. And I'll be going over there after this session. So we also have concerns about the rule, and I see I'm over my time, but concerned about the unallocated language about rulemaking authority. It doesn't talk about the Bureau of Insurance, and the Bureau of Insurance regulates private health plans and has authority over 24A. So we have concerns about that not being included. And if the committee does choose to advance the bill, there needs to be discussions about the effective date for health plans because they, on an annual basis, those become available. I really do appreciate the time and a couple extra seconds to
Thank
speak
you.
to our issues. Yeah.
Further questions from the group, committee? Seeing
The
none?
licensing bill you reference, is that 2128?
It's 2133.
Okay, is there also a 2128?
I'm not familiar with that one.
Okay.
Yep. I bet there is. I mean, to get to 2133, they had to go through 2128 to get there, but I'm not sure. Yeah. Thank you so much.
Further testimony in opposition?
Good afternoon, Senator Ingerson, Representative Meyer, and members of the I almost said the wrong committee. I apologize. Health and Human Services Committee. Try to remember where I am this afternoon. My name is Christine Ossenfort. I am the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I appear before you this afternoon to testify in opposition to LD 2119. Our concerns with the bill are several. First, as many have testified, it would require coverage of transportation to alternate destinations. The definition of alternate destination is extremely broad, and it could inadvertently become a means of transportation to non-emergent medical appointments. Can't get a ride to the doctor's office, call 911, and the ambulance must take you and we must pay for it. So to the extent the committee is interested in pursuing this, we would support the suggestion by Ms. Harvey McPherson that a stakeholder group or work group be established to look at that. Because we certainly are interested in avoiding ER whenever possible, but as drafted, we are very concerned that it creates significant cost. Much of the bill is also duplicative of existing requirements, as other speakers have noted. Maine law already requires that state-regulated health plans provide coverage for treat no transport situations. And actually, we at Anthem were reimbursing for that even before the state law took effect in 2024. We're also concerned that this legislation won't have the desired impact, particularly with respect to community paramedicine services. There has been quite a bit of discussion about how the clientele served by community paramedicine is largely a main care and an elderly population. They are not the people covered by commercial insurance. They are largely covered by Medicaid or by Medicare plans, neither of which would be subject to, Medicare is addressed in the bill, but sorry, I'm mixing up Medicaids and cares. Medicaid would be addressed, Medicare would not. And the state doesn't really have the ability to impose these requirements on Medicare plans. A study of the Lincoln County Community Paramedicine Project in February 2020 found that the average age of the individuals referred for community paramedicine program was 78.3 years old. That's not our membership. And so the reimbursement requirements also won't apply, nor the coverage requirements. As Mr. Demerit noted, this legislation would apply to a very small portion of Maine's population. Approximately 300,000 people are enrolled in plans subject to state regulation. So you will continue to see emergency service providers who are billing out-of-state insurance plans, and Medicare will not be reimbursed for these services, even if you enact LD 2119. I see that I'm out of time. I'm happy to answer any questions, and I do apologize for not having written testimony, but I wasn't able to get to print it this morning, so I will provide it to you for your folders.
Do we have any questions? Yes, Representative Zager.
Thank you, Mr. Chair. Thank you, Ms. Ossenfort. Good to see you again.
Yes, you too.
Does Anthem, the medical literature has found largely that community paramedicine reduces ER visits. Not all the studies, but that's one of the general findings. How convinced is Anthem that it does that, given that diversity of findings? How convinced is it that it reduces ER visits? And based on the first answer, how supportive are you? Because your members would have to pay for the ER visits of those that would be prevented by your covered members, right? So what is Anthem's take on that element of?
So I'm not aware that any of our sister plans in the other commercial states in which we operate are currently covering community paramedicine. I do believe it is covered under some Medicaid programs. So I can try to get some information on that. And I wouldn't say, it's not that we don't see value in community paramedicine. We are concerned about a mandate to cover it, and a mandate to cover it at what are pretty high reimbursement rates, because LD 2019, current law says that the mandated reimbursement rates of 200% of Medicare and 180% of Medicare do not apply to community paramedicine. LD 2019 repeals that exclusion, which means those rates would apply to community paramedicine. So I think, we don't need a law to be able to contract with a provider to provide services. But we do want to be able to set those reimbursement rates, because we want to make sure that, for example, I think there was earlier testimony that said that community paramedicine is often sort of a bridge till home health care can be arranged. But we shouldn't be reimbursing similar services at significantly higher rates. So I think there was a stakeholder group a year or so ago that I was a member of that laid out sort of a path to pursue for community paramedicine. And I think Mr. Butch Russell, I'm sorry, I forgot there were two Mr. Russells who testified, mentioned that as well. I'm not sure that we have followed the recommendations of that report to sort of move into covering community paramedicine just yet. We're certainly open to the conversation, but we are opposed to a mandate at this point in time.
Okay, thank you.
Thank you.
Thank you so much.
Thank you very much.
Further testimony in opposition? Testimony neither for nor against this legislation? Seeing none? Request from the committee for the work session?
I guess
Yes, Senator Moore.
I would be interested in hearing about the study that was done on the community paramedics. I
Oh, yeah.
think that'd be nice
The one
to,
the last-
the the last one was done with the recommendations, if we can. Thank you.
Yes, thank you, Senator. So we've got several bills. I think there's at least two over in HCIFS. And I would want to see a side by side, the intersecting aspects of those bills.
That brings to a close the hearing on 2119. Do folks feel a need for a break before we jump into 2131? 5 minutes.
Okay.
When this hearing's over, we're gonna have to take some time to caucus, because you may be gone for the last part of some of these.
Yeah, so,
You know what I'm saying?
let's just say this is over at 2:30.
Okay.
Then let's,
Caucus till 3.
well, we're supposed to start
I know.
at 2:00.
15, 20 minutes for work, for caucus.
I don't know how many people this is going to bring out. Maybe it doesn't have a lot of people.
Okay.
So if we can,
Just play it by ear, see where we are.
maybe it's just the people that are left.
We're back and ready for the hearing on LD 2131, an act to preserve and improve access to nursing facility services in the state, presented by its sponsor, Senator Grohowski of Hancock.
Good afternoon, Senator Ingerson, Representative Meyer, and distinguished members of the Health and Human Services Committee. My name is Nicole Grohowski, and I'm honored to represent 22 coastal and island communities of Senate District 7. Thank you for the opportunity to introduce my sponsor's amendment to LD 2131, now titled Resolve, directing the Department of Health and Human Services to amend specific portions of the nursing facility principles of reimbursement and to timely release quality payments. The reality is that for many of our neighbors, the nursing home crisis isn't just a headline, it is a heartbreaking personal experience. In my hometown of Ellsworth, our community felt this shift deeply when Seaport Village, which was the very last skilled nursing facility in Hancock County, was forced to change its mission and convert to residential care. Since 2014, 29 facilities across Maine have closed their doors, leaving anxious families and uprooted seniors in their wake. We have the oldest population in the country, and yet we have seen the very infrastructure meant to care for our elders disappear. To put this in perspective, I'll ask you to consider Ron Stanko and his daughter Samantha. Ron experienced a traumatic head injury later in life that left him 95% nonverbal and wheelchair bound. He required a level of skilled nursing care that simply vanished from our county overnight. As a result, Samantha was forced to navigate a relocation of her father to a facility over an hour away from home. When we lose these facilities, we don't just lose beds. We lose the ability for families to be present for one another. No daughter should have to drive 2 hours round trip just to hold her father's hand because the care he needs is no longer available in his own community. Rate reform went into effect on January 1, 2025, and its first year has had some promising results. So that's the good news. But despite our collective efforts, we are still not out of the woods. A year of data has shown us that some additional course corrections are needed to keep the remaining 78 facilities that accept Medicaid afloat. Ultimately, we must move beyond just preventing closures and build a system where it is viable for new facilities to open and meet the growing demand for care across our state. So what does LD 2131 do? This resolve is an emergency measure designed to stabilize our long-term care sector by ensuring that the funds the legislature has already appropriated actually reach the front lines of care. Here's what the bill requires. First, fixing the guardrails. Currently, there are guardrails in the reimbursement formula that are preventing 35 of Maine's 77 nursing facilities that take Maine care from receiving their legislatively approved cost of living adjustment. This bill directs DHHS to adjust the guardrails for inflation so that half of our state's nursing homes aren't left behind while facing real rising costs. Secondly, the bill has a direct care add-on. It partially reinstates the 2025 add-on to the direct care rate at $6 per Maine Care resident per day. This is a critical tool for recruitment and retention of the staff who care for our neighbors. We've seen a reduction in reliance on expensive contract travel staff, but we must support facilities in hiring and keeping permanent local teams. Thirdly and lastly, the bill it releases quality bonuses. Our nursing homes met the DHHS mandated requirements for 2025 to earn quality bonus payments. LD 2131 requires the department to release the $8.1 million in earned quality bonus payments by March 1st, 2026, using funds already in the Nursing Facility Transition Fund. The legislature established the Nursing Facility Transition Fund specifically to bridge the gap during the current 3-year rate transition and to support a high quality and local direct care workforce. LD 2131 would ensure that these funds are used where they will make the biggest difference for our providers and our seniors. This bill is a critical adjustment to a complex system that, left untouched, could lead us back to a cascade of closures, a dire situation I do not wish on any other region of our great state. We cannot afford to lose the ground that we've regained. Thank you for your time and your commitment to Maine's older adults and disabled individuals. I would be happy to answer any questions the committee may have.
Thank you, Senator, for your testimony. Senator Moore.
Thank you, Senator Grahowski, for putting this bill, and I know I was a co-sponsor of it. I'm trying to think, what is preventing the 35 of the main 77 to get the reimbursement formula?
Thank you for the question, and there are others with much greater expertise than
that's what I
me,
wondered,
but
yeah.
my understanding is the guardrails were put in place to make sure that nursing facilities rates couldn't go up or down by more than certain tolerances. That way, as the rate transition happens, nobody was sort of left with the rug pulled out from under them, if you will. So those are why the guardrails exist. But it's sort of an order of operations issue. If you say, we're going to check that you're within the guardrails and then we're going to add a cost of living increase, then those facilities would get that money. But my understanding is the calculation of the cost of living increase is being hemmed in by the guardrails. Does that make sense? Okay. And somebody might do a better job of it, but that's what I have learned.
Thank you. Yeah, thanks.
Any further questions? Seeing none. Thank you.
Wow. Thanks, guys. I had all these answers for your questions written down, but
Yeah, just hand them to us.
you didn't have.
I don't see any bill sponsors here except for Senator Moore. Any testimony? Testimony and support.
Hello, everyone. Again, I'll try not to repeat everything that Senator Grabowski said, who did a wonderful job. First, I appreciate the opportunity to talk on this bill and give my opinion. Senator Ingerson and Representative Meyer. I want to especially thank Senator Grabowski and the other sponsors for their efforts related to this. I'm Michael Tyler. I'm the chair of the Maine Health Care Association, amongst other things. I'm testifying in support of LD 2131 because it upholds commitments that were made during the establishment of the new nursing home payment system. That effort, as I've said before, was an extremely positive experience, one of the most positive I've had in terms of collaboration with the Department of Human Services in the 40 years that I've been involved with long-term care, and the results were positive. My concerns are that within the system, there were certain assumptions that were made, and we're not even just over a year into this now, and those commitments, several of them are now being reneged on. This bill has three parts that were described, and those parts go to basically bringing those things back into place. The question related to the guardrails, I personally believe that was not thought through, and sometimes there's unintended consequences. In this case, it's clear that the legislature wanted to have facilities get the full benefit of a COLA without the guardrails being readjusted in a proper way. That won't happen. It doesn't, we forget pretty quickly. I mean, there were 29 nursing homes closed during the last 10 years. What we put in place collectively a year ago did stabilize things, and we really need to move forward. We don't want to go backwards and go to more closures. Senator Grabowski is from Hancock. I grew up in Bucksport. My wife's from Castine. My sister lives in Blue Hill. I was hired by the Department of Human Services to run the last nursing home in Penobscot. There are other parts of the state that have the same issues. I went to school in Washington County. There's very little services there. It's important that this bill be passed and the corrections be made that some were unintended, some, and this is fully, in my view, all of it is fully funded. This is
Tyler,
not,
can I get you to wrap your testimony up?
yes,
Okay, thank you.
I know I'm long-winded, but I do appreciate, and I appreciate you folks too.
Thanks a lot.
It is not easy. So thank you.
Thank you. Any questions for Mr. Tyler? Seeing none. Further testimony in support of this legislation?
I can't see the clock. That's why I keep going over. I need high heels. Good afternoon, Senator Ingerson, Representative Meyer, and other distinguished members of the committee. My name is Wanda Pelkey. I'm the CEO of First Atlantic Healthcare. We run 17 facilities throughout the state of Maine, taking care of 1,500 Maine Care elderly each day. Today, I'm testifying in support of 2131. This bill, as Senator Grahowski provided in her overview, does tackle three things relating to the recent nursing facility rate reform program. I'm not going to go through them, but I do want to highlight one. That one relates to the component of the bill that asks for a rate add-on of $6 a day. The reason why we're asking for that is to partially offset a scheduled rate cut of $12.85 that occurred last January, so January 1, 2026, that was based on the expectation that providers will reduce reliance on expensive contract labor from an assumed 20% last year, 2025, to an assumed 10% utilization rate in 2026. As I described this morning to the committee, we have made inroads, but we're not there yet. Plus, we have invested a lot of the money that the nursing facility rate reform program provided to higher staff raises and benefits that outpace what the rate of cost of living adjustments were. We need to maintain that level of funding so that we can continue to afford raises and benefits for our staff who are very deserving. They work 365 days a year, 24/7. This change doesn't fully restore the cut of $12.85, even coupled with the 1% cost of living adjustment. Year over year, our direct care rates, which cover nursing facility or nursing labor costs, will drop by a net of 4.5% year over year. While the $6 a day add-on doesn't completely cover that rate cut, it does go a long way with helping us provide some measure of staff increases for this year. So I urge you to support the bill for that very reason, and I'm happy to answer any questions you have for me today.
Thanks so much for your testimony. Any questions? Seeing none.
Thank you.
You're welcome. Further testimony in support?
Good afternoon. I submitted my testimony as well as Jessica Fay's testimony because she had to be on a panel. She wasn't sure if she'd be here. My name is Mary Jane McDade. I'm the Chief Executive Officer for North Country Associates. Thank you for Chairs Meyer and Ingwerson, and distinguished members of the committee for hearing about my support of LD 2131. As the CEO of North Country, we own 20 long-term care, residential care, and ICF IID facilities throughout Maine. I won't go over all of my points, but I will address one that this bill needs to address is the bonus pool of $8.1 million that was promised to our facilities as a result of the value-based purchasing and Quest program. Are you all familiar with the Quest program and what that entails? Quest stands for Quality, Equity, Staffing, and Teamwork. DHHS worked with our facilities and required that we name a quality champion. We had monthly education to attend. We started dementia care initiatives, and we also had, we were scored, all of our facilities are scored every quarter on reducing antipsychotics, and improving our quality measures to include falls. So our facilities really stepped up and embraced that. We were not only told that there would be an 8.1 bonus pool, we were even sent letters in December. Each of our facilities were sent letters to say how much they would receive, each facility. So we, of course, took that. It was a letter from DHHS, and then planned our operational budgets for 2026. And here we are the second week in February, and we've still not seen that money. So this bill is asking for a timely release of that money, as we've promised wages and increases to our staff. They've already started without us getting anything to support that. So thank you for listening to me, and I certainly can answer any questions you might have.
Well, thank you so much for your testimony and your explanation. That's great.
Sure.
Do you have anybody have any questions? Yes, Representative Fredericks.
Thank you, Mr. Chair. I'm unclear about the quality bonuses. Can you just give it a very brief 2 sentences of?
Yes. So this bonus pool was meant for all facilities that qualified. And by qualified, they had to jump through those hoops I explained, the training and whatnot. If you qualified, then you'd get a portion of that bonus pool. I think all but maybe 2 facilities qualified.
Yes, go ahead.
Thank you, Mr. Chair. So still I'm yet unclear. So your organization they qualify, they did and is it an automatic that you receive those? Or is it
That's what we were told.
So is the reality that the process is a subjective? You've jumped through the hoops, you've done the quality process.
Right.
X amount of dollars, is it negotiable? Is it a automatic?
It should be automatic.
Should be.
Yeah, if we were given that money. It really has been unclear to me as to why we haven't received that
Fair
yet.
enough. Thank you very much.
You're welcome.
Further questions? Seeing none. Thank you. Oh, I'm sorry. Representative Zager.
Thank you very much. I don't know if you're the best person to ask this, but how close to that 10% of there was going from 20% of using temp staffing to goal of 10%, and I recognize that was the department expected that to happen pretty quickly, which is where the $6 provision has come from. How close to that are where along that 20 to 10% are?
I guess I'm not sure what you're asking, and maybe in further testimony, Angela will be here and maybe she can explain that better.
Fair enough. Thank you.
Okay.
Thank you.
You're welcome. Thank
For
you.
the testimony and support.
Here. Good afternoon, Senator Ingerson, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here today to speak in support of this bill on behalf of Northern Light Health. My testimony today will focus on the challenge of patients in need of nursing facility beds that are living in our hospitals. But first, our impression that nursing homes in Maine really have stabilized with the funding resources and the new payment methodology. And the bill before you today helps sustain that stability. So we're pleased with this progress. But we continue to be challenged. In 2025, the average length of stay for a Northern Light hospital for a long stay patient in need of a nursing facility was 24.4 days. And that's higher than the year before of 18.24 days. On any given day, we have 30 to 40 patients in an acute care bed. In 2025, the long-term bed searches accounted for 9,394 avoidable days in our hospitals. We estimate that expense at $6.3 million. Today, we have 38 nursing home patients, but the average length of stay is actually over 30 days. And 30 of these patients are at Northern Light Eastern Maine Medical Center, which disrupts tertiary care throughout our region when patients can't be admitted. These 38 patients have a combined length of stay of 3,240 days, now an average of 85.3 days each. So our impression is the acute care challenge is no more the post-COVID nursing home staffing crisis, we need to close beds. The challenge we have is the loss of bed capacity, the dramatic loss of bed capacity, and we can no longer meet the demands of our population. We have counties such as Hancock County that have no nursing facilities, and other rural communities, very large rural communities and regions, may only have one. From the period of 2021 to 2025, we see that 751 nursing home beds closed in Maine. Some converted to residential care, and we are putting enormous pressure on residential care facilities to take higher acuity patients. The chronically challenged patient populations in our system, geropsych, bariatric, neurobehavioral, and ventilator care, that occurred before COVID. It has not been resolved. These patients, we generally send out of state. So we support the bill before you today, but we need to think about how do we have a rational approach to bring back bed capacity. We need a thoughtful approach of our aging population, the regions where we have beds, the regions where we have no beds, and a thoughtful plan to bring new beds back to market. And with that, I welcome any questions that you have.
Questions for Lisa Harvey McPherson? Yes.
Thank you. Hello.
Yes.
You said you send these people out of state.
Mhm.
Who pays for that?
In general, there's a process with Maine Care where we have to demonstrate we've contacted every nursing facility in the state of Maine, and no facility will accept that patient. Sometimes we go through that process 2 or 3 times, and then we obtain approval from Maine Care for an out-of-state placement in a list of facilities where they have contracts out of state.
So the taxpayer.
Mhm.
Thank you.
Are you suggesting that the plan to increase bed capacity be included in this bill?
I think it's bigger than this bill.
I would.
And you
Agree.
have a recommendation from the Commission on Healthcare Transactions in which this need for long-term care bed planning and state health planning, but specifically long-term care bed planning is needed.
Thank you. Seeing no other questions.
Okay. Thank you.
Testimony and support.
All right. Good afternoon.
Welcome.
Thank you.
Again, hello. Good afternoon, Chair Ingerson, Representative Meyer, and distinguished members of the Health and Human Services Committee. My name is Angela Westoff. I'm President and CEO of the Maine Healthcare Association, representing about 200 long-term care facilities in Maine. I'm pleased to stand here before you today to provide testimony in support of LD 2131, and I'd like to thank Senator Nicole Grochowski for sponsoring this important legislation. Before I get into my testimony, I also want to take a moment to thank the department for their collaborative efforts to develop this new nursing facility rate model, which was implemented in January of 2025. I also offer my gratitude to the legislature for making strategic investments to ease the transition into the new rate structure by establishing the Nursing Facility Transition Fund as part of Public Law 2024, Chapter 643. That transition fund was created expressly to ease the transition and to support workforce recruitment and retention. Our goal, as you've heard here today with 2131, is to make 3 straightforward course corrections to help improve the nursing facility model and keep the system stabilized. The first is to address the issue of guardrails and an unintended misstep with the calculation of the cost of living adjustments. And we've had other individuals testify about that here today, so I will skip ahead in my testimony. I would just add, though, that when the transition period is over in 2028, there will be no guardrails. And so at that point, any nursing home would be eligible to receive its full COLA. So this is really technically an artificial barrier. And there's also no new cost to this. These dollars have already been appropriated. Second is the reinstatement of the $6 a day add-on. I think my colleagues have already given you a good snapshot into that step-down approach, that in the original rates, it was worth approximately $12.85. We're seeking $6. There's no magic to that. It happened to be a round number, and it was about halfway in between. Maine lost about 15% of the workforce during the pandemic, and we've certainly struggled to recoup those lost workers. As you've heard me testify many times before about the expensive use of agency labor, this step-down approach from year 1 rates into year 2 will continue to allow facilities to ease their reliance on agency. We still have some facilities that have agency as high as 50 or 60% of their overall staff. And I would just remind you that in 2024, per the nursing facility cost reports, agency usage was 26% on average through the entire state. So while progress is being made, it's too soon to take our foot off the gas. And lastly, the 8.1 million in quality bonus payments. You all asked some very good questions about that. Year 1 was pay to participate. So as long as nursing facilities attended meetings, participated in the trainings, identified their quality champion, they would have earned their portion of the 8.1 million, and all but 2 facilities did that. Those facilities have received their letter. I understand that the department is still waiting for CMS approval for that. I would just note that the entire system has not been approved either by CMS. So it seems perplexing that 8.1 million is still holding up the works, so to speak. Even without CMS approval, the department could use state funds in the nursing facility transition funds and release that 8.1 million. I could see I'm out of time. I will conclude and say thank you for your attention, and I appreciate all that you do here.
Sure.
Thank you.
Can I just going back to the Quest? So these are, this was part of nursing facility rate reform.
Correct.
If I recall, this was, these were value-based payments that incentivized a certain
Quality measures?
Yes. Yes. So among them, a decreased use of psychotropics.
Correct.
So I just, a comment about the statements regarding these payments being jumping through hoops, which is, perplexing to me when we're talking about improving the quality of the care delivered to the individuals who are in nursing homes in Maine. So just a comment about that kind of articulating the value of this program in such a way as, it's jumping through hoops diminishes what I believe the department was getting at here with regard to quality improvements.
I appreciate your comments, Representative Meyer, and I don't think it was meant to be dismissive or somehow undermining the importance of the quality improvement programs. I think what providers are reacting to is frustration that when the criteria for meeting the value-based payments were established in year one, and those are outlined, we did rulemaking, they're in the nursing facility principles of reimbursement. It was a lot of meetings. And when facilities are particularly very short-staffed, they carve those times out of their schedule, participated in all the required trainings. And it wasn't just the Quest meetings. There are also multiple subcommittees. There's one on dementia care. There's one on culture change, right? There are all kinds of things happening. And those 3 quality measures, psychotropic medications, the importance of reducing those, the importance of reducing turnover in staff, right? Like we talk so much about staffing in this committee, and not just for nursing homes, but across all of Maine care. Those, I mean, I don't think there's a provider in this room or out in the state that would say that they don't have, that, staffing is perfect, right? Who can say that? Everybody would love to hire more staff. That's really one of the challenges that's driving this. So I think it's frustration, Representative Meyer, that's coming from, you told us what to do. We did it. We got on board. We carved out the time. We committed. And I don't think the department, and I'm sure they'll testify, right? They're not saying that it won't come. We just don't know when it will come. And I think that is frustrating because as you've heard from a couple of CEOs today, they've already given the raises. They've already told their staff, right? Like, we were also told that the 8.1 million could be used to increase your wages. And so when we didn't get a full COLA, we said, oh, but there's these other quality bonus payments coming. You can still, I'm moving on, you can still increase, reimbursement to your direct care workers. And yet we're still floating that, right? Because we don't know when that money's going to come.
And
So
could you just
I think that's the
clarify
frustration.
what aspect of Quest or the 8.1 million
Yeah.
we're awaiting CMS approval around?
I don't know what portion of it, because my understanding, again, I can't speak for the department, is that the state plan amendment has been submitted both for the whole model that's been paid out over the last 12 months, and then there's some sort of delay. And then the Quest, the specific 8.1, and I would also say it's 8.1 million for each of the first 3 years in the transition model, so a total of 24.3 million. That would be dollars that are coming out of the existing nursing facility transition fund. So part of that is federal match. And that's probably why the department is waiting for CMS approval. We would say there's already general fund dollars in the nursing facility transition fund. You could pay it out of that, assuming that CMS would approve it. And even if they don't, you have general fund dollars in that account that would cover it. 22 other states have value-based payment programs for nursing homes. I don't think this is a novel idea.
Thank you.
Yeah, of course.
Appreciate
Thank
that.
you. Thank you for the question.
Any other questions? Yes.
Thank you. My concern is that CMS thing. If they did use general funds or some type of main funds that are fully available right now, are you aware of whether or not they would in the future lose any federal match?
It's a great question. I don't feel comfortable answering it.
I'll ask
But
the
maybe.
department when they come up, and I'm sure they're against us. Thank you.
It's a good question.
Seeing no other questions, thanks.
Thank
being
you.
here
Thank you for your
today.
time.
Testimony and support?
Senator Ingwerson, Representative Meyer, members of the committee. I'm Sarah Calder with Maine Health, and I'm here to testify in support of the legislation before you today. I had a great chart that went with my testimony, and I forgot it in my haste to leave this morning, so I apologize. I will submit
Upload
it.
into the system.
But the chart shows a very stark reality, which is that there's a significant gap between the number of Mainers who will need long-term care and the number of available beds, and it's growing. And as you all know, we're the oldest state in the country. We have the fewest skilled nursing facility beds per capita in the entire Northeast, despite this. And I've shared with this committee many times, Maine Medical Center several years ago was forced to open a 42-bed nursing unit dedicated to patients who are medically cleared for discharge, but we have no safe place to send those patients. That unit remains open today, and it's fully staffed and cares for about 36 to 42 patients every day. On any given day across the entire Maine Health system, we have about 100 patients who are ready to be discharged, but we have no residential placement for them, and their average length of stay exceeds 50 days. Last year alone, we were forced to send 104 patients out of state because there were no nursing facility beds available in Maine. So not only is this bad patient care, they're in the wrong setting. Sending them out of state separates them from their family and their support systems, but it's also placing an enormous financial strain on a very fragile healthcare system. So once patients are, their acute episode has been resolved, most cases, their payer source dissolves. And so we've been able to quantify the impact, the financial impact of having to care for these patients who no longer need acute level care. And we estimate that's about $100 million annually for the Maine Health system. This is $100 million in unreimbursed care. And as we're talking about healthcare costs, this is care that we're not getting reimbursed for that is contributing to that higher cost of care. We're fully supportive of LD 2131. I think it has been said many times, this is not the panacea. We need to make some difficult decisions. There are outdated policies on the books like budget neutrality that need to be looked at. We're very supportive of the recommendation from the Certificate of Need Task Force to form a long-term care work group. But there are really difficult decisions that we need to make to meet the growing needs of our aging population. And with that, I'm happy to answer any questions that you may have.
Thank you. Questions for Ms. Calder? Seeing none, appreciate you being here. Testimony and support?
Good afternoon.
Welcome.
Good afternoon, Senator Ingerson, Representative Meyer, and members of the Health and Human Service Committee. My name is Nicole Marchese, and I'm the Public Policy Advocate for the Maine Long-Term Care Ombudsman Program. As you know, the Ombudsman Program provides a statewide advocacy for residents residing in nursing homes, residential care, and assisted living across the state. I'm pleased to provide testimony in support of this legislation. Sorry, I get short of breath reading, so. Recruitment and retention of staff, along with adequate staffing levels, are critical in providing quality of care to residents in nursing homes. Reimbursement sufficient to allow competitive wages is a primary factor in both retention and recruitment of staff. Additionally, staffing vacancies have made it necessary for nursing homes to rely on temporary staffing agencies at a much higher cost. In fact, we spoke with the CFO of a provider with many long-term care facilities across the state who told us that the agency hourly rate for CNAs ranges from $36 to $60. The hourly rate for LPNs ranges from $57 to $72, and the hourly rate for RNs is $85 to $90. While nursing homes have made progress in reducing the use of agency staffing, it is still a factor for many homes that impacts their costs. Maine nursing homes have committed to working on quality measures that include recruitment and retention of staff and reduction in the use of antipsychotic medications, along with other measurements. These efforts are supported with funds from the Quality Bonus Payment Pool included in this legislation, which you've heard much about, Quest. Thank you for your consideration. Happy to answer any questions you may have.
Thank you, Nicole, for being here. Questions from the committee? Seeing none?
Thank you.
Testimony and support.
Good afternoon. I apologize. I think my testimony is there, but I forgot to keep a copy of it for myself to share with you. So I'm going to attempt to read it. I have it right here on my screen. But this is a new thing for me. Senator Ingerson, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. I'm Jess Fay, and I'm the Policy and Advocacy Director for the Maine Council on Aging. Nursing facilities are a critical part of our healthcare system Nursing facilities provide for the complex care needs of residents every day and play a critical role not only in the health of their residents, but also in the health of our families and communities. Without them, the continuum of care for older Mainers would fail. Nursing home care, hospital care, home care, and personal care are interdependent. Each setting must maintain stability so that the entire system remains stable. Essential care and support workers are the foundation for the care continuum, and the cost of living adjustments to the reimbursement for care in all settings must keep up with rising costs, especially the cost of labor. The numbers tell a stark story. As I'm sure you've heard today, in 1995, there were 132 nursing homes in Maine, and now there are 79, with none in Hancock County. This committee has heard these numbers before and has grappled with finding solutions to these difficult problems. Even as the Department of Health and Human Services and nursing facilities partner on promising comprehensive rate reform that prioritizes quality of care and minimizes the use of contract labor, the costs to provide care keep rising and the reimbursement is falling behind. Maine's healthcare workforce crisis is not a future threat. The collapse of this workforce is happening right now. Many workers cannot afford to continue in the field. They are being driven away by wages that have not kept pace with a rising cost of living. When facilities cannot maintain adequate staffing levels, everyone suffers. Workers face impossible caseloads. Residents lose access to the attentive, dignified care that they deserve. LD 2131 requests a continuation of the Maine Care Resident per day add-on for direct care at $6, down from $12.85, as the new rate model is phased in. Given the increase in the cost of benefits, wage compression, the competition for workers from outside the healthcare sector, and the importance of maintaining staffing ratios for quality measures, this piece is critical. Essential care and support workers are the backbone of nursing facility care. They are the professionals who help residents bathe, dress, eat, and live their lives. When we invest in direct care, we invest in quality outcomes for Maine people. And I see I'm running out of time, so I will just say that cost of living adjustments must keep up with the cost of providing care across the entire continuum. And LD 2131 provides a mechanism for this committee and for the legislature to do just that for nursing homes while the department finalizes the transition to the new value and quality-based system. Please vote ought to pass on LD 2131. Thank you very much.
Thank you for being here, Jess. Any questions? Seeing none. Thank you.
Thank you.
Further testimony and support. Let me look.
3.
Yep, we have 3 online supporters. Lisa Trundy Witten. And then Louis Dougal, excuse me.
Good afternoon.
Welcome.
Good afternoon, Senator Ingerson, Representative Meyer, and the distinguished members of the Committee of Health and Human Services. My name is Lisa Trundy Witten, and I serve as a principal at Barry Dunn, McNeil and Parker. Barry Dunn is a Portland, Maine-based accounting consulting firm that provides assurance, cost reporting, and advisory services to more than 90% of Maine's nursing facilities. And for more than a decade, we've maintained a comprehensive statewide database of nursing facilities costs, reimbursement data, which allows us to analyze financial and operation trends across peer groups and regions. I won't repeat too much of the bill because you've heard it from others, but I really want to focus on Section 1 of LD 2131, which addresses the cost of living increases and the application of the guardrails on nursing facilities as it's relevant to the statewide base rate of nursing homes. So based on our analysis of the current rate data, we do believe the rate reform is moving towards its intended objective of creating a reimbursement structure that's more predictable and more adequate to sustain access to nursing facilities. The implementation of guardrails as outlined in the nursing facilities principles of reimbursement has helped many providers transition to the new methodology in a more stable and measured way. However, the current order of operations, and that's the way that the providers' rates are calculated, has produced an unintended consequence. And as you heard before, about 35 of the 77 nursing homes are not able to receive the 1% COLA in calendar year 2026. And I'll take you through an example of how this works. So the statewide direct care rate with the 1% COLA applied is $234.33. A facility with a 2025 direct care rate of $195 remains more than 10% below the statewide rate. So under the guardrails, that facility is limited to the 10% increase, resulting in a 2026 rate of approximately $215, which is still well below the statewide rate. Because the facility does not reach the statewide rate, it does not receive the benefit of the COLA that was added to that rate component. So they get the 215, the guardrail, and that's it. A similar outcome occurs for facilities whose rates are over the statewide rate. They get a 5% decrease from their 2025 cost. And, for calendar year, January 1, 2026, 35 facilities are under the direct care rate. Excluding more than half of the state's nursing facilities from receiving the COLA was not the intended outcome of rate reform. Rather, it was an unintended result of the current sequencing and the application of the guardrails, and this bill serves to correct that mistake. Without going too much into the 1285, because I think Angela and others covered that from the direct care add-on, I just want to say, as of the first quarter of 2025, agencies is still up in the state of Maine. In Franklin, or above 20% in several counties. Franklin County is still at 29%, Knox County at 32%, Piscataquis at 22%, and Sagadahoc at 21%. These are some of our more rural counties, and these also are the counties that contain those low-cost providers that we just talked about under the direct care rate.
Lisa?
So the complete elimination
Can't
of
hear me.
direct care add-on at this stage of the transition runs counter to the department's stated objective of supporting a stable and permanent and well-trained workforce. So section 1(2) of this bill seeks to retain that add-on. So in closing, I would vote yes on LD 2031, which will correct the unintended consequences in the current rate structure, improve financial predictability for providers, and help prevent further nursing facilities from closures. More importantly, it will preserve access to the care for Maine's most vulnerable residents. And I welcome any questions.
Thank you so much for your testimony. Do we have any questions? Seeing none, thank you for your testimony. Let's see, Louis Dougal. Hi, Louis.
Hello.
We are running a 3-minute clock on
Yes.
testimony, just to remind you. Thank you.
I'll make it snappy.
Appreciate that. Thank you so much.
You're welcome. Good afternoon, members of the Health and Human Services Committee. My name is Louis Dugal, and I'm the president of Highview Rehabilitation and Nursing Center in Madawaska. Highview has been a family-owned nursing facility for 47 years, of which I have been president for the majority. Highview is located in the most northeastern Maine town of Madawaska. We are licensed for 51 residents, but due to low staffing, we have had to limit occupancy to under 40 residents, which creates a disservice for the people of Aroostook County. Staffing and occupancy have been an issue since COVID-19. Even though we prefer to hire local staff, we have been forced to contract with staffing agencies, hiring travel nurses to be able to meet minimum staffing levels. Prior to COVID-19, we experienced staffing challenges, but nothing like the difficulties we've been experiencing since the pandemic, when many of our staff left healthcare employment altogether. Between the pandemic and the low reimbursement rate, which makes it difficult for direct care staff to make an honest living, many staff decided this field of work just wasn't worth it. Because of my geographic location in northern Maine, I am limited to recruiting potential hires. It's no secret the overall population in Aroostook County is shrinking, and our population is getting older, creating a double whammy of limited workers and high demand. My staff, like all other nursing facility staff, work very hard, and are very devoted to the residents they care for. The job is 24 hours a day, 7 days a week, and 365 days per year. Nursing facility staff come to work to care for the residents, blizzards or not. There's no snow days for us. Section 1 of the bill cleans up language in Section 67 of the Principles of Reimbursement for Nursing Facilities. These are important changes as they'll ensure COLA and reinstate the $6 per day add-on that will help centers like mine pay more competitive wages for employees and hopefully help retain staff longer. Section 2 of this bill requires the department to release the funds nursing facilities earned by meeting departmental requirements. We upheld our end of the bargain as part of the rate reform, and yet we're still waiting for the department to hold up their end of the bargain and release the quality bonus payments. Thank you for your time, and I urge you to vote yes on LD 2131.
Thank you so much for your testimony. Any questions for Louis? Seeing none. Thank you.
Thank you.
Wasn't there a third one?
No. Oh, two of the same person. Testimony and support in the room. Anybody remaining? Testimony in opposition to this bill.
Hello. Hi, I'm back. Hello again. Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Olivia Alford. I'm the Deputy Director of Policy and Programs at the Office of MaineCare Services. I'm here today to testify in opposition to LD 2131. The amended bill requires provisions of nursing facility rate reform be changed through emergency rulemaking. The bill also requires the department to use the transition fund to issue the 2025 quality bonus pool payments by March 1st. I'm going to read my testimony, but happy to answer some additional questions that have come up already today. Overall, the department is seeking additional time to review the cost of living adjustment proposal and discuss with stakeholders. Throughout the nursing facility rate reform process, the department has thoroughly invested in and valued our close collaboration with nursing facility providers. You've heard about that today. We've worked closely with the Maine Healthcare Association and have developed a very, very good working relationship. The successful transition of MaineCare's nursing facility payment model from a primarily cost-settled system to a primarily prospective per diem system with quality incentives has been a true achievement of this partnership. The mechanisms of how the new methodology operates and intersects with COLAs, the 3-year transition period, and ongoing facility challenges is inherently complex and requires due diligence review. There are a few elements of this bill the department would like to address outright today. First, the proposal for contract labor cannot be effective January 1, 2026 due to federal noticing requirements, which must take place prior to a reimbursement change effective date. The department and the Maine Healthcare Association have discussed how there have been overall improvements in the reliance on contract staff within Maine nursing facilities, as was the goal with nursing facility reform. While we applaud this progress, additional investment in this area lessens the planful, phased transition of nursing facility rates over a 3-year transition period to achieve that statewide base rate and will cost significantly more money out of the transition fund, which is a limited resource and necessary to cover the cost of reform. For this bill, the department also objects to the rulemaking timeline proposed, which was proposed as emergency rule within 30 days. This would disrupt high priority rulemakings, such as those related to children's behavioral health settlement agreement rules, and is not feasible. The department can advise on more appropriate timelines based on the final provisions of this LD. Lastly, the department is concerned with the proposal to pay the 2025 quality bonus pool by March 1, regardless of whether the department has received federal approval. If we did not wait for federal approval, we would be required to use all state funds from the transition fund, which runs a serious risk that funding will then not be available for other intended purposes. We do anticipate CMS approval on this new quality bonus pool payment, but making any payment prior to formal federal approval carries risk, as this is a new kind of payment for Maine and a new federal administration, I'll note, reviewing such type payments. Thank you for your time. I'm happy to answer questions.
Thank you for your testimony. Any questions? Representative Meyer.
Yes. Thank you, Olivia, for being here. So the funds in the state funds that are currently within the fund are there.
Yes.
They exist in the fund. And what you're saying is, without CMS approval, if we were to use those funds and the federal money not come our way, we would have depleted the fund that was created to bridge nursing facility reform.
Yes. So what's at risk when we use state-only dollars to fund the full portion is that we may not, worst case scenario, receive those federal matching dollars if they don't approve the state plan amendment. And therefore, we've then used all dollars out of the state fund, which again have other intended purposes to support the transition. So we are cautious about using these dollars without that federal approval.
And CMS approval, as it, can you guesstimate when we may hear from CMS?
Well, I do want to say we submitted this state plan amendment in March of 2025. State plan amendments do take some time. It is important to mention that there's a new federal administration and there's been significant staff turnover as well as a federal shutdown and all sorts of things that have happened in that time. So this is taking longer than usual. We have done some administrative moves to try to prioritize the CMS review of the quality bonus pool portion specifically to release those dollars as soon as possible. And it has been moving along. The questions that have continued to come down from the federal government are administrative, I would call them, kind of questions that are sort of standard questions, but about this new payment methodology. So nothing concerning regarding the questions. We could anticipate receiving approval as soon as next week. We've been in communication with the MHCA this entire time about this. And I do want to note that the letters that went out in December to providers noted that the release of the funds and the final award amounts were contingent on federal approval from CMS. I know because I spent many hours sending those letters out myself personally.
Go ahead.
How much money is in this transition fund? I know you were talking about the 8.1, but I think it's 3 years worth.
Yeah,
So
I
it's
believe
like
it's
24 million or something.
more than that. I believe it's 70 million, 72 million.
And what's that money? It's earmarked, right? For this transition fund. What, do you have it planned what you're going to spend it on or?
Yes. So it funds essentially the transition, the guardrails that you've heard a little bit about today, how do we get from the previous methodology to a phased implementation of the new methodology. We monitor the use of the transition fund dollars against, it is both known amounts such as the 8.1 million, but also projected amounts because we're also talking about shifting utilization, closures, mergers, other things that impact facility rates over the 3-year period. And we've been working with the MHCA to talk about that timeline to continuously review the transition fund balance and make sure that we are on target to not overspend that transition fund over the 3 years based on all of the agreements that we have made regarding that 3-year period.
Okay. Can you bring us up for the work session a breakdown of that money and how it's projected to be spent?
Yes.
And where? Thank you. Yes.
Okay, would you also be able to provide us maybe just a copy of a sample letter that was sent out to the facilities? You're telling them they're going to be getting their money, so to speak, just so we have an idea of what it was said.
Yes, absolutely.
That'd be great.
Go ahead.
Thank you. Yeah, when you get us that information, I would like, I'm not clear on why there's a transition cost, because it would have to be from an outside source because your staff's already being paid. So anybody on your staff that's involved in the transition, that's free. It's already there. So what outside resources are you in need of using that would eat up this? Because this is a lot of money. And paying the 8.1 million is 10% of what's in there.
So none of the money is for the department staff. It's all for the nursing facilities. The transition fund is purely to support the rates and the quality bonus pool going out to nursing facilities over this 3-year period, 2025, 2026, and 2027.
So it's paying rates
Rates and the quality bonus,
that we're
Cool.
not
Yeah.
paying.
right, that we have not yet paid for 2025. That's correct. And we'll pay, again, mentioned that there's the 8.1 million is a amount that's in every year of the transition fund.
Okay, I would love to see a detailed breakdown of that transition cost if you could get us that. Thank you very much.
Seeing no other questions. Thank you.
Thank you.
Testimony in opposition in the room? Anybody on Zoom?
Nope.
Testimony neither for nor against, but with additional information? Anybody on Zoom? Okay. Requests for additional information from our analysts for the work session. Seeing none, we'll close the public hearing. Well, we've got 4. Yep, so it's 2:30. We just need to go do what we need to do.
Okay.
Oh.
We're going to take a pause to caucus for the work session for a little bit. We'll be
and
back
we'll be done when we're
ASAP.
done. Do you know where your,
I was going to ask you, yeah.
yeah.
All right, where are you?
Well, right now we're going to talk to one of them.
Okay.
So
You want me to do this?
I got it.
Okay,
Starting with.
we're going to start with 2154.
Yep. Go ahead.
Okay, LD 2154, this is an act to establish the Information Technology Fund to support a state designated statewide health information exchange. This bill establishes the fund within the Department of Health and Human Services to support the operation and sustainability of the state designated statewide health information exchange, which is the HIE or the HIN. I don't want to say that again. And to meet the state's matching fund requirements to obtain available federal funding for that purpose. Funds may only be used for purposes directly related to the operation and sustainability of the HIE, and the fund is non-lapsing and consists of money appropriated or allocated by the legislature, federal funds, grants, gifts, and other funds from public or private sources. And the bill includes an ongoing appropriation of 1.8 million annually in support of the fund, beginning in fiscal year 2026 to 2027. And you did hear about how this would draw down federal funds and the proposal from the budget last year, I'm sure you will remember, and that this was looking for an ongoing, something in the baseline way to support that. You also heard about the barrier for those providers that are still not on the Health InfoNet. And without the funding, Health InfoNet would need to continue to increase subscription fees, and IT and security costs are continually going up. There are a number of providers in support, and then the department was neither for nor against. They said that they reminded you about the 2024 supplemental appropriation that was 1.7 million, which was through September 2025. This bill would allow 7.2 million in all funds of HIE operating costs to be covered through Medicaid annually, contingent to CMS approval. In the short term, DHHS included funding within the budget of the recently awarded Rural Health Transformation Program, and they recommended using federal funds for that grant rather than the ongoing general fund in the short term. You did have a question about from the Maine Primary Care Association, which is the CHCs and FQHCs, and you do have an answer there for not how much they would save, but what they would spend the money on if they could save it. And that is, and then there is obviously a preliminary fiscal impact statement of 1.8 million beginning in fiscal year 26-27 to establish the fund.
Questions? No questions? I will entertain a motion. Representative Zager.
Thank you, Mr. Chair. I move off to pass.
Second from Representative Daigle.
It's actually technically as amended because of the fiscal note.
As amended, and because the
Fiscal note only. Yeah.
Sorry?
It's the fiscal note only.
Fiscal note only. Yeah, HIN helps our system work as a system.
All right.
That's very much needed.
And we have a second from Representative Daigle. All those in favor? I'll just pass as amended.
Unanimous, all those present.
Next is LD 2083, an act to expand access to certified residential medication aid training.
All right. So the Department of Health and Human Services has authority to establish rules for the administration of medication in assisted housing, residential care facilities, daycares, children's homes, nursing facilities, and non-nursing ICF-IIDs. That already exists in Title 22, Section 42, subsection 1A. This bill directs the department to issue a certificate to an individual who has successfully completed a department-approved Certified Residential Medication Aid, CRMA, course that meets the medication administration training requirements for unlicensed assistive personnel in accordance with rules established by the department for those facilities that are listed in subsection 1A. The bill also requires the department to review the course curriculum at least every 5 years and allows the department to establish by rule certification fees and sanction fees for CRMAs and instructors. The fees range from 25 to 100 per individual per course and be valid for a 2-year period. The fees support certification activities and ongoing oversight, and the rules are routine technical. So the proponents, including the sponsor and Long-Term Care Ombudsman Program, the intent is to expand access to CRMA training, increase capacity, and alleviate some workforce challenges in residential facilities, and to ensure consistency in medication administration, competency, and instruction. And there is higher acuity in assisted living now. Many of the people in assisted living are nursing facility eligible. So accurate medication administration is critical. You heard from the department that this provides clear authority of the department to establish rules for certification, decertification, and competency evaluation of individuals who administer medications in these facilities and instructors who train and certify them. It establishes a regular schedule for reviewing and updating the curriculum, and the department will engage with the Board of Nursing to establish the rules and certification process to ensure continuity and quality. The department intends to pursue a learning management system for hybrid training options and ensure security of testing evaluation materials. There was some neither for nor against testimony, where they said the intent of the bill was not to expand access, but to tighten curriculum and oversight. They mentioned the fees, and it was unclear how the new training process for CRMA instructors will be developed, and the Board of Nursing should have authority to impose penalties and sanctions on RNs. And it's difficult to access the CRMA Train the Trainer courses, and the cost of any fees will be borne by providers. And there was a request for an amendment to establish rulemaking authority and a stakeholder group prior to rulemaking, and also some requests to include in the stakeholder group a person receiving IDD and ASD supports whose care team includes a CRMA and a CRMA instructor. There was also some testimony opposed. The department is working on an online curriculum, and that doesn't meet the needs of over half the students because of the practical portions of the course. The course currently costs students $350 to $400, and the cost is determined by the instructor. And if instructors are required to recertify, that would be built into the course cost and passed on. There are some technical issues. These are sort of nitpicky ones, actually. They don't really get at the policy issue, but they are things that you might want to fix if you're moving forward. There is some inconsistent terminology in this bill. The line 21 of the bill states that the certificate for CRMA is for unlicensed assistive personnel, which does have a definition that exists. We know what that is. And it is at the bottom somewhere. It's on the next page. Oh, no, it's just below the bullet points. But line 24 states that the course is designed to ensure competency for safe administration of medications by individuals who are not licensed healthcare professionals. I'm assuming that's the same group of people, but I'm not 100% certain of that, but it seems like you could use the same language there if the intent there is that it's unlicensed assisted personnel, which has an actual definition, then it may be worth putting that there. I'm not really sure. The fees are set from $25 to $100. That's consistent with how the APA works for rulemaking. The whole point of the routine, technical, and the fees is that they have a cap, and it has that. The question is not about that, but whether certification fees and sanction fees are both within that range, and that's not a question I can answer. If the sanction fees are the same, $25 to $100, I can sort of get my head around the certification fee, but I wasn't really sure about the sanction. And then I think this is just sort of a grammatical issue. Fees must be set by rule, ... and be valid for a 2-year certification period as specified by rule. Is the certificate for 2 years, or is it the fee mustn't change for 2 years? If the certification period is 2 years, then maybe that sentence should be 2. But these are not things I can answer, and they're sort of technical issues. But just if you move forward with it, I sort of want to know which ones I should move forward with. The thing that you did ask for at the public hearing was the Board of Nursing perspective, and there are 2 people here from over there in the corner behind Laura, who are here to give you any questions you have from the Board of Nursing perspective. There is a preliminary fiscal impact statement. It requires an OSR allocation of $272,316 beginning in fiscal year 2026 to establish one position to oversee this certification program, and includes all other funding for a contract position. It is OSR, so the OSR means that the fees go towards paying the cost, including the person, so it wouldn't go to the table.
Thank you. Any questions for our analyst at this point? Director Monteo, could you come up? Thank you so much. Hey, would you like to start, Samir?
Well, I guess first of all, if you don't mind introducing yourself and
Oh,
then.
sure, there you go.
And then just kind of if you can kind of walk us through, I know you've given us a really good kind of some additional information. If you could kind of highlight that for us and just kind of tell us where we are, I guess, with this whole process. I know there's a lot going on. And so if you could kind of start with that, that'd be great.
Certainly. Members of the committee, Senator Ingerson, Representative Myers, members of the Health and Human Services Committee. I'm Bill Monteo. I'm the Director of the Division of Licensing. And what I provided after the hearing is just some additional information for you in the memo format, pointing out that the department currently has authority for developing rules related to the administration of medications and facilities that we license, which is, as your analyst alluded to, which is in Title 22, Section 42. We also, when we were looking at this, the beginning part of that, Title 22, Section 42, subsection 1, which is the first part of this, is a pretty broad statement where the department shall issue rules and regulations considered necessary and proper for the protection of life, health, and welfare, and the successful operation of the health and welfare laws. That was determined to not be clear enough to allow us to move forward with issuing certification of individuals who are CRMAs or their instructors, or assessing a fee, which is why we put forward this bill to make sure that there was, as we alluded to in our hearing, clear authority to do what we're looking to do. Under Title 22, Section 7853, the department may require unlicensed personnel to have successfully completed a program of training and instruction approved by the department for the administration of medication that is not limited to in-service training. So this is the section of statute that gives us the authority to approve medication administration courses for individuals who are going to administer meds in non-nursing facilities.
A question about.
Yep.
So Bill, in my understanding, and this is not really saying that the department will develop the curriculum, but that any
Correct.
group or what, as long as they present it to the department for approval, is that how I'm understanding it?
Correct. So currently, the only department-approved course is one that the department developed. I think originally back in 2003, was revised in 2010. And we actually, through grant funding, obtained a curriculum developer, writer, who's updated this curriculum. But we haven't received any, but we're certainly willing to review other curriculums that are provided. And, you know, the standard is if it meets or exceeds the department's curriculum, it would be approved. I mean, that's the reality of where we stand and what the statute gives us the authority to do.
How long does that normally take for review? If we were to present one to you next week, how long would it take for review, you think?
It all depends on whether we have the qualified person to do that. Right now, we do have a curriculum designer. I would, you know, without having run this by her, I would say it'd probably be somewhere in the 2 to 4 week range to review and improve it and look at the objectives and the training process.
Okay, thank you.
Yep. And then further down on page 2 on my memo, just above where I bullet number 2, I did want to point out that we referenced the learning management system. Learning management system is a computerized web-based educational system. We have recently obtained access to the USM Muskies program that we've been working on for the testing process of the course. But what we're looking for is the fee that we're proposing to provide a more robust system that could be utilized by instructors to help expand access to these courses. For example, people that live in rural areas, people that live on the islands an instructor could use a learning management system for a hybrid training program where people could do some web-based online training and then come in and meet individually with the instructor, could interact through a chat with the instructor. It gives opportunities for expansion so that, particularly in the winter in Maine, if you had a class that couldn't be held because of the weather, the instructor could have the option of, prior to the weather forecast, saying that we'll do this on a remote basis.
Thank you,
Yes.
sir.
Go ahead.
Thank you, sir. I appreciate that, Chair. But what about the cost of that? Would that cost be passed on to the student, or would it be, who would actually, because that would be kind of costly.
Yeah, the intent is to pay for that with a $25 fee.
Okay, $25, and that was what the fee is, and that includes the test, correct?
That's the goal.
Okay,
The system that we are looking at now, there would be a $20 fee for each individual to take the proctored exam
okay,
through the learning management system.
okay.
Um,
And then the class itself would be 25? Is that what you're?
no, the certification. So for the department to issue the certification, the courses, course cost varies by program and training entity and instructor. The department does not set a cost for the course.
So that's left up to the instructor or the firm that they work for, or
Correct.
whatever.
There are numerous, there are 327 instructors currently.
Oh, wow.
They are all nurses. So the instructors or the training entities that they work for set the course cost.
Okay.
Do you know what the range of those fees is? Because I see on the analyst works at 350 to 400 was mentioned.
There was one person's testimony.
Yeah, there was one testimony related to that. I do not know.
Oh, okay. That was just one. Yeah.
But the department doesn't set that course cost.
Okay.
So the fee that we're proposing would cover the learning management system, sustaining it in the future, and the curriculum writer developer for reviewing the state's curriculum and revising and updating it, and also any other curriculums that get approved at least every 5 years, so that we don't get back to where we currently are, which is a 15, 16-year outdated curriculum where the books are no longer available.
All for $25?
There are roughly 12,000 CRMAs and 327 instructors. So we're not looking for an exorbitant fee. We're only looking to cover
I
the cost of the
appreciate that.
program. So,
Absolutely.
yep.
Okay,
And
thank
we
you.
believe we can do that.
Representative Zager.
Thank you, Mr. Chair. I appreciate it, Director Mateo. 327 instructors in Maine. I assume that you worked with some of them to make these plans?
We worked with some of them. When we revised the curriculum, when our contractor updated the curriculum to current standards, there was a group of instructors that was brought in to give feedback on that curriculum. And then we are at the point where, now that we have a learning management system for the testing process, we'll be doing a pilot of the curriculum and the testing process to see if it will do what we really believe it will do. And I have spoken with Angela Westar from the Maine Healthcare Association just prior to this, saying, because she's expressed an interest to be part of the group looking at that. We're certainly willing to bring that. The intent is to have CRMA instructors do the pilot, provide feedback to our curriculum developer or writer, and then go forward. I do want to point out that the actual training program and curriculum is not really part of this bill, other than the utilization of, or the requirement that we would review and revise and update it with every 5 years. The focus of the bill, as we are looking for, is really to get clear authority to assess the fee and establish the certification process for the individuals. And that ties into kind of when I looked at the purpose of the bill and present that to you, I kind of outlined these points. But also in addition to the certification of individuals and instructors, the bill does require us to review the curriculum. So if other entities provide a curriculum and it gets approved, we would be reviewing that curriculum. And if it's not updated, we would request that it be updated, or it would no longer be approved. The department, as I mentioned in my hearing, has engaged and will be engaging with the Board of Nursing, primarily on the instructor criteria for, what does it take to be an instructor? Because currently all instructors for this training program are nurses. Administering medication safely is really a lot more than just taking a tablet out of a bottle and giving it to people. There's a lot more intricacies.
Especially today.
Correct. And this is really the goal of this, is to, one of many goals, but I mean, what we're really looking to do is improve accountability at the individual level and try and address the medication errors. Facilities are ultimately responsible for what happens within their facility, but we're looking to have a process where if we certify an individual, We could then decertify them if it was appropriate based on significant and egregious medication errors so that they don't go down the road and work somewhere else. Sanctions that we've referenced would be on the certification. It would give us what we're looking for in rule is the ability to impose sanction really on a progressive process. Requiring somebody to do re-education and training prior to their certification expiration would be a sanction if it was deemed appropriate. So if you had somebody that was making regular errors on transcription, that we could require them to do retraining and education and transcription. We're not looking to overly fine or penalize people and diminish, the ability of people to work. We're looking to address accountability for errors and have a process to ensure that people get training and education that they need. The learning management system, we believe, will expand access because it gives the instructors a lot of options. It helps address and make training programs more accessible. The other thing that we think it will help us with is in increasing the number of train-the-trainer programs. Currently, to become an instructor as a CRMA, there's only 4 courses on average a year. They're limited to 12 individuals, and they're predominantly held here in Augusta. With the ability to have a learning management system, we could expand access to that much more. And what we'd like to work with the Board of Nurses on is the criteria to become an instructor. Some of the train-the-trainer programs, for example, could be reduced if you had instructors that are currently CNA instructors and already have training and education and teaching the adult learner. Right. So a lot of that would be developed through that rulemaking process. And just to clarify, I know there was some discussion about sanctions. The department would only sanction the certification that we issue. That's the only authority we would have. So if we certify an instructor who happens to be a nurse, if we're sanctioning that instructor, we are only sanctioning that instructor certification, not their nurse license. And that's part of what we will be engaging with the Board of Nurses on is when does it warrant a referral to the Board of Nurses for their consideration. So.
Yes, Senator Moore.
And that this is more hypothetical, but if we do come out with a new curriculum, I know there's always a little bit of a lapse of someone has to take the training and they may not be as familiar with it and say they fail the first test around or they pass it, but they have some weak spots. Would that be a reason to decertify them?
Not necessarily, not in and of
Give them a
itself.
little bit of a break or something, yeah?
Yeah, and that's sort of the thing that we look to engage in the rulemaking process. Our intent, and I apologize for not making this clear, but our intent is to hold listening sessions, like what Director Saucier used to do, and really to hold at least 2 sessions with the individuals who are currently CRMAs. Once we have authority to say, we now have authority, we're going to engage in rulemaking. Before we do that, we want to hear from you as the individuals. What do you feel is reasonable for criteria to become certified? We will also do that exercise with current instructors, and we will do that exercise with other stakeholders like the Ombudsman, the facilities, Maine Healthcare Association, the other associations that represent ID clients and others that use CRMAs, so that we get input prior to rulemaking. And then we'll be working with the Board of Nurses, particularly on the aspect of the instructor criteria, because we do plan on maintaining a requirement that the instructors be nurses, because one of the ways we think we can address the issues of medication errors, in addition to facility rules and changes, is really increasing clinical oversight and personal accountability to the individuals that are doing this.
Representative Zager.
Thank you, Mr. Chair. So, Director, so it sounds like you're describing like a stakeholder group or a series of them.
Well, not really stakeholder groups. What we're planning on doing is internet-based, whether they're Zoom or Teams, but listening sessions where we engage with the communities. Like, for example, we would do a session with all the CRMAs and we would notify them, those that we have emails for, or we would send out notices to the facilities. On these dates, we are going to hold a session to get your feedback on what you feel is a reasonable and appropriate criteria for a certification for you to practice.
Would at least one of them be overnight? Because some of them work overnights. Half of them do.
I hadn't considered that, but yeah,
would you consider it?
Yes. I mean, I don't know that it would be overnight, but it would certainly be either early.
Yeah, evening. Yeah, it doesn't have to be 3 a.m, but
yeah.
Something to try to not have a
Traditionally, sir, we do those during the business day, just like
Yeah.
with other hearings and sessions.
But understood.
But yeah, and I think that would be something that I'd reach out to Maine Healthcare Association to see with their employers. If we have enough that warrants doing it, then I personally am not opposed to doing it. I'm willing to, I used to work nights myself in the ER. I'm willing to certainly host and have it as a recorded session. As long as I have my coffee with me, I'll be good.
Thank you. Any further questions? Director Monteo?
Thank you. Thank you very much.
Thank you. Thanks so much.
You want to call Board of Nursing?
I know there was a request for the Board of Nursing to be here. I don't know if anybody has questions for them.
Senator Anderson, would you like me to address the questions that? came
Oh,
up?
yes.
please.
Would you like those addressed now, Anna?
Persnickety ones?
Yes.
Yes,
Yeah,
please.
go ahead.
Go for it. Is unlicensed assisted personnel and not licensed healthcare professionals the same?
Yes, it is.
Okay. The $25 to $100 certification fees and sanction fees, are they both within the range? The sanction fees are the same?
Correct. We're, again, we're not looking to overly penalize. We're looking to just establish a reasonable.
And then the fee set by rule, that makes sense, obviously. Valid for a 2-year certification period. Surely you mean the certificate is
Correct.
first? Yeah, okay. So that should be 2 sentences.
Yes.
Got it. You don't write it. It's not your fault. Thank you.
Okay, great. Did
Any
you want to
other-
talk to Board of Nursing? Okay, good. Now representatives from the Board of Nursing
Yeah.
come up, please, and introduce yourselves.
I just give it courtesy there.
They're both here, but one's coming.
No, so, okay.
Go ahead, introduce yourself.
Good afternoon. My name is Amanda Boulay. I am the Assistant Executive Director with the Maine State Board of Nursing.
Welcome.
And thank you for coming. I just really wanted to kind of just hear your thoughts on some of the conversations we just went through right now and how you all feel about. It's kind of, we're looking at it a little bit of a different angle than what we first thought it was. So I would appreciate your comments on that.
Sure. I think, first and foremost, just to put out there that the board itself has not reviewed this, right? And so certainly don't want to speak for the board. However, given, the information that's in it, the intent of it around, increasing patient safety, ensuring that there is collaboration with the board, ensuring that we are holding CRMAs and nurses accountable. And also this ties in with a rule that we have proposed in HCIFS that's happening right now, 2166, which is specific to delegation and does include CRMAs and medication administration and how that is delegation. So the board is happy to collaborate. I think that, to Bill's point around, this is around managing and regulating a group and ensuring safety. That's the same mission that the board has, right? And so it would make sense that we work together on that.
Great.
Yeah.
Thank you.
Appreciate that very much.
Yeah.
Any further questions? Seeing none. Thanks so much for coming.
Thank
both
you.
of
Thanks
you.
for taking your
Appreciate
time
it.
and coming.
Thank you.
Any further questions? Yes.
No, no, I wanted to just interpret something.
Oh, yeah.
We don't want, I forgot to ask about that.
Yeah. Why don't you then?
Yes,
I think you need to ask about it. Yes.
Director Monteo, could you come back up? We have another question for you. Thanks.
Thank you. I'm sorry.
worries.
I meant to ask this question already. I know that when we were looking at the fiscal note on it, it was showing that it would establish one program services to position to oversee the department certified certification program. I have a little bit of problem with that. Can it not be absorbed within your department that you already have with the people that you have?
It actually is the position we already have. The position that we have is a limited period position that it runs out. The grant funding for that runs out at the end of 2026, the calendar year.
Okay.
So what we're looking to do is
Make that.
convert a limited period position to a permanent position and utilize this funding to sustain it going forward.
To sustain it. Okay. Thank you for the explanation. I appreciate that.
Okay. Do we have any further questions? If not, I'll ask for a motion.
I'm not gonna make it, my name's on the bill.
Okay,
It is your bill. It's kind of hard to forget.
I can make a motion. I'll move that we ought to pass as amended on this bill. Is it amended or is it just with a
Yes.
memo?
Yes.
We
there
did do
is.
some amendments.
Yeah,
But it's
you gotta
just
make
a,
the-
it's just a little one
Okay.
plus the fiscal, is that right?
Yeah.
Yes, then I would move on to pass as amended. Need a second? Second. All those in favor? It's great. Okay, moving on to LD 2123.
All right, this one's mine. LD 2123 is an act to improve dental care access for children by modifying the main care reimbursement methodology for the provision of anesthesia for certain dental services, and this is the speaker's bill. So this requires, it's an emergency bill. It requires DHHS to provide supplemental payments to providers when reimbursing medically necessary deep sedation or general anesthesia for dental services provided to a child at an ambulatory surgical center if the patient population receiving dental services at that ambulatory care center consists of at least 50% main care members. It requires DHHS to amend its rules to provide that a time limit may not be imposed on the provision of reimbursable anesthesia services for comprehensive dental provided to a main care member who is a child, as long as those services are medically necessary, and to set requirements for the reimbursement rate and billing processes applying to anesthesia for comprehensive dental services provided to a child. There is an amendment to the bill. I don't know that it was discussed much at the public hearing. It is the first document in your packet, and I will talk to you about it as I go here. You heard a significant amount of testimony for this bill. Proponents of the bill noted that children covered by main care often face significant delays in accessing dental care, and in particular when anesthesia is required for that care. Children who need deep sedation or general anesthesia for dental work include kids with severe dental disease, extensive treatment needs, severe anxiety or trauma histories, very young kids, and kids with developmental, behavioral, or medical conditions that make that routine care very difficult to provide in an office setting. While in-office sedation works for certain kids with dental needs, general anesthesia is the only option for some kids. It was noted that lack of delays in care also exists for adults, and in particular those with intellectual disabilities or autism who often need dental services under anesthesia. The current main care reimbursement rate, dentist who testifies noted, does not cover the cost of care when anesthesia is needed. The hourly rate providers are reimbursed by main care for anesthesia services is less than the hourly rate of an anesthesiologist, which forces the dentist to use funds to provide for the dental work to cover the cost of anesthesia, leading to a net loss when those services are provided by the dentist. This bill would help 2 ambulatory care surgical centers in the state provide care to more kids with main care, and could also incentivize other centers to create a sustainable payer mix. The department testified against the bill. They noted that dental services is on its rate review schedule for 2026. That schedule is included in your packet. They also noted that the bill's limitation of supplemental payments to ambulatory surgical centers with 15% or more of a main care caseload could present an operational challenge because the department doesn't collect data on non-main care members on that payer mix. They also noted that the bill precludes the department from limiting the number of units and time billed for dental anesthesia. They did note that there is not a limit. Right now, there is a process to get authorization if you go over a certain time period. They finally noted the limitation of the enhanced rates to anesthesia services provided in ASC is unusual. The anesthesia services identified in the bill do not have ambulatory fee schedule rates and are reimbursed as professional services and not included in the ASC fee schedule. I did want to bring up a few things I noted as I was reviewing this bill. So first, the amendment. So the amendment is fairly straightforward. So it adds 2 dental codes. These are codes that are used when a dentist bills a service. So if you look at the fee schedule for main care, which you have a link to in your packet that you were emailed, and you also have it printed out here for you. The dentists use those codes for specific services to receive reimbursement. So the original bill included two codes, D9222 and D9223. Both of those are deep sedation, general anesthesia. The first code is for the first 15 minutes. Second code is for subsequent 15 minutes. The new codes, D9224 and D9225, are for an administration of general anesthesia with advanced airway. Again, for the first 15 minutes and each subsequent minute. Those are brand new codes for 2026. So they're not yet included in the fee schedule, but they're new. So as noted by the department, the bill limits this enhanced rate to dental services that meet three sets of criteria. So first, the patient has to be a minor, a child. Second, the procedure must take place in an ambulatory surgical center. And third, the ambulatory surgical center must serve over 50% of main care members. So this is a bit of an unusual sort of limitation here, and that it would likely require CMS approval, and it could be, and main care could speak to this, probably a little complicated to implement because of those parameters are not kind of the usual way that things are paid for. Also just, and this is more technical, section 1 of the bill is allocated language. And that allocated language doesn't limit the payments to pediatric patients. If you read it, I think that was probably an oversight in drafting. And I think you actually don't need the allocated language if you, it doesn't add anything to the bill. I think it was probably there to give the committee the option to keep the bill in act if you wanted allocated language, because you remember that weird rule about you can go from an act to a resolve, but you can't go from a resolve to an act. So I think that was probably just placeholder language. Again, the bill is an emergency preamble. It would be very difficult. Actually, it's probably not possible for the department to do the work that is needed to do this before July, which would make it an emergency. So, and they can speak more to that too. So again, rate setting, just the department did note, as noted, but this bill wouldn't allow them time to go through the usual rate determination process, which is of course described in statute under section 3173J, which you are very familiar with by now. So you had asked about the current reimbursement rates. I did include the fee schedule. The current maximum allowances for the two codes that are covered is 153.17. You have that full fee schedule there. And Senator Moore, you had asked about managed care. So if you recall, so we've had a number of bills talking about managed care, and one of the subpopulations that we've talked about applying managed care to has been dental. And there was actually a report that was done for the department on just a couple years ago on a managed care dental carve out. I did include that report in your packet. So they did look at that. Right now, there's not an active pilot to do that, but that is something that has come up again over time in this committee. So you have a number of things in your packet. You've got the main care benefits manual language. You've got the fee schedule. You've got the rate setting 3173J. You've got the rate determination schedule, and you have that managed care report. You do have a preliminary fiscal, which indicates general fund appropriations of $29,993 in this fiscal year. But again, that's probably not something that realistically could happen. And then 121,429 in fiscal year 26-27. And I think that is what I have for you.
Representative Zager.
Thank you, Madam Chair. Thank you very much, Sam, for the analysis. You mentioned that CMS approval will be required as drafted. If we were to kind of make it more generalized and less less specific with these criteria, would that require CMS approval? If we did not have those three conditions applied?
I think I think it depends on what you're doing. I mean, rates need to be approved by CMS, so there's still a process that the state needs to go through for rate approval. I know Deputy Director Alfred's here and could speak more to that. If you
Yeah,
want
so-
details on that.
And I want to bring the department up, but I would also just like to suggest that the committee consider removing the criteria and expanding the dental sedation rate across the board. So
I agree,
instead of-
because I had a real problem with the only limiting it if you had more than 50% main
Right.
care, and it was for children only. I
Right.
mean, I have an adult child that has to have anesthesia because we
Right.
can't even, her anxiety is so high.
Right, so
So I'd like to see it expanded as
we,
well.
we've often heard over the years on this committee, the difficulty that individuals with ID and DD have with dental care and the need for sedation. I would propose to the committee that we expand the rate for sedation to include those individuals as well. I also, I would also like to remove the time limit language.
The cap.
The cap, yeah. And I guess bringing the department up to discuss what I've just asked the committee to consider might be helpful. Thank you. Big day for you, Olivia, and HHS.
Now you're gonna really get after Michelle, so you next time you're gonna.
So, just thoughts on amending the bill, and then some discussion on, what that rate might look like if, we were to expand it, across the board.
Yeah, thank you so much. I'm Abby Stivers, Director of Government Relations. Thank you for having me up. Let me introduce yourself as soon as.
Okay, Deputy Director.
For a lot of issues, we do ask that we, consider rates as part of the process. But in this particular case, and I'll let you speak to that, we do have additional information that we could implement for this that would be across the board and not just specified to this particular population.
Yes, I think what you're discussing now certainly is much more possible for us to administer as a kind of a short-term way to address a concern regarding these rates. We do want to hold that there would be a full dental rate determination after this, which is scheduled, as Sam said, for 2026 to begin anyways. And certainly not having all the caveats of who these rates apply to is part of what makes it easier to implement. And also to the question of CMS approval, we do still need to seek CMS approval, but much quicker expected review and approval when it's not kind of a situation where you're asking for multiple caveats to when an increased rate is applied.
Thank you. So this is section 25?
Yes.
Okay, and the caps, the time.
The limits on anesthesia services. Are you asking if you'd like to remove the caps or keep the caps?
I would like to remove the caps. Yeah.
Yeah, and I've discussed this with since this bill with the team and medical director as well, and we are open to that and removing the caps on this service. We do have a prior authorization there to make sure that units are appropriate, but we can remove those caps. We commit to that.
Go ahead.
We, as a committee, we have worked so hard on the rate. We heard this all day, I'll tell you today about that. And so that was one of my concerns about the bill originally, was that, wait a minute, we've got the schedule, it's on the schedule. But as I'm understanding, then you're far enough along that this portion has already been done as far as the rate review goes. Is that correct?
Well, it's more, so it's, just have to do a quick history on what's happened with the dental rate determinations, which may help this conversation is, so under dental services, back in 2022, we had done a full rate determination and established how rates would be set. Because they were benchmarked to commercial payers, we were due to do a reassessment of that methodology after 2 years. At that time, we determined that the methodology, if we had continued with that, would have reduced rates for several services. And we collectively did not feel that that was appropriate. And so we basically held rates steady at that time and committed to doing a full rate determination as soon as possible, which is now we are in 2026, and that's what we're doing. So for these rates, what the option here is sort of just a minor adjustment that's sort of within the same framework as how we originally intended this to be. It would still result in a rate, I believe, that's over $200. So not as high as the bill laid out, which but is more aligned with how we would do this kind of short-term adjustment. The other, and then this feeds into the work that we essentially have already been started with the rate determination for dental services.
So it wouldn't be a long drawn out, typical going through. You've already done all that.
No, we haven't done the full rate determination, but we are.
No, but I mean for just this section.
For just this section, yes.
Yes.
This section is
done.
Yeah, we've crunched the numbers. We could do it this way again for the short term, and then we would do the full rate determination.
Right, I understand that's good because it'll take a lot longer to get, but this portion of it is done enough that we could go forward with it and still be part of the whole rate determination.
Yes.
Perfect. Thank you.
Did you have a question, Representative?
Well, just a comment. Having been on the provider end of things, I'm very happy to see these changes because I believe they're a whole lot more workable. They're more equitable. We're going to serve more people that way. So thank you.
Thank you. Yes.
Abby, for the record, could you tell us what the new rate would be and approximate note for this?
So I want to be clear that I think that if the committee would allow us to, we'd like the opportunity to work with the analyst on the specific language of exactly what you're putting in. Some of the previous numbers that we've run about doing this, comparing, an across the board raise versus the speaker's bill, which I believe the fiscal for the state portion was somewhere around 40,000. This would be somewhere closer to 240, 250,000 for the work that we're doing. But for the details, Representative Lemlin, I would just want to make sure that we were working out exact language with the analyst, but those are the base calculations that we've tried to run while we've been doing this work in the background to find a way to do this in a way that MaineCare would actually be able to implement
Right.
more fairly.
That's all I wanted was the ballpark and what's the what's the rate? Is it 203 something? What did you show us?
I
know
yes,
it's
and
not
these
100%,
are our
yeah.
calculations in terms of trying to figure this out, but we do estimate that the rate would be somewhere around $203. So it would be a raise for all providers, but less than the original bill sponsors language.
Okay, thank you. That's all I wanted.
Any other questions? Any questions for them, for us before?
I think I've got enough that I can. work
Okay,
with.
so I would like to make a motion. I would,
Just clarify, do you want the two new codes included as well?
Yes.
yeah,
And does that?
Could we speak to that for just a moment if that's
Yeah,
all right?
yeah.
So, yes.
Well, that's so I think what you're speaking to right now is just changes to deep sedation, general anesthesia, including the two new billable codes under just that area.
Correct.
Okay, and not addressing any other dental codes or services.
Are you okay with that?
So I think that we already,
Well, I just want to make you aware that part of what's going to happen with dental rates as currently planned, due to what I was just explaining about the history of the dental bills, the dental rate determination, is that there are two codes that will be facing a small, or not small, but a rate reduction on 7/1/2025 because we sunset the we established this hold. We will not reduce rates until we do a rate determination, and that is set to expire at the end of June. So we thought that you all were interested in those two additional codes that were for other services, and those are contributing to the 200 to the state shared number that we just shared with you, so just wanted to make that right. But if we're just focused on sedation, then we've covered it.
Okay, you just lost me.
Yeah,
Yeah.
you lost me too.
We're talking about other
So,
codes.
yeah, we're talking about, yeah. What are those two codes?
24 or 20.
I know the numbers, but what do they
So
apply
the
to?
two new codes are just, they're deep sedation.
Yep.
Oh, with that area, yeah.
So, and I'm sure Dr. Dangle can tell us what that meant, but I think this might be a separate issue, correct?
Mm.
I think we're
Okay.
talking about two sets of codes. So the codes
Okay.
I was talking about were the two that were in the amendment, and I think it's clear those were.
Okay, those are the
included.
ones that we are focused
Those are
on.
included.
Yes.
I think this might be a separate issue. Yeah,
Yep.
Okay, so we're talking about the 4.
the four codes.
Yeah.
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 All right, so the two codes in the amendment, our OMS is fine with including, and I think that we already hit Blitz.
Okay.
Yes, just speaking about which codes in the.
Okay, we're good.
Okay. I would move ought to pass as amended on LD 2123.
I'll second the motion.
There's a motion and a second. Any further discussion? All in favor? Thank you. Thank you.
Thank you for all of them.
So we'll work with the department and bring it back.
Please.
Yep.
2136.
Great. So the last one for the day is 2136. This is an act to support victims of trafficking in Maine in response to federal funding cuts. This is Senator Nangel's bill. So this bill provides one-time funding of $317,000 to support Preble Street anti-trafficking programs in order to replace federal funding that has been delayed. The bill, proponents noted the bill is a response to the unexpected delay of federal funding from the U.S. Department of Justice's awards for victims of crime. The funding expired in the fall and the next round of awards has been delayed. Typically, applications for this funding open in April, but in 2025, the call for applications was delayed without explanation until the end of December. Preble Street's anti-trafficking services program has been impacted by these delays, and they have had to waitlist survivors for services. They've averaged about 20 folks on that waitlist. The bill would provide a one-year funding bridge. DHHS testified neither for nor against, noting that they were not sure if the funding is still needed. Though the application process for the grants was temporarily delayed, it has now been issued. While the department is supportive of the efforts to assure continuity of services, they're concerned about establishing an expectation that the state will hold financial responsibility when federal funding is interrupted. So background information, the Federal Department of Justice Office for Victims of Crime provides grant funding for victims of human trafficking. These 3-year grants expired in September. The RFP for the new cycle was delayed for approximately 8 months in 2025, which resulted in a lapse in funding. Those were released on December 30th, and I believe the grant application closes in mid-March. This bill's a little odd in how it's drafted. And the bill itself does not mention Preble Street anywhere except in the summary. So the summary holds no legal weight. The summary is just a summary. It's not anywhere. While it could help a court decide legislative intent, it really should say in the bill what you're doing. It's also a little unusual to have a bill that directly provides funding to a specific entity. And I know we've had this conversation here before. It's not that it's not allowable. It's just a bit unusual. And this would bypass, of course, the usual procurement process.
So we would need but notwithstanding.
I think
the usual in order to
be
make it
very
clean.
safe, you might
Okay.
not withstand the procurement laws,
Yep.
which we could do. And then somewhere it should say that this is meant for Preble Street. And we could do that just by adding unallocated language before the ANA section there. But I think it needs something there. Yeah.
I stepped out when you were discussing sort of the timeframe for the federal grant funding and
Yeah.
why we have this bill at all. Where is that money now? And
So it's still my understanding, and I'm sure folks, I know there are folks from Preble Street here, who correct me, that it is still in the RFP stage. So it's not, they haven't finished, the federal government hasn't awarded yet, and it could be a bit, I suppose, until those grants are awarded because
yeah,
they're still. in
and
the-
refresh my memory, the reason why we've got this delay and this potential
Yes, it's so
this
the
issue
grants-
is that the application process was sort of kicked down the road
about
and
8 months. It
Yeah.
was delayed. Yeah.
okay.
Yeah.
Okay. The funding though, is there somewhere.
The federal government has put out the RFP. They just
Okay.
are quite late in
Okay.
issuing the awards.
Okay.
Yeah.
And if I recall from the public hearing, lacking funding from the state, the services that are currently in place for individuals who have lived experience with human trafficking, that program would cease.
They've had to waitlist people. I think they're doing the best they can at the
Yeah.
moment, but they've had to waitlist people.
Okay. Okay. Rep. Sager.
Thank you, Madam Chair. I've seen up close and take care of people who are very deeply affected by this, and I cannot, in good conscience, let more and more people be added to a wait list. Recognize that this might not be needed, but I would move on to pass as amended with the provision that Sam suggested, just by the A&A section, to make it clear what the intent is.
I'll second.
Okay. There's a motion and a second ought to pass as amended. Any discussion? Yes.
And I appreciate your comments too, Dr. Zager. I really do. And Representative Zager, I'm sorry. And I agree with you. I mean, there are victims of trafficking that it's horrendous. And it really does bother and hurt my heart with that. But I feel like we're going to set a precedence. There are monies that are going to come. I mean, it's a little low, a little slow, and but the RFP is out there. And it will be a matter of them actually filling out the paperwork, which they're quite familiar with doing. They've done it before. And that the funding will be there instead of us having to come up with 317,000 as a one-time fund. Somebody else, what's next? Somebody else is going to come back and say, well, the RFP is delayed, the grant's been delayed, we need some funding from the general fund for that. So I see this setting a precedence that would be very hard for us going forward. My suggestion, I know there are a handful of other locations that actually do similar services. They're not exactly like Preble Streets. However, they do fundraising on their own. I hate to call it like a bake sale, but they do fundraising. They do the tree decorating and all that kind of stuff. So maybe in the interim, that would have been an opportunity to be able to cover that shortfall temporarily. But so I cannot support the bill as it is. Thank you.
Thank you. Representative Daigle.
Do we have any idea how much longer?
I imagine Preble Street has an idea. I am not sure.
Okay.
Go ahead.
Yeah.
Would you like to come up?
So if awarded, funding would begin on July 1st, but it will not offset the cost of the last 9 months of services we've been working to provide without funding for survivors of human trafficking.
Could you just introduce yourself? for the record?
Apologies,
Yeah.
sorry. I'm Haley Veruso. I'm a licensed clinical social worker. I'm the director of anti-trafficking programs at Preble Street.
Welcome. Thank you.
Apologies.
Okay, so you've been operating without the required funding for months,
For 9 months, that's
Yeah.
right.
but still providing what services you can.
That's exactly.
And then starting a wait list that is growing.
That's growing and has a ripple effect for both minor victims of trafficking and adult victims of trafficking.
Yes, so children.
Children, yes.
Yes. Thank you.
Yes.
Appreciate that.
Can you just summarize for me and for the committee what services you provide?
Sure. So
that haven't had funding to provide them?
we provide intensive case management to survivors of human trafficking. And so essentially what
Okay.
that is we partner with survivors to support them in exiting dangerous situations, support them in relocating, establishing safety, security, coordinating with basic need resources, ensuring folks have access to medical, mental health, and substance use disorder treatment. All of our work is survivor-centered and guided by our clients.
And this work involves minors as well?
Absolutely. Yeah, minors comprise a third of our client load.
Okay. Thank you.
And yes, Representative Daigle.
Will this funding that's coming in be like a catch-up payment? Or will it deplete what comes in the future?
So we have been operating a wait list, as I shared before, and that wait list grows. And so that wait list is growing at a rate in which the federal fundings, if awarded, would not immediately be able to catch up to. So what this funding will allow us to do is to support the 20-odd people on our wait list who have been needing services, and then also allow us to continue our work of outreach services, because without that, we are missing so many victims of trafficking, but have had to limit how we outreach folks because we can't in turn provide services. So if anything, it will allow us to recalibrate and reach equilibrium again.
I think somebody mentioned that there are other organizations doing similar type of things. Are they in the same position financially? And if so, how are they getting by?
Preble Street is the only recipient of the Office of Victims of Crime Enhanced Grant for Survivors of Human Trafficking. And while I have deep respect for my colleagues involved in the anti-trafficking movement here in Maine, Preble Street is the only organization that provides dedicated services to both labor and sex trafficking victims. Labor trafficking is a growing issue here in Maine, an issue that is often underreported and undersupported. And victims of labor trafficking often need to have an intersectional issue of sexual violence or domestic violence to access services, or in our program, we support across the board. So our whole is felt right now.
Further questions? Thank you. Thank you for coming here. Any
So
further
there's a
comment? We did have a motion.
Yep, there's a motion and second ought to pass as amended. All in favor? All opposed? And your report?
Not to pass.
Thank you. We've got lots of language review, correct?
Yes.
It's too late for me to go home now.
Yes.
All right, Anna and I both have some, I only have a couple. Anna has more than a couple.
That just means he gets his work done earlier than I do.
So the first is for the PTP bill, LD 1989. It's the fiscal impact statement, and you don't even really have to see it. It's no fiscal impact, no fiscal not required. So
Oh, we love
I
that.
handed it out, but
That's why you got that one out easier.
so the second one is LD 1416. If you'll recall, this is an act to require DHHS and human to immediately take custody of persons sentenced to mental health facilities that may not include county or regional jails. You had asked that you wanted to maintain or keep the commission, which was in the proposed amendment. You had wanted to insert an emergency preamble, which I've done. There was a request to change the title of the commission to the Commission to Study the Placement of Certain Individuals Committed to the Custody of the Commissioner of Health and Human Services. It made that title change there. And then the other change was to the membership. We've added a few members. the department had requested to add the superintendents of Dorothea Dix as well as Riverview or their designee. So I have included those at 4 and 5 on the list of folks in the commission. Also the director of the Maine State Forensic Service or designee. There was also a request to add another member with lived experience. So instead of 1 member with lived experience, there are 2. That's at number 9. And additionally, it was brought to my attention, this isn't reflected here, that there might have been a desire to add a member who was in representative older
Yes.
Mainers. I was reminded of that this morning, so I can add that if you would like to add that. I don't think you need to revote it.
Yeah.
But if you want me to add that, I will go.
I would definitely like you to add that. That would be great. Thank you.
Is everyone okay with that? Adding that?
Sounds fine to me.
Okay.
Any issues? No issues.
Okay. I will add that, and so you will have 21 members, which is good because it's odd.
And no, I like an odd number.
That you?
Yeah.
You're all done.
And I think that's everything else is as you had seen it in the draft. And I'll bring you the final back when it goes through the revisor's office, but other than that, all set.
If you want to do yours.
Okay, this is the first one for my stack, but none of them are hard. So this is Senator Ingwerson's bill, the resolve to establish a working group to prioritize wellness and mental health resources for heritage industries. You had a few changes. You wanted a specific member for logging, which also made it 12 rather than 11. And then the changes in the duties were to review existing mental health primary care and wellness resources available. And then consider the impacts of individuals in heritage industries living with serious brain injuries and traumatic brain disorders and traumatic brain injuries, and also the identify issues facing migrant workers.
I've received, since we passed this bill, I've received some feedback from a couple of stakeholders, among them the department, feeling that they'd like to go back to having an odd number of commission members. And they, even though they said forestry logging, they feel pretty strongly that a representative of state's forestry sector isn't really needed and isn't compared to logging, which is, you know, first line workers, folks with the chainsaws, people driving the trucks. That's the kind of independent work where that stress is felt, and never really meant to include forestry. So I just wanted to suggest that we reconsider and strike the forestry. This is coming from the Department of Agriculture, Conservation, and Forestry.
Representative Zager?
Thank you, Madam Chair. I move to reconsider.
Okay. Is there a second?
I'll second.
All in favor?
I just have a question first. Oh, I guess I can on the reconsideration. Never mind.
All in favor of reconsideration? Okay, so we are reconsidering what the bill's sponsor has suggested, that we remove an individual from the forestry industry.
Okay, so you're keeping the logging.
Keeping
Keeping the
logging,
logging,
yes.
removing forestry is any discussion?
I guess I'm just trying to remember why we talked about splitting it out.
I think I don't know, someone made the
I know,
suggestion in the committee, I
The
believe.
logging people asked for it at public hearing.
Well, and the logging, I definitely
Logging,
agree. I mean,
yeah.
they are, like you said, they're out there with chainsaws and they're doing all that. I just couldn't remember why we were splitting out the forestry and the logging. What was that about forestry? And
Well-
that was the thing.
If we can't remember, it must not have been too compelling.
With my brain, I don't know.
Yeah, I think.
Was there
Go ahead.
comment or?
Representative Zager.
I was just going to say, I think it had been a legacy of forestry and logging are frequently together,
Yeah.
and we wanted to ensure the loggers were.
And they need to be.
Yeah.
Yeah,
Okay.
Thank you.
Senator, did you have a
No, I'm
comment?
fine.
Okay. So,
Are the other changes right before you move on?
yes,
The duties?
I don't see-
duties?
Okay.
Okay, so do I have a motion?
I'll make the motion about to pass as amended,
Removing,
removing the forestry sector So that would bring us back to the odd number, which I like an odd number in a membership. You have to break a tie. Yeah.
And a motion and a second, Representative Daigle. Any further discussion? All in favor?
Okay, I think you have the next one in front of you. I'll just give one to Sophie before I carry on.
2134.
Yeah. Okay, 2134. Oh, this is the pharmacies inside a grocery store. So I've just attached the original bill just so you can see it if you need it. You wanted an emergency preamble on this, and you wanted to make it clear that they couldn't move. So it now would say, line 336, would now say the pharmacy was established by lease agreement within the retail establishment at the same geographic location prior to July 7, 2025. I'm not sure that language is really needed, but it certainly doesn't hurt. So I think that was what you were looking for there. Everything else remains the same. It's really about the emergency.
Okay.
You had a question mark on.
No, after I copied that, I realized that I had copied my version that I had to go look up that word.
Oh, okay.
So I
you
should
were
have
okay
found a
with that.
clean one before
Okay.
I moved on.
No
Sorry about
problem.
that.
That's okay.
It was not a word I was familiar with at the public hearing.
Anybody with issues on adding an emergency preamble and clause and clarifying the geographic location issue? Seeing none. Okay.
Okay, the next one is 2125. This is the one around children's residential care services and the $1 million. I actually think this language is going to change in the process of going back and forth between revisers and fiscal and us, but the language itself doesn't change. But I think that non-lapsing language may well end up in the blippy. I've been going back and forth with the reviser's office today, but I think you can still see, we'll bring you the final version anyway, but this is how it went over to the reviser's office in the fiscal office. And the reviser's office is probably going to put the non-lapsing language instead of being its own section, because it was hard to kind of figure out quite where to put it, because it's language all by itself and it doesn't relate to anything else in the bill. So it was sort of tricky, but it will probably end up in the blippy, but you'll see it when it's final anyway.
Issues? No. Okay.
This one is final before it is pink. All these colors. Yeah. I'll just. Oh, is it not paper clipped together properly?
I think just that first
Just the
one.
top one?
Yeah.
Okay. So this one that's coming around is, I think this is Senator Inglison's bill on the child care employment award. So this is a majority and a minority. The majority is on the top. I think they're all paper clipped together, so they should come apart. The original bill is at the back so that you can see, actually, if you go to the back first, you can see there where section 1 and the 3 million are kept in both versions. So on the top, the majority report really is just the updated fiscal note in the lines 22 to 29. So that was the position. And that had to be changed because the fiscal note had it required an update. And then in the minority version, which is the one underneath, it strikes out the position altogether.
And it's got, oh yeah, perfect. That is in the back, there's all. Thanks. Yeah, it has the position. Thank you.
That's the difference between the majority and minority was the, okay.
Yeah, just the
Yep. Yep.
So LD 1955 is coming around. This is the Senate President's bill on the CCAP, basically.
Yep.
This was a complete strike and replace, so I didn't include the original bill. This is the bill that, if you remember, went to the governor's desk and came back from the governor's desk, and then you had another work session on it, and this is where you ended up. This is a majority report. It retains the piece about the long-term plan for the financial stability of the CCAP, the requirement that the funding is non-lapsing and requires 15 million in fiscal year 2026-27 to fund the program. And you'll see on the bottom of the page there, the Blippi has also been changed to say provides ongoing funding, because that was something you also did at the work session.
Okay.
Where's the ongoing piece?
It's the very last line.
Oh, at the end.
Actually, it's right at the front. If you go right to the front, Senator, the very last line.
Oh, thank you.
Yep. And then the last one, this is minority report. This is Representative Lemlin's amendment. This is shown as a markup just because that's the way I went back and forth with Representative Lemlin to clarify what he was looking for. So there are just a few changes here. Change everything, every date. It was a carryover bill, so every date has been moved forward by a year. On the 5th page, in the middle of the page, there was a requirement to submit a transition plan rather than a report that would come to the legislature. And then the other requirement that he was looking for was, and this is in a couple of different places, it's in the statutory language as well as the transition language, that a person who has held the position of commissioner or deputy commissioner in DHHS and also a director or associate director within OCFS that was hired between January 1st, 2019 and January 6th, 2027, which is the date in which the new governor would be inaugurated, go into office. Is that the same? I don't know. That they would be unable to be hired into this new department. So that is Representative Lemlin's amendment, and you will need to see it. It is a markup. Yes, we've already talked. This is a markup. You will see it when it is final. And then we have two more quick things. You'd like to go first?
Sure. So
I can take it.
as you'll recall, there is a process when a new public records exception is included in a bill that the committee is seeking to move forward, that the Judiciary Committee reviews that confidentiality provision. So the way that this works is we write a little memo to Judiciary talking about the exception, telling them why the exception should be there. And they will schedule a time for usually one of the chairs comes and talks to the committee and see if they have any questions about that proposed exception. So actually, both Anna and I have letters that are for our respective
There's two.
exceptions, and mine is for the 2108 an act to establish the Suicide Mortality Review Panel. And there's a confidentiality exception there for the records that are held by that panel and the interviews that that panel conducts. And so there's a set of questions that by statute, the Judiciary Committee is supposed to ponder over. So we have in our memos given them kind of our take on those questions. So
those are like a template questions
Yes,
usually
exactly.
that goes,
Yeah,
okay,
yeah.
gotcha.
so these memos are walking the committee through those.
Yeah. And the second one is similar, so as Sam said, it's triggered by the that piece of the law about public records exceptions. This is 2001. This is it's just one piece of it that matters. This is the one that requires, or at least a piece of it, requires that that records for licensing and inspection sanctions, I guess we'll do for now. Those records are currently confidential for licensing and investigation teams when they go to do their inspections. Part of that bill from the department, which they had gotten some advice from the OAG, was to require those records to remain confidential through the appeals period. It doesn't change
who those records go to in terms of the mandatory and required, mandatory and optional, I should say, mandatory and optional disclosures. It just holds those records which were already confidential for a longer period through the appeals process. That was a unanimous report. I don't believe you amended that section. There was an amendment, yeah, but it does have to go to the Judiciary Committee. I expect that somebody from the department will probably help you out with that, but they will want somebody from the committee as well. So I have those for you to sign.
Thank you.
And that's all.
That's all.
That's it?
That's all, folks. We can if you'd like.
I don't know. Schedule?
It'll be quick.
It'll be very quick because I think we've got AFA.
Do we
next
have
week.
a?
I
I
think we
think it's still
likely
in
do.
draft, but we sort of know.
Okay, good.
Yeah.
Because that was.
All right. So I entertain a motion to adjourn.
Do not have committee tomorrow.
You
We
do
do
not
not.
now
Tomorrow.
because
But-
you stayed.
I do too, so.
You don't have HHS.
That's right.